I'm very proud to have Dr. Lee with us. She's been with us since the beginning. She's the chair of the Department of Urology at The Ohio State University. We're not going to hold that against her. She did her undergraduate degree at Albany Medical School, residency at U of M, and fellowship at Memorial Sloan Kettering. She is really a true blue Michigander, but is living in the state of Ohio now. We're also proud to have Dr. Yahir Santiago-Lastra, who is in Puerto Rico on her way to her house in her car. She's the director of the UC San Diego Women's Health Pelvic Medicine Center, associate professor in the Department of Urology at UC San Diego School of Medicine. She did her med school in the University of Puerto Rico, residency at Harvard, and FPRMS fellowship at U of M, also a Wolverine. I'm going to have Dr. Lee start first, and this is meant to be a interactive process. Feel free to ask questions in the chat or by putting your hand up. Dr. Lee, please take the floor.
Okay, let's see if I can get all my sharing and everything together. Oh, wait a minute. Let's see.
We can see it.
Oh, you could see it?
Yep.
All right. Can you see that?
Yes.
Recording in
progress.
And is it in presentation mode?
No.
Okay, wait a minute. Let's see.
Oh, you mean with the
Is it in slide?
Perfect. It looks perfect. Yeah.
it looks perfect.
Oh,
Yeah.
okay.
Yeah. The
Let
notes.
me go one more time.
Yeah.
Two. Okay. Can you see that?
That looks good. Yep.
Okay, great. Well, first, I want to say good morning, and I want to thank Drs. Salami, Drs. Go, and Palapattu for the opportunity to speak with you today. The Michigan Urology Academy, I'd say, has been just a wonderful opportunity, to be able to have people gather together, talk about important issues, and begin to develop mentorship and sponsorship opportunities, and just learn more about urology. So it's really exciting to see so many people here. As I've shared, I've kind of lost my screen to see everybody. So I hope, again, if there's a problem, please let me know. Dr. Go, we're still good?
Still good.
Okay, great. So what I want to talk about today is sponsorship. You're going to hear more from Dr. Santiago-Lastra about mentorship, but sponsorship really is quite different. And although we talk about the two together, I think it's worth it to take a few minutes to really hit on a few key points. So what we're going to cover today is, just defining what is sponsorship and how is it different from mentorship, and why do we need sponsorship, and how would we identify a sponsor? And I think this is something that all of you are probably thinking about already, but maybe we can provide some tips. And after these two sessions, we can have some time for questions and answers. So what is sponsorship? To me, put plainly, it's when individuals are utilizing their power and influence to advocate for someone. Typically, it's someone more junior and someone who's rising in their career ranks. But certainly, those who are rising medical students are really looking at areas for sponsorship. And as your career progresses, the types of things you're looking to be sponsored for will change. Although mentorship is exceedingly important, and you're going to hear more about it, I would contend that many trainees and early career faculty are over-mentored and under-sponsored, meaning that this very active, intentional use of someone's personal influence is critical to ensure very, I would say, regular career progression. And it's not to say if you don't have a sponsor, you're not going to be able to achieve some success, but your success will be accelerated if you do have someone like that in your corner. I want to just comment on a study that was done that pulls out some important themes related to sponsorship. This is a study that was done several years ago in 2016 at Johns Hopkins that included semi-structured interviews with Johns Hopkins faculty. And what they did is they looked at, I think it was 12 faculty who were sponsoring more junior faculty, and then also interviewed those 13 junior faculty. And they talked quite a bit about career progression, success, mentorship, sponsorship. And these themes came out around sponsorship, these 5 themes. That mentorship is different from sponsorship. Sponsorship is episodic and focused on specific opportunities, as opposed to mentorship, which tends to be more of a continuous relationship. Another theme was that effective sponsors are career established and well-connected talent scouts. In other words, they tend to be more senior individuals with leadership roles. And again, they need to have the cachet and the experience and the positions to be able to sponsor a junior protege or a trainee or someone they're advocating for. I think another important theme, and we'll talk about this a little bit more later too, is that this is a reciprocal relationship. Effective trainees or proteges rise to the task and remain loyal. In other words, when given opportunities, they take advantage of opportunities and are able to be successful. And there is also, of course, a need to help your sponsor maintain their credibility, so your success is their success. Another theme was that trust, respect, and weighing risks are key to successful sponsorship relationships. So you need to respect the sponsor, their position, really, again, their credibility and reputation that they're putting on the line for you. And lastly, something that I think we'll hear multiple times is that sponsorship is critical to career advancement. Now, when I think about my own experiences related to sponsorship, I think back to a term that I heard many years ago that I've used in my career related to mentorship. And I've always said, well, I have a mentorship quilt, pulling many mentors together. But in truth, when I was a trainee at the University of Michigan, I had a sponsorship quilt as well. In other words, I had people from different aspects of the field doing different things to help me not only learn complex surgeries, not only give the credibility or provide the credibility and opportunities for me to become a good teacher, but also opportunities for research. Dr. Bart Grossman gave me a position in his laboratory when I was thinking about academic medicine. Dr. McGuire provided opportunities and encouragement for me to actually enter urology. Dr. Jim Monty gave me opportunities to do and learn complex surgeries and help facilitate a fellowship position at an elite institution. Dr. Bloom provided many sponsorship benefits for me in terms of important committees and influential societies. All of these things were important in my journey towards not only being a successful resident and then fellow, but then as a young faculty member, gaining the tools that I needed to be successful in promotion and gaining promotion and tenure. So how is sponsorship different than mentorship? First, you're going to hear later today about a number of important mentorship opportunities that are happening nationally. And I can't help but use this airtime as a moment to champion some of these things, because as I'm talking about sponsorship, I want to really emphasize how important mentorship is. And in thinking about Urology Unbound, which is an organization that was started by Dr. Shenelle Wilson, but also has had many people involved in it. Dr. Sam Washington, who you'll hear from later, Dr. Lamont Barlow, who's at NYU, Dr. Washington at UCSF, and Dr. Wilson is in a private practice group in Atlanta, working to ensure pipeline development, particularly for students who have historically been underrepresented in urology. So this kind of a pipeline program is so critical in attracting students to the field, but also helping to retain students within the field and develop their progression. Of course, there's also Uriter, a wonderful mentorship program started at UCSF and has been under the guise of Dr. Washington. Again, you'll hear more about this later. Again, really helping to support Black, Indigenous, and other students of color, as well as Latinx students, with a goal to help them be successful in gaining entrance to urology and then remaining in urology. So these kinds of programs are so important for mentorship, but they also set up relationships later for sponsorship, in that you get to know people, they get to know you, they get to know your work, and they can use their influence to connect you to others and to advocate for you in other committees and roles. So I want to talk just a little bit then about these relationships. Whereas a mentor is more of a senior or a peer who is instrumental in developing a skill set, a sponsor is an advocate who is providing influential and promotional support. Their goal is to help advance your career and provide you with the opportunities to do it. Now, we're not really talking about coaching much today, but this is another area that is critical. Mentorship is developing skills. It's going to help you gain knowledge. And this is going to be really important at this phase of your career. In coaching, we're really thinking about improving performance. And often it's around something very specific. And this kind of coaching is something that you should keep in the back of your mind. Again, we're not talking about it a lot today, but in the past, it used to be felt that coaching was really provided when people were underperforming. But actually what we've, I think, come to in 2023 is that coaching is a way for high-performing people to remain as high-performing and to continue to develop their specific skills. In sponsorship, we're talking about career development. And what is important there is having access to opportunities. And with those opportunities, that will drive career progression. This is a great little cartoon here that summarizes it. So when the character is talking about mentorship, she says, you know, have you tried applying to speak at conferences and meetups already? So this is what a mentorship might be suggesting to a mentee. A sponsor might say, I recommended you for this speaking gig. Can you do it? So this is the difference between you wanting to do something and being encouraged to do something versus you actually being given the opportunity. Now, yes, mentorship and sponsorship is different, but in truth, those roles aren't always mutually exclusive. And certainly mentors can be very valuable sponsors, especially if they're highly placed, you know, in whatever area or field you're involved in. And they obviously need to be well connected. So when you think about how a mentor could also serve as a sponsor, and the mentee can help encourage some of this, I want you to know that mentors can recommend you for opportunities, even early in your career. And this has probably happened to some of you already, as you think about being recommended for committees, being recommended to apply and attend programs like the Michigan Urology Academy, And certainly there are many other programs across the country. So these are early areas of sponsorship that your mentorship can be active in. Also connecting you with change agents. So even if they don't have the ability to sponsor you directly, they may be able to introduce you to others who can. And of course, nominating, mentors can nominate their mentees for awards. And that's important because oftentimes we think about these various awards in our field or in our institution. Many times very few people are actually applying. So it really just takes someone to step forward and to nominate candidates and really speak to their skills and and all of their expertise to have them potentially be competitive for an award. Inspiration and encouragement is important and a major part of mentorship, but also thinking about how to stretch. And a mentor can encourage you to, for example, apply for positions, apply for grants, apply for various awards that you may not have considered yourself eligible for. So these are some of the ways that, yes, there is some overlap between those who can be your mentors and your sponsors. Now, why do we need sponsorship? We don't have a lot of time to talk about it today, but I do want to highlight a couple of things, particularly for women and those who have historically been underrepresented in medicine. From the STEM fields, we know that sponsorship is important in helping to empower women. And I bring this up, obviously, because women are significantly underrepresented in the field of urology. But in STEM, when women have sponsors, their careers are improved. 22% are more likely to be satisfied with their rate of promotion, 37% more likely to actually ask for a raise at work, 70% more likely to have their ideas endorsed, over 100% more likely to have their ideas in an organization, and 200% more likely to actually have their work and their ideas actually implemented and operationalized. So I think there is evidence in many fields. The evidence in urology is growing. I'll point out some data actually from the University of Michigan that really speaks to the issue of experiences of sponsorship and how it may be different between men and women. And in this study, there was a survey that was delivered to recipients of K08 and K23 NIH awards. So these are very highly sought after awards. They're very difficult to achieve. And so to achieve one of these awards, you are really at the top of your field. So almost 1,000 of these award recipients responded to the survey. And here you're just seeing some of what the study looked at in terms of sponsorship and what actual sponsored activities the candidates received opportunities for and actually participated in. So you'll see that there were invitations to serve as an oral discussant or a panelist in the second group of bars. The third group of bars is looking at the invitations to serve on a national committee or a study section. The fourth group is looking at invitations to write an editorial, and the fifth group, invitations to serve on editorial boards. So these are all important career examples of career progression that will be important in considering promotion. The dark green bars are representing men with male mentors. The kind of aqua green are men with female mentors. The lighter green, women with male mentors, and the white bars, women with female mentors. And essentially you see that women with female mentors had the lowest utilization of these different opportunities. And this was statistically significant when compared to men with male mentors and men with female mentors. So we can talk a lot about why this data exists, but I think it does point out that experiences of of sponsorship are different by sex. And this is in a very highly expert pool of individuals. When we're thinking about those underrepresented in medicine, I just want to reflect on a recent study that was published out of UCLA that was surveyed a cross-sectional survey of UCLA medical students. But one of the things that came out of the survey was that students were more likely to report that having a mentor of the same race or ethnicity was extremely important to them. Now, that wasn't the specific goal of the survey, which was looking at mentorship experiences in students and the quality of that mentorship, their perceived quality. But I bring this up because if students are really looking for that kind of alignment with their mentorship, I suspect they're looking for that in terms of sponsors, but we know that there really is a dearth of underrepresented minorities in leadership roles in urology. So it can be very difficult to sometimes identify those sponsors. So we're going to have to be very strategic as we think about sponsors. And I reflect back on my own sponsors. Those individuals who may be deeply invested in you may look very differently than you do. Seeking sponsorship. In my last few slides, this is a book that actually, if you have time to read, would be great. This is written by an economist, not a physician, but she outlines some of what we would call a roadmap, a 7-step roadmap to identifying a sponsor. And you'll see these steps here. One, thinking about having your own personal vision, and I would say your own personal mission to understand what exactly you want to do. It's hard for someone to help you and sponsor you if you're not sure what you want to do. 2, thinking about scanning the horizon for potential mentors, sponsors. That includes your mentor. Because like I said, your mentor may be able to sponsor you in some ways, serve as a connector, or even allow you to, as part of a team, be sponsored. You know, I mentioned that as almost like a piggyback type of sponsorship, where you might be in a group that's excelling and doing great things, and that group may be sponsored to engage in various activities. Also, distributing your risk, and I'm going to come back to my sponsorship quilt, having multiple sponsors in and outside of your institution. Also, appreciating the reciprocal nature of the relationship, as we talked about before. You need to be successful and help your sponsor be successful. You're a reflection of them. And so striving for excellence is always important in whatever you're engaged in. As you are given these opportunities and excel, you will certainly have more. I also want you to think about developing and deploying your own currency. And for me, part of that is self-nomination. If you don't have someone that's there to nominate you for various things, it's okay for you to think about self-nominating, directly contacting individuals, talking about your expertise in currency, and trying to gain opportunity that way. And last of all, thinking about leaning in and leading with yes. So saying yes to your sponsor, not to everybody, but saying yes and really taking the opportunity to develop that relationship, show you can be successful, and be available for other opportunities that will come about. I also want to say that building skills and relationships through programs across the country that offer mentorship is a road to sponsorship. I'm going to just call out the Prospect program, which is a wonderful collaboration between the North Central section of the AUA and 4 institutions in the North Central section: Ohio State, Michigan, Cleveland Clinic, and Henry Ford. This is an 8-week summer program that offers research opportunities, but also opportunities to come together and ultimately develop the kind of mentorship you need that will guide you later into sponsorship opportunities. So just to conclude, sponsorship is a tool for professional advancement. It is different than mentorship, although certainly there can be some overlapping areas. I do think we have to be more strategic in developing strategies, particularly for women and for those underrepresented in medicine. So this is just a little bit of a whirlwind through sponsorship, but I hope we'll be able to answer some questions in a little bit. I will stop sharing and allow Dr. Santiago-Lastra to talk about mentorship, and then hopefully we'll have some time for questions.
All right, that was amazing. And as you will see, once I share my slides, I have included Dr. Lee in one of the people that contributed significantly to my learning as a future mentor. So I think it all kind of pays forward. So I'm very appreciative of her forward thinking in understanding that, as we'll discuss in my slides, mentorship is an exercise that you have to train for, and good mentors have practice and feedback, and often the best mentors have even had formal training. So I'm going to go ahead and share my screen. Can you guys hear me okay?
Yes.
Perfect. All right. Okay. Does that look okay? Not in presenter view?
Yes.
Beautiful, beautiful. So I'm very appreciative of the earlier introduction from Dr. Go and Dr. Salami. I definitely benefited from a lot of mentorship and a lot of sponsorship to get to where I am today. I've had fantastic mentors, I've had so-so mentors, and I've had really awful mentors, but I have learned something from each of those individuals. And what I hope to give you today is a bit of background into what to look for in mentors and what some potential red flags could be, why they're important. I think it is very true that we have a lot of mentorship programs that pop up at institutions, and most places have some sort of formal mentorship attempt in place. The hard truth about that, though, is that most mentors don't get formal training on how they can excel in this role. And there is a lot of data. Most of the data that we know about mentorship and about sponsorship actually comes from corporate America. And obviously they want to make money. They want their employees to be productive. They want their employees to be happy and to thrive, so that they can improve their organization's bottom line. And from a lot of that data, we know that poor mentoring can actually be worse than no mentoring at all. And I'll give some examples of that. And so even though there's very few opportunities to train mentors, there's more mentorship programs than there are opportunities for mentors to learn how to be good mentors. People who are fortunate enough or savvy enough to find the right mentors get more advancement opportunities. They tend to have higher salaries and higher satisfaction with their current employment, with their overall career or specialty, and also with their potential in life. And that can have to do with their life in work, can have to do with their personal life, their balance. And so finding those good mentors is important. And one big takeaway that I'll give you from the beginning is that no one mentor is going to satisfy it all for you. The same as you need more than just one sponsor. And I think the visual of the quilt or of the mentorship quilt or the sponsorship quilt is something you should definitely take with you and say, okay, let me start building my quilt. And that definitely will go beyond your medical school or your chosen specialty. You'll find mentors beyond that. So one example that I give, which is a critical example, is what's happening to women in medicine, and specifically Black women in medicine. What we're looking at in pipeline, and there are a lot of pipeline efforts that pop up. And one of the things that I really like about the Prospect program that Dr. Lee mentioned, as well as the longitudinal mentorship that Urology Unbound offers for students of color, is that it looks at the mentorship and the sponsorship over time. Qué lindo. And that's that's important because a lot of times we recruit people of color into medicine. We put them or set them up with mentorship programs that are temporary or perhaps short-sighted. And it leaves people lacking for significant mentorship that can really help them leverage their careers or look at careers that last and have longevity. At my institution at UCSD, a few years back, we noticed that, we're getting students excited about academic careers or about being physicians. We're graduating a lot of students of color, but when we look at our ability to retain faculty of color after the associate professor level, which is about mid-career when you're like in your first 10 years of practice, not quite learning, you're seasoned, but still with some challenges and things to learn, that's when we start losing people. And I think because there's no active mentorship that looks at those needs. So it's very critical to make sure that a mentor is the right mentor and that the mentee-mentor relationship is one that is symbiotic and that actually serves both individuals and their life experiences. So here we have Dr. Lee. I was very fortunate. When I was a fellow, there was an intentional program that was developed to help us as fellows learn how to be educators. And mentorship starts with education. And there are a lot of things that we learned there that are beyond the scope of these few minutes that I have to speak with you. But there's a few things that are really important about being a mentor. Active listening. So when you are listening to your mentee, getting a sense of their agenda. Bidirectional feedback, meaning when you sit down to give feedback to each other, it's bidirectional with opportunities for each of you to learn from the other person. It's not just the mentor giving the advice and the mentee soaking it in. There's reciprocity there. Mentors need to challenge their mentees. And so a mentor that's really supportive sounds really nice, but if you are not headed in the right direction or you're making decisions that come with potential pitfalls later, it's important for your mentor to challenge you and not to be afraid of disappointing you because they're giving you some difficult feedback. However, that has to come also with affirmation. So we need mentors that believe that their mentees can succeed. And the way that can sometimes be affected if mentors don't have the right training is that sometimes they put their biases or their lived experiences, which may be very different from their mentees, and they put them on that person. And when the lived experiences are different, there can be advice that's given or judgments that are being made that are not appropriate for the individual. And so you also want a mentor, obviously, that has integrity and knows the profession you're in and knows the institution that you're in. So they're not mentoring you through some things that maybe just won't fly at your institution, for example. And I think that really good mentors can also be sponsors. There's opportunity there, and they're advocates for their mentee if they need to be, and they put themselves in that position. But then let's also be real. So those things that we mentioned in the last slides are all things that we went through in that education course. How do you give feedback? How do you make sure that you're not putting your biases onto your mentee? But there's also some foundational virtues and abilities that you can't teach that are essential to a good mentor. So for example, a good mentor that comes from a similar background, a mentor that has high emotional intelligence, that has integrity, and has good judgment around boundaries and confidentiality. And then also a mentor that's interested in acting with the mentee's best interests at heart. And the reason that I mention that is because a lot of times, and this happens a lot to faculty of color or women faculty, they are tasked with mentoring a lot of students of color, a lot of residents of color. And sometimes, there can be one mentee too many, and you're spread thin, and you're not as good of a mentor to each of those individuals as you can be. And so you may not be acting with your mentee's best interest at heart because you're just, spread thin, or you may not be interested in being a mentor. So that's why I want to give you all tools today to be able to identify what mentorship relationships are going to serve you and which ones may be challenging, but yet are worth investing in. And I have here Serena Williams and her dad, definitely a mentor that was 100% invested in his mentee's best interests, was her father. And he really believed that she had a talent that the world needed to see and that would lead her to great success. And he was right. Throughout the process of teaching her, he did not have formal training and he made a lot of mistakes. For those of you that watched King Richard, you can kind of see it play out in that biopic. But one of the things that they'd had about their relationship that was really good was that it was bidirectional. That bidirectionality was sometimes screaming and crying and tears, but that existed. And so with that, I highlight that most of the mentor-mentee relationships are going to have some flaws. And so you have to channel your inner wisdom to determine what will serve you and what will not. So let's go over some of those things. Let's go over some mentor archetypes that seem awesome, but they really are not awesome. So for example, mentors who withhold valuable information, and this isn't meant to be like, sinister. Sometimes people withhold valuable information because they're distracted and they have low, they don't have the bandwidth. There's also absentee mentors who check in with you and then they disappear for a year and you can't reach them. And so they don't really get to help you because they're just not around. There are mentors that think, okay, I'm going to mentor you, do this project, and then let's talk when you finish this project and I'll write you a letter of recommendation. And they have a template in their mind that you're going to fulfill. And so it's hard to kind of point them in the right direction as to what the expertise you want them to share with you. And there's the don't outshine the master mentor, which is the mentor where you're great and you're sponsored as long as you do not exceed or outshine them. And that is also something, that you have to be aware of as you get more advanced in your career and have some wisdom. So let's look at some archetypes just for fun and to kind of understand. So there's Glinda the Good Witch. Everyone would say, this is one of the best main characters in all of film history. But I would say this is a woman who literally the entire movie knew that Dorothy was struggling, and knew how she needed to get to the end, literally withheld very critical information from her through every step of the way, instead of giving her structured feedback on how she could get back to Kansas. And so we don't want to go down the yellow brick road with our mentors. We want mentors that can lay out the path for us and can be transparent about what the expectations are. We don't want them necessarily to deflate our spirits, but we also don't want to be kind of wondering where things are going every step of the way. So we want to have mentors that have that ability to give us information and to outline things for us. And this is really common with mentors who you depend on to think about career paths, like applying to urology or developing a research project or figuring out what career path you want to take as far as like academics, private practice. You want to make sure that you see kind of how things are outlined and what the master plan might be for what they're trying to mentor you for. And there are some ways, which we'll go over in a little bit, that you can be proactive and help them map that out for you. And so then there's Dumbledore, the absentee mentor. They're amazing. I mean, nobody is going to question that this man was the absolute most brilliant wizard in all of the wizarding world, but they're never around. And sadly, I've been this type of mentor many times. And sadly, not with the amazing wizarding capabilities of Dumbledore, but definitely with the absenteeism. And that is something that I've learned to avoid as I've learned to be a better mentor, is to say, let's first sit down and talk with each other and get to know each other and see how we might best work together. And I always talk about a collaboration. And that allows me to understand what the mentee's goals are. A lot of times students want to just connect with another female urologist or another Latina urologist. That happens a lot, but they don't really have, like a set plan. They just like, I just want you to mentor me. I just want you to be a person that I can talk to. And that's great. But there's a lot more that you can get out of your mentorship relationships than just like someone, especially if your mentors have very little bandwidth. Having like a structured agenda can help you. And I'll give you some slides where you can kind of have a stepwise. And so there may be those of you right now that are triggered. Maybe Mr. Miyagi is before your time. Maybe he's one of the best characters in all of, film history. Definitely an excellent teacher, had an unorthodox style, but this man legit had this kid. He was like defending this kid with martial arts, attacking his bullies, like seeing that he was like getting tortured. And not once did he think to like tell the authorities or talk to the school principal or like talk to the kid's mom. So you definitely want to have a mentor where if you are experiencing moments of harm or there is something that is happening that is outside of what the institutional norms are, that this person is going to have the integrity to support you and to navigate those processes. And this is sometimes what happens in mentorship relationships where a very strong friendship is formed. And then your mentor becomes more of a friend than an actual mentor. And you definitely, the mentor-mentee relationship is a relationship that has power differentials in it. So you definitely want to be aware that those power differentials come into play. And we see that time and again in allegations of misconduct or abuse on behalf of like mentees towards mentors towards their mentees. And that's not a mentorship relationship that anyone wants to be in. Not saying that Mr. Miyagi is an abuser, but definitely had he gotten some formal mentorship training, he might have, instead of going to just train this kid to fight, he might have also, made sure the parents were aware that, he was experiencing bullying at school, which is like a very serious thing. All right. And then we have Miranda Presley, the highly, highly successful mentor who doesn't realize and I skipped something there. They don't realize their lived experience is different. So the mentee has a different lived experience and approach. And this happens a lot when faculty mentor underrepresented students or students who come from backgrounds that are not the same as their own backgrounds. There can be highly dangerous advice that is dispensed here, and there can be a lot of harm, and there has been harmed. There have been mentees that are harmed. So it's really important, especially when you are being mentored by someone who doesn't have your same lived experience. They may be mentoring you to do things that that may not apply to you. And so if we had, my pie in the sky goal where every mentor that took on a student or that took on a mentee had, some opportunity for feedback and formal training, they would know that there are implicit biases at play and that not everything that applied to you will work for someone else. I'll give you an example. I recently had the opportunity to mentor a young resident who was starting to navigate the process of motherhood. And she wanted to advocate for herself for the time she felt was necessary for her maternity leave. And I did the same thing when I was a resident. But the way that I navigated that was definitely more upfront, was definitely, I self-advocated a lot more. And because of this particular young woman's lived experience, that was not something that was going to work for her, because she had lived through experiences where that had been weaponized against her. And for me, that, I navigated the world a little differently. And so if I had tried to put upon her doing things as I had done them, I might have put her in a situation where she was actually targeted or even disciplined for doing things the way I had done them. And I had to have the understanding that everyone has different experiences and approaches to the world. And just because I was successful doing something a certain way does not mean that my mentees are going to be successful. So we can discuss, play it out, troubleshoot what approaches we might take. But ultimately, again, it's bidirectional. And you want to have a mentor who's going to understand that and is going to be able to think outside the box a little bit, outside of what works for them and about what the standard has been. Because remember, medicine was built for cisgendered white men, and that was the standard and has been the standard. And we are now starting to try to make that change. But the framework of what was successful for Dr. Halstead is not going to be successful for me, and may not be successful for many of you. So these are some key areas for you to think about that might be useful, or in which a mentor is very essential for leadership development, as you're transitioning or inducting yourself into your own specialty. The corporate world calls this onboarding, but for you guys, when you start your residency and you start learning a lot about surgery, taking care of patients on the floor, how to be a good resident, then you start to have maybe some near peer mentors, maybe your senior residents, maybe your chief residents, maybe a fellow, maybe an attending, who are going to start to form your style of how you navigate this space. And so identifying mentors there is very important. Practice development. What type of surgeon are you going to be? Are you going to be a urologist who practices in academia? Are you going to be in private practice? There's also mentors to help you navigate urology if you are a woman or you're underrepresented. There are mentors for, let's say you're going to take on a role of associate professor, or you're about to become a department chair. You definitely need a mentor there, and probably Dr. Lee can talk about that. I had, like I mentioned, the fortune of having Dr. Lee mentor me through how to teach others and how to teach that effectively. And I always tell her that I simply followed that mentorship approach that she provided me with during my fellowship years. And right out the bat, when I became faculty, I won the teaching award. And it was not an innate quality that I had, but that I had been taught something by someone else. I had a great mentor there. And then, as we discussed, maternity, paternity planning is a big one too. And there's ways beyond this. You can have a mentor in every which way, and they don't have to be urologists. You will identify mentors everywhere. My kid has mentored me through things. So, think outside the box there. And so where do you begin as far as developing a mentorship experience? The first takeaway that I want you all to take with you is that the person that's in the driver's seat of a mentorship relationship is actually the mentee. That should be the person that's driving this. You identify your mentor. Maybe one is assigned to you, and maybe that mentorship relationship works, but usually your assigned mentor is not going to be your only mentor. So think about what you want to achieve from a mentor. Maybe you just want to get to know them first and develop that along the way, but have a plan. And that is attractive as a mentee. Take ownership for what you want to get out of that relationship. You may say, oh, I want to reach out to Dr. Lee on Twitter because she's a Black woman that has achieved being chair of urology. She needs to mentor me. That is so aspirational. I'm going to direct message her on Twitter. And that's great. But assess your current network too. You may have some really great faculty in your own network that you can also gain access to for leadership and mentorship, outside of that. Don't get stuck in the ideal. So you may have a vision of what your ideal mentor is, but again, some people think I'm a great mentor. Some people probably are like, who is she? She disappeared for a year and I could never reach her. sadly. I'm trying to never do that, but definitely have been a culprit of that. Speak to your program director, your chairperson, your senior residents, your fellow students to try to identify them. And then if you're trying to, determine if someone can be a mentor, begin the process informally. And then once you determine you want someone to mentor you for something specifically, ask them, state that objective so they're aware. Oh, I'd like for you to mentor me on how I can be a successful urogynecologist in private practice, and just be specific, and then they know what the ask is. And then be proactive and commit to that relationship once it's there, so that if they ask things of you or they recommend things to you, you can give them feedback on where you went with that. A great mentee. These are some qualities of some of my great mentees, and I have had so many amazing mentees. I'd say, I learn everything from all of my mentees, but there are just some people that are always prepared when we meet. They ask excellent questions, like they prepared. They act on their action plans, and I don't have to remember or even sometimes keep notes. They ask for feedback regularly. I have residents who I'm prepared to use my model for feedback, and they ask for it themselves, and it's amazing. They're in the driver's seat. They're aware that I'm not their therapist, and the reason I say that is because sometimes residency is hard. I have a therapist, and my therapist counsels me on deep things that I need to seek a professional help for. So I know my mentors are not my therapists, but you do sit and talk to them about personal things many times, and that's okay. A great mentee is also very enthusiastic, and they're self-aware, and they appreciate our time. It's always nice to feel appreciated. I also observe that great mentees check in with me to see, how busy am I? How is my bandwidth for a meeting, for a touch point? They have a focus when we meet, so the agenda stays on time. They review actions we've taken from previous meetings, and they update me. If they're having challenges with something, they don't stay silent on it. They say, hey, I'm having a lot of trouble with this REDCap database you told me to set up because I wasn't clear on the instructions. And they tell me that early so that we don't, months don't pass by without knowing. They help create the plan. They send me reminders to help me stay on task. That may just be individually for me. You may have mentors that stay on task and are very organized. I need 3 text messages, an email, a phone call. And I love when my mentees also make sure to get on calendar for our next meeting, or we have standing meetings so that we continue projects, we continue mentorship, and things don't fall through the cracks. As far as mentorship opportunities, similarly to Dr. Lee, I wanted to make note of the integrative summer research program in urology. Similar to the Prospect program, this is a program that's been happening for 2 years. It's also in the Prospect model. We have students that come do some mentored summer research. It's specifically for students that are in medical schools that do not have a home urology residency, so that we can give them that exposure to mentors and to research and to opportunities, because we are always looking for more great and eager urologists. And finally, all of you are going to be mentors. Pass on what you've learned, like Yoda said. Amazing mentor. Strength, mastery, what you did well is important, but your failures are also important too, because failure is the best teacher. This is my email address. If any of you want to email, have a conversation, ask more questions, appreciate your time, and especially since we went a little overtime, and open to questions from whoever may have them.
Well, thank you very much. Those amazing talks for both of you. I think for us to keep on track, we are going to have to forego questions. And if people want to put it in the chat or email us directly, we will get the answers to your questions. So I'm going to go ahead and get folks ready for the next session. So now we are going to go ahead into the breakout sessions. We are going to run over a little bit, so we'll probably shorten the lunch break. And I'm just going to look for any burning questions in the chat before we go. So those of you, we have the breakout rooms open. Is it open, Simpa?
Yes, they are.
Okay. Go ahead and move yourselves to the breakout rooms.
So groups, group A, that's M1 and M2. So just move yourself to that breakout room. And then group B, M3 to M4, move yourself to that breakout room. And then subsequent instructions will be provided in subgroup B.
Do I need to go to a breakout room or just stay here?
You go to group B.
Yep.
Yes.
Let's see, join. I don't seem to be moving.
I can try to move you.
Okay, let's try one more time. I
So
hit okay, I found it. It worked.
Okay, perfect.
Okay.
So it looks like some people joined the subgroups, so I'm moving them to the big groups.
Okay.
To group B. So
Are you able to move the two that are stuck? There's two options.
so M4, I will. All right, so group B. All right.
There's one more.
Or like to find her name on the last. Sarah, you there? For whatever reason, when I go to the breakout rooms,
Yeah.
also I can see her name listed in the unassigned.
Yeah, I don't see it there. I see somebody else's name, but that person's not here.
Yeah. Sarah, are you there? Okay. There's some folks in the subgroups that I want to make sure I move them to.
Okay. I'm going to go into Priyanka's group.
That sounds good. And then I'll join Dr. Perry shortly.
That's quite a bit different for, say, emergency medicine physician. An emergency medicine physician or a family practice doctor, internal medicine doctor, who patient comes in the door and it could be anything from a broken leg to lymphoma to a psychiatric disorder to cancer, who knows? So do you feel comfortable knowing a lot about a little or a little about a lot? I like to know a lot about a little. So a lot of the uncertainty with regards to patient stuff, I find a little bit challenging. Again, this is all about self-reflection, insight into yourself and what makes you comfortable and in an area to really be your best self. Feelings. This is something I think is really important. And it has to do with how you feel on certain rotations. On the rotations that you're on, for example, if you pick one in your mind, how did you feel when you're on the rotation? Feel happy, sad, energized, tired in a bad way, or tired in a good way? Or you on the rotation thinking to yourself, man, I can't wait to go home, or what am I going to do this weekend, or what am I going to have for dinner tonight? Or were you thinking, man, time just flew by and this is really interesting, and you felt compelled and interested to explore what was happening tomorrow? Did you get up before the alarm clock in the mornings, or did you loathe kind of going to work every day? In some sense, of course, how you feel in rotation is governed by your microenvironment, the team you're working with, but also I think health has a lot to do with the topic and the content and the patient interaction and the actual daily work. So think about how you're feeling on a given rotation. Birds of a feather. I do think this is definitely true, and this is not anything to do with like gender or athletes do orthopedic surgery, or you can pick your stereotype for a pathologist or something, but it is, or a urologist even for that matter. But I do think there's something said about how individuals with a given field think about health, think about wellness in their patients, think about illness, and think about their role in that, right? So not all orthopedic surgeons have to be former athletes for sure, but they all like fixing problems very clear, and I think in a distinct way. They like typically operating on well people. They typically, if they're operating on sick people, they don't like taking care of those patients afterwards. It's not a valid judgment, it's a fact. Contrast that to, say, an ICU physician who is all into the very sick people. They like the complexity. So think to yourself, do you approach clinical problems, surgical topics, issues in a similar way to people in that field? And I think, again, you might kind of find your people in terms of how they view sickness, patient sickness, that is, and their role in patient wellness. What is hot now? This is another thing that's often overlooked, I think, by students. And I would say is go to the journal of whatever topic you're interested in, say Journal of Urology, the Global Journal of European Urology. Go to the AUA, American Urological Association National Meeting that just happened. Look at the plenary talks. The plenary talks are for the AUA National Meeting, or the talks are given to thousands of people. This is what we in the field think is hot now. Go to the Journal of Urology and just look at the table of contents, or the Journal of Ophthalmology or Neurosurgery. Look at the table of contents and read the titles. Do the titles, don't have to read the papers, don't even have to read the abstracts. Do the titles seem interesting? Do you feel, is your interest piqued by what they're talking about? Recognize that what experts are putting in the journals and at plenary sessions at national meetings are what we in the field believe is interesting. If you don't feel what we believe in the field is interesting, that might be telling you something. Further, what we believe is hot now and potentially controversial will become commonplace in 10 years, 5 to 10 years, what you in practice will be doing. So again, think to yourself, you don't have to fully understand these topics. The key is really, do you feel interested? Do you feel compelled to kind of explore it further? Daydreaming. So another thing to think about is like, what do you do when you're sitting around doing nothing before you go to sleep, when your mind is wandering, or when you're exercising, running, or doing something mindless and your mind is allowed to wander and you're thinking about things that are clinically oriented or medically oriented? What do you think about? Do you think about helping a patient, seeing them in the emergency room? Do you think about all eyes on me in the operating room right here, right now, attacking some sort of complicated problem with your hands? Do you think about comforting a patient and their loved ones after delivering some difficult news? Do you think you'll think about diagnostic dilemmas? So I think your mind tends to gravitate towards the things that you like, and just be mindful of what those things kind of are. And again, it really kind of helps shape your thinking about what kinds of fields might be right for you. Egoism. This is, I think, an interesting one. Surgeons, of course, are very egotistical. That goes without saying, right? Because what we do, we know, and we might not say it, we are directly responsible for. Right? Think about it this way. I could take all 15 of you today, show you how to write a chemotherapy order. We could all enter it in our Epic My Chart today, and a patient tomorrow getting all 15 chemotherapy orders will get exactly the same care, because I'll show you exactly how to do that. I could today also show you all how to do a robotic prostatectomy for about 4 hours on video, and then tomorrow all of us do one. Everyone's not going to have the same outcome, right? There's something very artisanal, there's something very personal, there's something very egotistical about what surgeons do. And while we may not say it, we feel it. How do you feel about that? How do you feel about having the responsibility of someone's life in your hands, where something good can happen and something bad can too? All of us who operate have complications. How do you feel about that? Some of us feel very uncomfortable by that. I think it's important to put yourself in a place where you feel comfortable. To some degree, there's a level of discomfort, of course, to grow. But if you find you don't thrive, or you find really a lot of anxiety with having to make a decision in a second or two that could either save someone's life or not, how do you feel about that? And I think that's something that only you can answer for yourself. And puzzles and people, lastly. This is just a broad generalization, but some people are puzzlers, right? They like the wordles, they like crosswords and word finds and Sudoku. Puzzlers in general tend to like things like pathology, radiology, these diagnostic fields, because it's somewhat like a medical puzzle. And the process is very similar. Are you a people person? Do you like interacting with people, engaging with people, getting to know their stories, sharing yours, listening to others, more than not? And I think there's some fields that are very conducive to things like that. So, for example, internal medicine, pediatrics, family medicine, very much are people kinds of fields. There's some fields that are sort of a combination of both of these as well. So, I mean, you can imagine emergency medicine physicians don't have a clinic and they don't want one. Anesthesiologists typically don't have a clinic unless they do pain and they don't want one. Do you want a clinic? Do you like to get to know patients over time and see how they do and progress? All of this, I think, kind of contributes to personal fulfillment, job satisfaction, and ultimately resonance into what makes you who you are. And I would say will contribute to making a successful you as a clinician, whatever field that you choose to go into. And that is all I got to say. And I'm going to stop sharing and wanted to hear any questions or thoughts, or maybe Laura and or Dr. Go might have some other things to say, but we have some time for questions, I believe. Dr. Go or no?
Yes, you're good.
Good. Thoughts from anyone about that kind of reflection? I will pick on you if you don't ask questions.
I have a question. That's okay.
Yes, sir.
Yes. Good morning. Thank you for your presentation. I just had a quick question. When you were going through the process of picking a specialty, what made urology special for you?
It's a very good question, Javier. Sorry.
Hobby's fine. No worries. Everybody calls me hobby too.
So I will tell you, I am at the time when I was in your stage, I went into urology because it could take care of old people and young people, men and women, adults and children. There was a surgical component, there was a non-surgical component. And the surgeries at that time were both microscopic, endoscopic, and open. Laparoscopic and robotic surgery hadn't really been popularized just yet. The robot hadn't been invented yet. We did cancer and non-cancer. And a lot of the cancers that we did, we help people. It sounds strange, but we help people. And further, the benign conditions, you make someone pee who can't pee, they're your best friend. You make someone who's leaking all the time stop leaking, they're your best friend. You take away stone pain from someone, they're your best friend, which is extraordinarily painful, as you can imagine. All those things were extraordinarily gratifying to me. But if I were to tell you now, 30 years later, why I went into urology, Javier, it's because people were nice to me. That's the reason. I wanted to go cardiac surgery as a student. They just beat it out of me. I went to Baylor College of Medicine, and they were, at that time in the 90s, it is what it was. Dr. DeBakey was there. His whole team was there. I did 2 months rotations with them. Man, they just beat it out of me. A neurosurgery, similar kind of experience. I found the patient material challenging. They go home and cry because of all the stuff that we did. And it didn't bother the neurosurgeons. But, taking out a GBM in someone, have you ever seen them do that? It's like pulling pork. And patients are not going to do well. And they often looked worse post-op than they did pre-op. And you thought to myself, what did I just do? Did we help anybody? Anyway, but then ultimately got interested in urology, and I was inspired and sponsored and mentored by Peter Scardino, former chair of urology at Baylor, who was in a Memorial Sloan Kettering chair of surgery, who was, for me as a medical student, the most influential person I interacted with. Long-winded answer, but I hope that answered it for you. Other questions?
I have a quick question.
Oh, okay. Talmadge. Yes, sir.
Hello. I just wanted to ask you, in your opinion, how does urology match in the puzzlers versus people balance?
I think a good question. Actually, no one's ever asked me that. I think it's a combination of both. It's as you know, it's one of those surgical subspecialties like otolaryngology, where there's a good combination of procedures as well as non-procedures. We certainly do follow our patients. We certainly do follow them longitudinally. We don't sort of treat them and street them, part of the expression, but some fields are like that. We're not just technicians and are done with our patients when we're done operating on them. So I think there's a good combination of both. Of course, there's outliers in every field, but I think in general, my sense is that urologists like people, but they like puzzles too. They love technology, right? And they like employing technology and tools to help people. So I'd say it's a combination of both.
Thank you.
Great. Let's go ahead and have Dr. Gupta speak, who is also a puzzler and a people person.
A very good puzzler.
All right. Good morning, everyone. So I'm Priyanka Gupta, for those of you I haven't met, and I'm the program director here at Michigan. And I'm going to share my screen here. And I just put together a few slides to kind of help guide our discussion here. And everyone can see that okay? Great. All right. And so I tried to frame this around talking about things you can do in your M1 and M2 year that will be helpful for you in setting yourself up for urology or other surgical specialties. I think all of these things we're going to talk about today are not necessarily specific just to urology, but I think you can use them for sort of all different areas. And then we also have Laura Zabib with us. She's a rising M4 who's applying to urology, and I'm going to have Laura also chime in on things, and then certainly we can take, and what I think I'd like to do is maybe take questions at each one of these sections if you have them. So
Priyanka, your slides need to be in presenter mode.
Oh, are they not?
I just see the next slide in your notes. There, not yet. One more time.
Did that work?
Nope.
No. Why is it not? I clicked presenter mode.
I think you want to be in present.
Oh, I think I have to swap it. Is that better?
Yes.
Okay, great. That's why I have to swap screens. Okay, perfect. So let's start by talking about rotations and shadowing first. So I think it is really important to start shadowing early. Depending on how your medical school is set up, you may or may not have clinical experiences. I think a lot of medical schools have moved towards having early rotations. But I think if you are thinking about a field like urology, which we know is an early match, we know it's competitive, I think it's good to get exposure early and decide, is this for me or not? So if there are things you are thinking about, I encourage people to really go do a rotation, or if you don't do rotations, see if you can shadow someone. I will say that when I was a M1, one of the people who's on faculty at Michigan now, Dr. Kristen Krauser, I actually happened to shadow her as an M1 in urology. And she handed me the scalpel and let me make part of the skin incision that day. And I to this day remember walking out of that OR saying, that was the coolest experience I've ever had. And then she and I ended up having a long talk about urology and international work. And, there was things she was doing that I was very interested in. And that kind of one early exposure was what started my whole interest in urology. So I say that because you just never know what that one experience might be like for you. If you don't have a home program, so I know that's an issue for some people, then I would suggest looking at whether there's an experience nearby in a community hospital or another program where you could even spend a few days. And you might find that you can start a relationship with someone there that might lead to other, rotations or clinical experiences for you in the future. So I'm going to stop there for a second. Do people have questions about rotations? And Laura, do you want to chime in about this at all?
Yeah, I would say one thing is see clinic and then also see the OR, because urology is both. And typically as a med student, you get to do more in a clinic. And to Dr. Palapattu's point about people were nice, also as a med student, you tend to go into things where you're allowed to do more autonomy, more engagement. So clinic is a great place to shadow as well.
Mm-hmm.
I have a question.
Yeah,
That's
great.
okay.
Yes, please. Let's
Yes.
some questions about this.
Yeah, so what about, for a school, for example, that does not have a home urology program, let's just say by chance when we're third years, there isn't a urology rotation or an elective or something like that. What would you recommend if that was the case?
Yeah, so I think I would certainly try to do some surgery rotations, right, and get exposed to some of the surgical specialties. But then I would see if there's a way you could set up an elective rotation at a community hospital, maybe if there's that opportunity, or to see if you could apply early for a rotation at another location. Those would be the things I would start looking, and I would start looking into that early, right? Because that way you'll maximize your chances of having opportunities.
Got it. Thank you.
Yeah. The other thing I would say too is, and we're going to talk about this in another slide, but there are opportunities through organizations you know, the AUA and then some of the sectional meetings and stuff too, where you can get opportunities to attend like the American Urologic Association meeting or attend a sectional meeting as a medical student. So if you don't have a home program, those might be some other good opportunities to get some exposure as well. And then Laura, I don't know if you want to provide some thoughts also when you're thinking about your schedule, what your thoughts were about how early to schedule like your surgery rotation versus other rotations.
Yeah, I actually did mine quite early on. Some people say you should like save the one you want to do for last so you can really shine. I think that like as the year goes on, people's expectations get higher. So it kind of ends up being the same. The data is very clear that it doesn't matter when you do your surgery rotation. And I wanted to know early on if I wanted to do urology. So I had time to make the investment. So I think early exposure, if you have to do it to where you save it to the end, it's not a big deal. As long as you're setting up experiences like shadowing, so you know what you want to do before you finish your M3 year.
Yeah, and I did the same thing as you, Laura. I did an early urology rotation. I think I did it very much at the beginning of my third year, just because I wanted to know for sure if this is what I wanted to do, because if not, then I was going to have to change course. So I do think that there is some value to doing it early if you're undecided. I think if you're 100% sure and you're like, I know this is what I want to do, then maybe doing it later is fine if you really want to get some more experience and really shine on the rotation. But I think it's helpful to think about, you know, where you're at in your decision-making process. Okay, any other questions? Anything in the chat? Sorry, I can't see the chat. So if anyone has any. Oh, okay, so the next thing yeah, okay, great. So the next thing I wanted to talk about was skills acquisition. So I think that if you are thinking about surgery, any surgical specialty, I think it's a good idea as an M1 and M2 to start acquiring some basic surgical skills. So start learning how to knot tie, start with 2-hand ties, then 1-hand tying. I remember I used to walk around with suture tied on my scrubs and I would practice tying knots. You know, I think starting to get some basic skills is helpful because again, if you want to do more in the operating room, if you walk in and you already know how to tie a knot and you have, you know, some experience with handling instruments, we're going to let you do more. And then I think that just overall lends to everyone having a better experience, your engagement. So, you know, I think learning how to handle instruments, thinking about basic suturing, these are things you can do at home. You know, you can get kits from your medical school. If you're in the operating room, you can always ask the scrubs if there's extra suture that didn't get used that was open during the case, and they can give that to you. I mean, otherwise it just gets thrown away. So, you know, take that suture home, you know, practice with it, get a needle. And I think the things to focus on as an M1 and M2 are just basic knot tying and suturing, like suturing skin. Don't worry about anything more advanced than that. I think just start with those basic skills, and that's a good place to kind of get a foundation. Any questions about that? Do you all have at your schools opportunities to start learning some of those skills early on or not really? I see some nods, maybe somewhat. Okay. There's also, you know, you can also look, there's certainly lots of tutorials online too, you know, if that's something that you're having trouble getting access to. And then if you are in the operating room, you could always have a resident just ask them like, hey, can you just show me how to do a 2-hand tie, 2-hand knot? And they can show you, you know, and probably like 10 minutes, and then you can go practice, you know? So those are things to do too. You can always just ask, hey, can you show me this? All right. I also would say orange peels are a good thing to practice on at home. That's an easy thing. If you can't get access to other types of suturing things. So I don't know if there's anything else you use, Laura.
I just put in the chat, there's like some really affordable kits on Amazon, and it'll come with the needle driver, the scissors, everything that you need. So you can just practice those hand motions.
Yeah, I used, I know I remember having a lot of dental floss that I used to use also to practice knot tying. That's an easy one too. So, okay. Great. So then I think research. So this is something that I think you should start thinking about early during your M1 and M2 year. So I would tell you any kind of project, right? It does not have to be urology. So again, going back to your question, Javier, about home programs, if you don't have a home urology program, that's fine. Do research on something else, right? What we want to see is we want programs are looking to see your engagement in a project. Okay, it doesn't matter what it is. I think quality over quantity is really important. If I see someone has been involved in 20 projects, but none of them have led to an abstract or a paper or a completion, they're just, their name on there, that doesn't mean as much to me as someone who's done one quality project that you can tell they've invested time in the research process and they've gone through it. They've been a substantial member of the team. They've been part of it. They've actually seen the project through. They've thought about, and they've got some things that they're working on. So I think when you think about research, this is really important. And try to find projects that are doable in the period of time that you have. So I think one of the kind of common pitfalls people fall into is, you have this great idea, you talk with a mentor and they say, oh gosh, this seems like a great project, but you're starting from scratch. You have to do the IRB, you have to then figure out how to get the data. Like most medical students don't have time to do all of that unless you have a dedicated research time, and that might require several months. So ideally, it's good to try to find a project that is kind of already on its way, where there's maybe an IRB started already, there's already a data set that you can look at. Other things that are really good for medical students are if there are review projects that you can get involved with, like writing a review article on a topic. That's a great project to do. Usually leads to a pretty quick publication, and that's something that doesn't require you to go through patient charts or data or things like that. It just requires a literature search and trying to really understand, the topic. So I think those are all things to think about with research. I'll let Laura, do you want to comment on any of that?
Yeah, I think the biggest mistake that we try to help, so we help our university students here get set up with research. The biggest pitfall we try to make sure they don't make is don't get involved in a project just because somebody's famous and you want a letter from there. You really want to do a project that you care about. You really care about the topic. You're interested. I'm not a basic science person. I shouldn't be doing basic science research. I do public health research. And that is why I'm successful in that area, because it's what I genuinely like to do.
Laura, can you maybe comment on because you've done a lot of great projects, and maybe you could comment on one of the projects that maybe you started early on in medical school and how you kind of found that and got through the process?
Yeah, so what I did is when I started to explore urology, at the time, Dr. Kraft was the PD, I met with her and I just put my name out there and said, I have done qualitative research before and I've done public health research. I'm looking for things that I can get involved in. And right away, she said, you should meet Dr. Whitman. Dr. Whitman who's now retired, was a qualitative researcher here. And she got me set up with a project that I started. And then over time, the projects kind of start to present themselves. So you'll meet somebody, Dr. Go and I met, we started doing research together. I met somebody else, we started doing research together. And the longer you're in it and the more people as projects finish, other ones will come up. So another piece of advice is tell people that you're interested in urology. So I was on my IM rotation. The IM faculty member was interested in QI. And I said, oh, I'm really interested in QI. And he goes, oh, if you're interested in QI and you're interested in urology, you should meet Dr. Krauser. And that's how I met Dr. Krauser. So really being open to opportunities and telling people that you're interested, and people will try to connect you to people that they know. And also opportunities will start to just pop up as you get more involved in the departments.
Yeah. And I think, Laura, one thing that made you really successful, and I put follow through on the slide, but I think that it is really important as a medical student. So, I know it may seem like you're being annoying, but you're not being annoying if you send multiple emails to follow up, because most of us, and, I think Dr. Santiago commented on this a little bit in her talk too, is that, sometimes people get busy and they may not respond to you right away, or they're not following all the timelines that you have, right? So I think the students who are successful are the ones who, they email back and they're like, hey, I haven't heard from you. This is where I'm at with the project. Let's set up a meeting. Now with Zoom, I think it's really easy to get on people's schedules. If you know someone's administrative assistant, just put yourself on their schedule, email the administrative assistant, get 20 minutes on their schedule. That way you can make sure your project goes forward and moves forward. I I think having regular check-ins with your research mentor is important. So depending on the length of your project, decide maybe at the beginning, set the expectation, how often would you like to meet? How often do you think we should meet to go over this project? And set up those times and make sure you keep those appointments. I think when you come to those meetings, if you have a deliverable that you need to have done, really important to have that done, right? So get your portion of it done so that the faculty can help move things forward. And try to have deliverables. So I think that's the other thing with research is sometimes people get stuck in kind of the big weeds of a project and try to say, okay, at the end of your meeting with your mentor, maybe say, I just want to make sure I have my action items. Okay, fine. These are the 2 things I need to get done before our next meeting, and set, reasonable expectations and goals for yourself. And I think that will also help you to be successful and finish something. I think that if you do have a project, I also think it's really great if you can figure out a way to present an abstract at a meeting. So one thing to think about is sometimes, meetings like the American Urologic Association are a big national meeting. It can be hard to get things accepted. But the sectional meetings, so we have regional areas where, so there's like the North Central section, which we're part of, Southeastern, et cetera. A lot of those meetings are really geared for medical students to present. So those are great meetings for you to try to submit an abstract to, and oftentimes those will get accepted. And so that's a great place, to network and also present. You also can look at subspecialty opportunities. So if your research is in female urology, like what I do, the Society of Urodynamics and Female Urology has its own meeting, right? So that might be a place that might be better for you to present some research. And again, sometimes those smaller meetings, you have a higher chance of success of getting something presented there. For those meetings as well, there often are travel grants for medical students that are presenting that you can apply for. So those are all things to kind of think about, because, if you do get something accepted, you may have to figure out your travel to get to that meeting. So those are things to think about. Ganesh or Mady, do you all have any thoughts about research or any comments you want to make?
Sure. I think the research is, at your guys' stage is a surrogate for enthusiasm for the field. If you think about an application, right or wrong, it's a metric that program directors and others will look to see and get some sense of your engagement within the field of urology. Of course, it provides you with an opportunity to learn about science, to learn about the field, to learn about a topic in a greater way than you might otherwise get involved with. I agree with everything with what certainly Laura and Dr. Gupta were talking about. Getting involved in projects early on is key. Don't bite off more than you can chew. Deliver on what you promise. And if you can't, be honest and say, I'm unable to do something early on. Seek feedback to ensure that you're doing the project in the right way and you're writing it up in the proper way. And that you don't go all the way to the end and realize you should have done something else because there was a misalignment of expectations. And try to pick something you like. I think what Laura said too, it's certainly quality over quantity. Abstracts and publications, boy, they're nice, but I also fully realize as a research type person myself that some of the best science never gets published and certainly takes time. And I think being involved to the extent that you can in a research project and so that you can credibly talk about it on an interview is important. But, this is a game, the game being residency program applications, and having a tangible deliverable like a publication or abstract or a presentation is important. Ultimately, I don't think how important it is we can debate, but for the application process, it is an important component. Mady? Yeah. Or Priyanka,
I'm just going to put a quick plug in for the Society of Women in Urology. There's a mentoring session, mentoring conference that happens in February, which students, I believe, don't have to pay to get into, correct?
No,
I think that's correct. Yeah.
There's some grants, and they're also a great opportunity to present.
Yeah, and I was going to add about presentations also. So the other ways you can present, get creative. So if your medical school has a medical student research day, present your work there, right? So there are ways that you can, you talk about gaming the application process, but if you want to show that you've presented somewhere, you can, I've seen people put that they presented at their medical school, they presented at a grand rounds at their medical school. I mean, those are ways to also still show that you're engaging and presenting, because like Dr. Palapattu said, sometimes it's hard to actually get to a conference. And so if there are ways that you can show that you presented locally, that also can make a difference. Again, within urology, there are often state specific. So I mentioned the regional societies. There are also state specific societies. So like we have a Michigan Urologic Society, you know, almost every state has one. So that's another place where oftentimes there's a research day. Students can submit something to that. So again, there's lots of these smaller opportunities that you can try to capitalize on as well, especially if you don't have kind of a big home program. So those are things you can look for. Questions from anybody about research? Michelle, I see your hand raised.
I just have a quick question about how specifically do programs look at research that was done before medical school? So like if you like did a grad program or anything like that, and then you have research from that.
So I think we certainly will look at that and consider that as, you know, part of your package that you've had experience with research. And it's certainly something we would ask you about. I do think that while you're in medical school, though, we would like to see some sort of engagement in research during your medical school years. And like I said, it doesn't need to be 10 papers. It does not need to be that you were in a lab. I mean, I think, again, one good project is enough, but I think there does need to be some engagement during medical school. And again, it doesn't need to be urology. Other questions?
Hi, Dr. Gupta.
Yeah.
Just a quick question. What are your opinions on blog posts and such?
So I think that's an interesting question. And it's actually something that is certainly being talked about at the university level in terms of, you know, how much do we look at social media engagement and blogs as part of people's academic productivity. I think it's certainly, if you've been writing about something relevant to medicine and urology, I think it's certainly something that's good to talk about. I do think most people would like to see some engagement still in a research project, but I do think that certainly shows a commitment to writing about a field and writing about, you know, an area or a topic. And I think that's something that would certainly be very interesting on your application.
I would chime in and agree with Dr. Gupta. I think, you know, it can have certainly an upside, but it certainly is not a replacement for original scholarship that's been peer reviewed.
Mm-hmm.
That is the currency.
Thank you.
Questions? Any other questions on research? Okay. Well, then I will move ahead here. So I also talked about, I know you just had a lecture on mentorship, so I won't spend a lot of time on this, but I do think it is important to think about mentors from a clinical aspect, research, and life. It's good to have people that can help you in all different parts of your career. And I want to make a point about specialty choice that sort of echoes off what Dr. Palapattu was saying earlier. You know, sometimes you will meet somebody who is super charismatic and you think, gosh, I want to be just like that person, right? You meet them but I think it is important to separate that person and their specialty as well, because sometimes the actual specialty itself that they're doing might not be something that you're interested in reading about or learning about. So it is important to say, you know, do I like the person and the specialty, or do I like the person and want to be like that person, you know, from an overall career perspective? So the example I will give is when I was on my general surgery rotation, one of the breast surgeons, I just really thought he was such an amazing, you know, human person in the operating room, you know, and there was this time I walked out and I was like, you know, I'm going to do breast surgery. And I thought about general surgery. And then I started thinking about, like, do I enjoy studying about cholecystectomies and appendectomies, and what is like the bread and butter of general surgery? And do I like that? And I was like, you know, I don't know that I like that. I don't know if I want to go through a whole residency where I'm doing all these other things to get to being a breast surgeon. Whereas I much more enjoyed studying, you know, urology and kidney stones and incontinence and all these other things. So I think it is important to remember that when you meet people on your rotations, kind of, and to think about your mentors in that way too. You know, it's good to have excellent mentors and want to be like them, but also just remember to keep that in mind about the specialty you're choosing, because you do have to do it every day. Any questions about mentors? I know you had a whole lecture on that, so I'm not going to go into too much more about that. if there are questions you didn't get a chance to ask in the last session too about that. And Laura, I don't know if you want to comment on any mentorship advice that you would give to M1, M2s.
Yeah, I think, going back to the research portion of it, I think research mentors are a great way to get mentorship in urology because there's a fixed deliverable or goal that you're both working on. That can be really nice. I think one of the things that people struggle with is how do I identify who is going to be a great research mentor to a medical student? So there are great research mentors, people who can make your career as once you're a fellow or a resident, but mentoring a med student is very different because we often don't come in with very strong research backgrounds. So one of the ways you can do that is looking to see if the med students that they work with are on the publications that they put out. Are med students getting credit for the work that they're putting into these projects? That's really important. And then the other thing is you have to have that difficult conversation when you sign up to work with somebody as a mentor or as a research mentor specifically, the first time you meet with them, which is what is your expectation for timeline of how long this should take? Because if it doesn't meet your timeline, you probably shouldn't jump on that project. And what is your expectation for authorship or opportunities to present? And it can be very uncomfortable to be the person that brings that up, but you have to be appropriately compensated for your time and your work because you have very little free time. And making sure that this is a person who is going to give you opportunities to present, make sure that you get credit for what you do.
I think that's such a great point, Laura, because I think it's an honest conversation to have. And like you said, it can be very uncomfortable, especially when you're meeting a new mentor who is, very senior or very established. But I think more of us are comfortable having that conversation. I think it's becoming more commonplace. Like I know, for example, I try to set that expectation with my students at the beginning before they even ask and say, this will be your involvement. I would like you to present here, but when we write the paper, you will likely be at this position. Are you okay with that? And I think that's an important discussion to have.
I think it's also important to have, but I wouldn't lead with that.
Yeah. Yeah, I think that's the sort of end of the end of the conversation. Other thoughts or questions about mentors? Dr. Go or Dr. Palapattu, any thoughts from the 2 sessions about mentorship?
Oh my goodness, many. But I think it's been covered, fairly extensively and already, like you said.
Okay, so then the last thing I wanted to talk about was interest groups. And so again, I think as you're thinking about urology, what are ways to get involved? So if your institution has a urology or surgery interest group, I think that's a great place to get involved. Most interest groups try to have opportunities for you to meet faculty, to have mixers or research discussions, things like that. They'll often invite you to educational events through the interest group. So for example, at Michigan, we have a big alumni association meeting in the fall. We'll often invite students to attend portions of that meeting. We'll often tell students if there's opportunities for grand rounds or other visiting professors and things like that might be around. So it can be a nice opportunity for you to see what's going on. Also, sometimes these groups can be locations where you might find research mentors. So again, a lot of interest groups will try to help connect students with opportunities for research. And then we were talking, and I know we touched on this a little bit, but I do think that looking at some of the organizations like Society of Women in Urology, the American Urologic Association, some specialty groups, there are opportunities. And I think so I spent some time looking at a lot of the websites, and there are a decent number of things that are advertised. You do have to look a little bit on the sites, but you usually can find information about there's a medical student scholarship you can apply for. There's a travel scholarship you can apply for. So, those are things that I certainly would encourage you to take advantage of. And I think this is applicable to any specialty, right? I mean, not just urology. So if you're still undecided right now, it's also important to think these are ways to set yourself up for success in any specialty you choose. And I can give you the example that, I've had students who I've reviewed applications where people have come in and they were the head of their emergency medicine interest group or whatever, some other specialty that was not urology. And that's where their interest had started. And they were part of that group. And you can see that they were interested in that specialty. Then they switched to urology. But again, it was another experience that they had. It was something else that was on their application, and certainly something I would look at favorably. I wouldn't care that it was emergency medicine versus urology, you know. So questions about any of that? And then Laura, maybe I'll have you comment on other ways to get involved too, since you're closer to it than I am now.
Yeah, I think if there's any types of, so for example, how I met Dr. Go was our Student Diversity Council wanted to build a disparities-based curriculum. So that wasn't even through the Department of Urology, but it was going to have touches with the Department of Urology. That's like one way to get involved, is looking for how can you blend maybe an interest you have in some other area. Mine was DEI, disparities, with the field that you're going into, namely urology, and try to see if there's opportunities to do that and find the people who are doing that as well.
Then, yeah, Dr. Go, do you have some comments too about opportunities?
Yeah, I was just going to ask the group in general, like, where are you in your journey of deciding, like, just out of the blue, like, just curious. Have you done any observations already? Just let us know. Does anyone want to volunteer?
I'm sorry, is the question like our experiences that we've done in urology already, or what our interest level is in urology? I'm sorry.
What your interest level is, like, just curious.
It's my top choice. I don't know about others.
And Javier, can I ask, what experience have you already gotten to have so far?
Yeah, so I'm starting a similar research program. I'm sorry, what's the
could you
question?
stop sharing your slides so we can see that everybody?
Oh, sure. Yeah.
So I've just done a little bit of shadowing. So my medical school, we just got our first urology faculty this year. So that's kind of slow starting, but I just got into that. And I'm doing actually Dr. Santiago-Lastra's summer program. So I'll be doing that shortly. But yeah, not too much, but I'm trying to get there.
Excellent. Anybody else want to share their experiences?
Yeah, I can go. I'm also pretty set on urology. I've shadowed a few times, and I'm starting to work with a pediatric urologist on a research project as well.
Excellent. I think you're going to find, like, in general, this is probably why, like, as Dr. Palapattu alluded to, I mean, I ended up in urology because I rotated it by chance onto urology. And like he says, we're generally nice people. We're not hotheads. And we have the most awesome jokes. So definitely, that's what convinced me to be a urologist is, hey, I like hanging around with these guys. I like the surgery they do. And that's how it started. I did love transplant, but like Dr. Gupta said, the thought of going through general surgery made me think otherwise.
Yeah, for me too, urology is also my top choice. I've had a lot of shadowing experience so far. I pretty much shadowed urology all summer before my M1 year. Now going into this year, I plan on shadowing some more. And I've reached out about potential like urology research opportunities over the summer too.
Great.
Yeah, same here. Sorry I don't have my camera on right now, but I'm like 95% sold on urology. I'm at UCLA, so I've done a lot of shadowing in like the different subspecialties we have, and I've also done my surgery clerkship, which sold me because I originally fell in love with urology because of the clinical portion of it, and I didn't have much exposure to the surgery, so I really just loved our lectures on it. And then I did surgery and I loved it, so I think it's great.
Excellent.
I'm also sold. Oh, go ahead.
I was just going to ask a quick question just based on like kind of where I'm at in my like my progress through med school. So I am a rising third year, and because of how our curriculum is set up, I don't get to do my surgery clerkship until the very end of third year. I think it's my second to last rotation. And we don't have a home urology program, and I am not eligible to do a urology elective until my fourth year. So, and I came into med school actually intending to go into OB. And so all of my research experience up until this point has been based on prenatal care delivery. So I have shadowed a pediatric urologist actually at U of M, and I really loved it. I haven't gotten a lot of general urology experience, but I'm hoping to find ways to fit that into my third year. So I feel like I kind of found like a love for urology like pretty late compared to everyone else, just because I didn't think that's what I wanted to do coming into med school. But I guess my question would be like, what else should I be doing in my third year in order to kind of stay on track, in order to I guess like continue developing that interest, but also be ready to apply by the beginning of my fourth year.
So, I think Michelle, if you've already done a lot of research, I think that's great. And so I don't know that you necessarily need to have a urology project, but as long as you can kind of have good follow through on the work you've already done in OBGYN, I think that's, that should be sufficient. I think the biggest thing is to try to give yourself some experiences, and you're going to want to think at this point about, how can you have some good clinical experiences that are going to lend you to do well in sub-internships and do your elective rotations? Because I think that's probably the next part of your application that you're going to need to think about, is some of the letters and, where you're going to get those from. So I think what I would recommend to you is trying to start planning now for how are you going to do your sub-internships in urology, if that's what you've decided on, and where are you going to do them? How are you going to get there? And then also making sure that you're going to be able to get some strong letters of recommendation. And then obviously I think with the research you've done, I don't know if you've presented or not, but if you can look for ways to try to present during your third and fourth year, I think that's another good idea. And you certainly could pick up a urology project if you want to, but if you don't have a home program, I know that gets harder, to pick up something in urology. So that's why I think if you want to stick with what you've been doing, that's fine. But I would look for ways to try to present a little bit. Okay.
Thank you.
Mm-hmm.
Dr. Gupta, I know you mentioned briefly that you have experience with international health as well, and I'm very interested in that as well. So I was wondering if you could talk a little bit about how that fits in with your career in urology.
Yeah, so I was really, actually, I think part of what drew me to urology initially is I was very interested in the area of obstetric fistulas and, thinking about care and incontinence. And so I, as a resident, actually, so this goes back to like finding people that maybe have an interest. And so one of my mentors at Minnesota did a lot of work in simulation, and we started talking about, well, how do we think about, could we use simulation in low and middle income countries? Are there ways to think about capacity building? And so he and I started this project of developing a trainer to try to help people learn how to do fistula surgery, like just basic fistula surgery. And then, we started thinking about, well, how do you adapt technology in a setting, in a resource poor setting? So we worked on developing we developed a whole program that could be run without the internet on a computer. You don't need like high technology for it. So, it was that was something that I was interested in. And so because of that project, I then was able to, I made 3 or 4 trips as a resident to various places in Africa to work with fistula surgeons in developing this program. And so, I, as a resident, I was still early. I got to do some surgery, but I mostly was assisting, right? I mean, I wasn't ready to operate on my own. So I was assisting surgeons there, but I was learning from them. I was helping them with developing a program. So, that really kind of continued my interest in education, because I think for me, global health is a lot about thinking about capacity building. I think that's really important, and kind of moving away from sort of mission work, but really thinking about how do we partner with our colleagues in other countries? What can we learn? What can they learn? What are the needs from both sides? And so that's kind of where my interest in global health has kind of continued to sort of evolve. But as a resident, I actually used my vacation to go because I didn't have time to go. I think one of the weeks I was able to get covered as part of my research time. But other than that, I used my vacation, which, again, these are things like depends on what you're interested in and passionate about if you decide you want to do that. So, But then also as a faculty member now, I am working on thinking about global health for our department. So I actually just got back from Rwanda. I was there 2 weeks ago, doing fistula work with a group. And, you know, we're thinking about what are the opportunities for developing a rotation for our residents here. That's something I'm working on. And again, I think a lot of it is thinking, so actually one of my roles is really thinking about how do we do this in a sustainable way? How do we do this in an ethical way? You know, what is kind of the right way to do it today? Because I think global health looks very different today than it did, you know, 15 years ago, right? So yeah, so that's, I guess that's a short or maybe a long-winded answer. So
Thank you.
So looks like we are starting to wrap up here a little bit. Any other questions we can answer before we move back? Dr. Go, are we moving back shortly then?
No, we have about 10 minutes. That's for the other breakout
Okay.
because they're going to come back. They have 10 minutes to discuss.
Perfect. Yeah, other questions I can answer. Or anyone else want to share where they are on their journey? Oh, Raven, sorry, go ahead.
So I'm also at UCLA with Ashley, and you know, kind of we've condensed our preclinical into 1 year, and then we'll do rotations our second year. So I've been trying to like shadow urology this year. I scrubbed in on a vaginoplasty yesterday, and it's the coolest thing. But so our third year is kind of off to do some kind of research or health equity project or kind of whatever you want. And so I'm in the global health program, kind of already set up with like a pediatrician in Mozambique. And so I'm wondering, kind of with our curriculum set up this way and already like a plan to be like doing something not urology related in my third year, kind of how to continue to like show interest in urology, and then maybe to get creative, like ideas to get creative in that third year while I'm there to continue urology related work.
Yeah, I mean, I think, again, if you have projects that are already set up, I think that's excellent. And again, we're going to want to see you be able to talk about that on your application, even if it's not urology related. But I think, you know, if you're working with a pediatrician, you're going somewhere different, you know, if there's an opportunity to think about, hey, you know, there's a lot of kids we're seeing here that have, you know, voiding dysfunction or, you know, other things, you may be able to talk about that experience. So I would sort of keep an eye out for experiences that are urologic in nature, that you can, you know, that you may even be able to draw on for like your personal statement, or, you know, so these are like other creative ways to think about, even if you're having these experiences, are there going to be some element of that that will lend itself to your, you know, to your overall portfolio? And then I think going back to what Laura said earlier, you know, as you're having some of these experiences during your third year, even if they're not urology, sometimes the connections will happen, right? Like if you're doing, you know, equity work or you're doing other projects, you might end up finding someone else who is a urologist or is going to connect you to someone in urology doing similar work. So that would be something I would certainly keep an eye out for. Laura, do you have any thoughts?
The only other thing I would say I wish I had done my first and second year is write down the things that you do, because 4 years is a long time. And now I'm like at my URAS application and I'm like trying to remember all these things that I did my first year. So really writing them down and writing down stories, experiences that you specifically had that you can speak to. I had a friend remind me of something we did our first year that I had completely forgotten about. It was only 3 years ago now, but it's a long time.
Thank you.
And then I would also say too, Raven, you know, as you're thinking about your M3 year, you know, again, just continue the opportunities for shadowing. You're at UCLA. There's lots of opportunities, I'm sure, to interact with urologists. So if you have a half day here or there where you can go spend time in someone's clinic, it's never a bad idea, you know. And actually, to that point, I just want to make this point too. You don't always have to spend a whole day with somebody, right? So that's another thing too. I know your guys' schedules are busy. So sometimes, you know, I've had students come just say, hey, can I just come for a morning and spend a morning with you, you know? And that's totally fine, right? Like come for a half a day if you've got one, meet someone, work with somebody. It's always a good way to kind of show your interest, you know? Other questions or thoughts, or anyone else want to share kind of where they are in their journey?
I'm in MS2 at Baylor, and as of right now, I'm pretty set on urology. I've completed around, like, I guess, half of my core rotations. I haven't done surgery yet, but I've done a lot of urology shadowing so far. And I think I've been really lucky to find a really good research mentor and been involved in a lot of projects. But I did have a question regarding research, because I'm noticing that basically all of the projects I've done have all been kind of in the men's health, men's and male infertility sphere. But I'm wondering if it's, I guess, like, worth it to kind of branch out to other areas of urology as far as research goes, because I guess my concern for applying for residencies is that, like, if I apply to a program that doesn't necessarily have the strongest male infertility or men's health department, would that kind of like close off doors for me? I don't know if that makes sense.
No, I hear what you're saying. And I would tell you, I don't think so at all. I think, again, if you've done work in that area and that's what was accessible to you, again, everyone's going to look at that and say, great, he did work, it actually is urology related. That's excellent. That's who, because we know that you can't do everything. We also know that, there's things you're interested in. There's also sort of the chance of how the mentorship relationship ends up happening for different people. And so, again, I don't think that matters at all. I mean, we look at applications, and I personally look at just what people's involvement has been. I look at the project and I try to see, was there some follow through? And the way I gauge follow through, to be honest, is, sometimes people will write that they got to present it somewhere, or they'll say like they finished a manuscript that's been submitted. So, back to Dr. Palapattu's point, we know that it's hard to always get something published. That doesn't always happen. But, sometimes just saying at least submitted shows me that, look, you took it through the whole process, right? Like you did get the manuscript done. So that's what I look for. And I'll look and say, okay, well, they did one project where I can see it was kind of beginning to end. Great. They've been involved in research,
And then one thing I would say about the research is just remember, like what Laura said, write some notes if you're doing it early in the game, because if you're going to write this in your application, that's fair game when they're going to ask you a question. And it was in your first year, and all of a sudden, like, you have no idea what the details are, go look at it again.
Mm-hmm. Other questions? Yeah, great.
Hi, my name is Talmadge Gaither. I'm from Drexel University up in Philadelphia. I've had previous experience in urology during my gap years working as like a scribe.
Yeah, perfect.
I just kind of have a question regarding like balancing everything between school, shadowing, research. Like, how did you guys handle that?
Yeah, I think that's a challenge, right? So that's why, like I mentioned with shadowing, I didn't do a lot when I was a medical student. I think my first and second year, when I had a few free days, I did like some half days, right? Like I contacted someone, said, can I come to your OR? Can I come to your clinic? It wasn't like I went every week. I mean, I probably did a handful of days, and I did it in areas where I was trying to figure things out, where I was like, oh, I remember I went to ENT for half a day because I was like, maybe I want to do ENT, and then I watched someone clean somebody's ear for half an hour, and I was like, yeah, I definitely don't want to do that. That's gross. And so, I mean, like those, I think those experiences are really helpful, but you don't have to do a ton of it. Do what your schedule allows. For research, I would say that's where, again, I would say pick something that you can do, like not something that is an overwhelming project. Try to pick something that has kind of small, a smaller deliverable. It's something you can manage. And, I would say for yourself with research, try to, if you don't have so, there's some things that are required through your medical school. So like Raven talked about, you have something that you're supposed to do your third year. My medical school had, we were supposed to have at least one project that we were doing with a mentor, right? And mine was in QI. I actually don't think I had any urology papers when I applied to urology. So, I had those projects, but, so I had some medical school mandated deadlines that I had to meet. So that was helpful. But if you don't have that, I would set that for yourself. Like say to yourself, I'm going to work on this project, and my goal is going to be that I'm going to try to have something that I can present at the end of my second year. And then maybe I'll have a manuscript done by my third year. you know, and maybe focus on one or two things. Try not to do too much. Laura, do you have any thoughts? Because again, I'm talking about an older experience now, so
yeah. So
I'm not gonna age myself, but
I'll share a little bit of I've had projects that have been really successful and I've had projects that have been unsuccessful. So I'm going to share like a bit of a failure on my part was I tried to do a project that was like a chart review while I was in clerkship year. And that is like not the right project for that timeline. So clerkship year, those of you who've gone through it, you have very, very little free time. You probably can give an hour a week, maybe, and an hour is not enough for that kind of project. You could probably do some like manuscript writing in that hour, but so having the right types of projects is really important based off your timeline. The way I turned that ship around was like, I just started having to block out 5-hour chunks on my weekends. I mean, like, this is research time and this is when I'm going to work on research. If your school allows it, the other thing that was really helpful was I got to do like a research month or two. So that is designated time to where I just get to focus on just that. I'm not studying. I'm not in a clinical space at all. That's really helpful as well. And then to Dr. Gupta's point, do not bite off more than you can chew, because nobody tells you this, but by the time you become a fourth year, when you were that like leadership in that one random club, like those things matter way less. They eat up a lot of time because there's lots of meetings, but there's actually usually not much very deeply meaningful things that you get to talk about from that. So pick like 2 things that you're very deeply passionate about. Great if one of those is research, and make time for those, and make time for your own personal wellness as well.
Yeah. And I would add, when you're thinking about the research timeline, also remember, if you're going to do urology, you're going to be applying it in the fall of your 3rd year, right? So if you think about that, ideally you want to have a manuscript that's ready to go as you're getting close to the beginning of your 3rd year. Ideally, because if you want it on your application, right? Like, otherwise it's not going to be on your application. So that's why I was saying even the submitted part is great. If you can get something done and be like, submitted, that's gaming the system a little bit, right? But just thinking about how do you game the system and prepare for that timeline that's coming up for you. And so again, I would say, especially for those of you that are in an M1 year right now, like, think about, can you carve out some time maybe earlier in your M2 year to get a substantial part of your project done, right? So like Laura said, I also had some research time, and I think I took it fairly early, and I had a project ready to go. And so I spent time during that month really like knocking out the work I needed to do, knowing that I could do some writing later, but I got at least the chunk of the project done, right? And so kind of planning that ahead of time will help you be successful. All right, 3 minutes. Cameron, go ahead.
Yeah. Hi. Thank you guys for doing this. I had a quick question. So I just finished my M1 year, and so I've been doing some shadowing, but I do have some questions about like how to kind of approach shadowing, I guess. In my curriculum, we kind of do like basic science all first year. So like I don't really have a good foundation of like the medicine part of things yet. And so how do you like get a lot out of shadowing without kind of being in the way or kind of being like annoying? Like sometimes I feel like when I'm shadowing, I'm just kind of like standing there and I don't want to be like intrusive asking so many questions. So do you have any tips on like how to kind of be like a presence there, but like not be annoying, I guess, if that makes sense?
Yeah. So I guess 2 tips. I have a lot of students that come to shadow me, and I will tell you, so I think a few things that make people successful. When you see who you're going to shadow, look at their specialty and read like a little basic something about it. Like if people are coming with me, it's like incontinence, read a little bit about incontinence. The other thing you can do is, if you've asked to shadow someone, you could ask in that email and say, hey, do you have any tips on something I could read before I come to your clinic? And ask them, are there some topics I should prepare for? So I think that will help you it'll help make your experience better in the clinic, because you'll have some frame of reference to better understand the patients. I think the other thing I would say, and Laura, maybe you can also comment on this, is I would talk to other medical students maybe in the year ahead and find out who's a good person to shadow. Because I do think, I'm not going to I don't want to toot my own horn or whatever, but I guess, I've had many students who come and I've heard like, oh, someone else told me that I should come shadow you, right? And I think it's because people who care are going to talk to you more during your shadowing experience. And so you want to shadow someone who is going to do that with you, right? And so I think asking other people who those people are at your institution is a good idea. And a lot of times, program directors and people that are involved in a residency education side are good people. If you don't get any recommendations from other students, that would be the other place I would start, because obviously those are people invested in resident education and invested in like the next generation of med students. So you can look at people who are either med student clerkship directors or, you know, residency program directors, things like that.
I would say reach out to your urology interest group. We have like a whole list of people we usually refer to shadow. We know who's the best people to shadow.
Okay, any last thoughts? We're gonna be closing out here and going back into the main room.
All right, well, good luck to all of you. It's very nice to meet you in this session.
Thank you.
Thank you.
Thank you.
Thanks, Laura. Here we go. We're all going.
Dr. Go, for some reason it
Okay. I'm so sorry that in our group, we just got cut off very abruptly with a lot of pending. It's very hard, and I'm going to have to just send some email responses.
Very sorry.
Responses. Yes, I'm so sorry.
Yeah.
Where are we going here, Medi?
So now we've got a 15-minute break. We're gonna regroup at 12:30, and then we'll start up again. So if everyone wants to turn their stuff off, take a break, run to the bathroom, grab something to eat, great time to do it. Sorry, Marcia, every year, like, we need to make your session longer.
I thought it was longer this year. We have time. We dedicate a fair amount of time to the small groups just so that this wouldn't happen, but it's happening again because it's an important topic.
Yes. And I don't know if you know this, but we are the only group right now, at least according to Dr. Brusser, she's our Chief Diversity Officer for the AUA, that includes microaggression in their material.
You know, people don't want to air their dirty laundry, so they're not going to do this topic. So.
Yeah.
All right.
All right, let's take a bio break and we'll be back.
Okay.
Welcome back, everybody. So now we're gonna split up to our second breakout session. So the go ahead and join your groups. The M3s and M4s are going to go to Dr. Gupta's first group. Let's see. We're waiting on Dr. Gupta. Christian, can you move yourself to the other group by any chance?
Yes, which group is that? I only see group B, and then I see, oh, I see it now.
You see the other one?
Okay. You think we have almost everyone, maybe?
I think so.
Yeah.
Yeah.
Okay, great. All right. Hello, everyone. For those of you I haven't met, I'm Priyanka Gupta. I am here at University of Michigan, and I'm taking over as program director here in July. So this session is kind of a chance for, I think we started having some of these conversations last night, even in our breakout room, but it's really to talk a little bit about M3 and M4 year and things, considerations. So I've made some slides with just some topics of interest to spur discussion. But what I think what I'm going to do is, as we go through each slide or each topic, I'll stop and we can discuss that topic specifically. That way we can kind of just work our way through here. And then we've got a few students who have gone through the process. Who else here from Michigan right now? Or a few M4s who are applying soon. So
you have Basil and you have Laura. I think Laura's still.
Right. Okay, Laura, you still here too? Somewhere. Okay, there's a lot of people in this room. So I'll also maybe Basil and Laura have you all chime in on some of these topics as well. Okay, so let me share my screen here and let me make sure I do this the right way, because last time so now I need to, okay, good. That looks good. It's not in presenter mode. Okay. All right. So this is the outline of the topics I was going to try to cover today. So timeline, gap year, step 2 scores, sub-Is, research, and financing. Okay. And then we'll
fix your screen one more time. Like
one more time?
Share the right one.
Okay. That's what I was wondering if it, let me see. I think I have to swap it again.
Yep.
Is that
there
right?
You go. You got it.
Okay, so timeline for application. So I'm actually going to defer this right now to Basil and Laura. So do you all want to just maybe go over briefly the timeline for the fall from your standpoint as a student?
Sure. So I believe last year, I don't think they've released the exact date, but I believe ERAS closes last year around September 28th. So that is like the time point where you want everything in. I've heard from several people, make sure it's in like a week earlier, just in case things crash. Things always seem to flunk out right when you're trying to submit it. So ideally you'd have that, you'd have your letters in ideally a month before. That way they're just like sitting there waiting. If you're doing an away rotation in September, obviously that changes that timeline a little bit. ERAS opened this weekend, so you can actually start editing it now. And you have from now until September to do that.
Not much more to add. Hope you guys can hear me okay. I'm in a coffee shop. But also in regards to like the letters of rec, I know a lot of us are doing sub-Is maybe in August or like really close to application day. So it's always good to kind of get ahead of that and having whoever's running your letter of rec kind of know as soon as possible. So if there aren't any last second adventures trying to get those letters of rec in.
All right. Are there any questions about applying and timeline and nuts and bolts of application?
I had a quick question. I know that urology uses like a different, I guess, system. Are we still like applying through ERAS, or like do we go through AUA for the application? Because I'm having trouble trying to find where the application is.
Well, so it's through ERAS. It's not through the AUA. It is still through ERAS. So I think you should be able to find it there. I don't know if there's any other.
There's a question in the chat. Is there any benefit to applying right when ERAS opens versus closer to the end date?
I would say, yeah, there's not a benefit to that because we're not going to start reviewing applications till the end date for ERAS. I think though, to Laura and Basil's point, I think starting to work on your application once it opens is not a bad idea to start working on it early, just because there are a lot of components and there's certainly some burnout as you're doing it. I can remember from when I did it, like it's a lot of components to it. So it's kind of nice to start early and like get all your ducks in the row about dates that you did various things and to see how it's structured so that you can, you know, put in all the right areas that you need to.
Thank you. Namrita has her hand up.
So I had a question about the signaling, and if I read a statement saying that if we apply or do an away rotation at a program, we shouldn't signal that program. Is that statement still correct?
So signaling is complicated. It's a new thing that just happened. And I'll be honest, I don't know how all the different programs are using signals. I will say that for us, we have not been making that a big part of how we're making our decisions, because again, I think it's such a new thing and we're not really, I don't know that we want to weigh our rank list based on signaling. So, you know, so I guess that's my point of view about it. I don't know well enough how other programs are using it. At least last year, I think most programs were it was sort of an extra thing, but I don't know that people were weighing it significantly into their rank lists. But I don't know if that's going to change over the next few years or even this application cycle. Other questions? Brittany.
So I know that they said geographic signaling was going to start. Is that going to be more important if someone doesn't have a preference versus someone who specifically says they want to stay in that area? Will that hold more weight?
You know, again, I think it's really hard to know. You know, I can't speak for all the programs. I mean, I certainly could see where if you had two applicants who you thought were equal, right? And you said both of these applications are equal and you were trying to decide where to put them on the rank list. If someone signaled and said, you know, I really want to be in this geographic area, would you put them higher? Maybe. So I could see programs potentially using that information. But I think it's one of those things, it's so hard to know. Right now, I guess I would say it's hard to know like how well to game the system with signaling, because it's such a new thing that I think a lot of us aren't sure how much stock we want to put in it yet, you know.
There are two questions in the chat. One is, when is the best time frame to complete your away rotations to ensure everything is submitted on time?
Yeah, so I think that the part of it would be, so I guess part of it depends on if you're hoping to get a letter of recommendation from your away rotation. So if you want a letter of recommendation, then I would suggest trying to do it in, you know, July or August, so that there's enough time for people to write a letter based on your performance and get it in before the end of September. You know, I think even September is a little bit late to do a sub-I and ask for a letter from that institution. If you are doing the sub-I to help, you're not looking for a letter, but you're doing it as more of an audition rotation, or you're interested in the program, I think you can do that whenever.
The second question is general date range that interviews are offered.
Yeah, so I don't know. So I'm kind of new in this role too. I can tell you that ours are going to be in the November timeframe, but I would say starting kind of mid to late October through November is when most people are doing the majority of their interviews. And I would say there's probably some maybe into December. I don't know, Laura or Basil, if you have any info on that too, or what you've seen.
Basically, everyone has told me that November is the big chunk. You'll get like some maybe the last week of October, And just to clarify, the way that urology does it is all of the interview invites get released on the same day. So it obviously can't be anytime before that. And then you have like 2, 3, I think you'll get like a weekend, a couple days to kind of decide which ones you're going to say yes to, which ones you're going to try to get different dates for. But it's very organized in that way. So that kind of ends up meaning that most of the interviews are in a very confined, like 8 weeks between last week of October to December, and very few towards like the end of December.
And also, setting to that, urology is unique in hearing back earlier than most other matches. So that'd be like late January or maybe the first week of February.
Other timeline. Oh, sorry. There's your go.
I was just going to say you're going to have a session on the interview process for those who just went through it in a little bit too.
Yeah. Perfect. Okay. Any other questions about application?
There's another question in the chat. Sorry, another timeline question. If you were going to do an away rotation for purposes of an addition, what would you say that there is a date that you should complete it by for an audition rotation?
For an audition rotation. So I guess I would say you would want to do, well, so again, this depends on, are you trying to interview at that program? Because if you were trying to interview, then ideally you'd want to be done with your rotation either. So some programs will interview you during your sub-I. So for example, we do that here. Some programs will still offer you an interview. So if you are trying to get an interview, I'd say you'd still want to probably do that be done by October, depending on when the place is offering their interviews. And if you're doing it as an audition, then you also could potentially still do it even in November, because if you're going to have your, you'd want it done before rank lists, right? So if everything closes kind of end of December, that's when everyone's making their rank list, you would want to have finished your audition before that. I would caution probably against November, because if that's when you're interviewing, it's going to be hard to be on an away rotation and be, having to say I have to leave for interviews all the time. So probably the most realistic time would be to be done by October. Are there any other questions? Okay. All right, so I'm going to move on to gap year.
I had an additional.
Oh, sorry. Yeah.
No problem. So I just kind of read that the 2024 ERAS doesn't have an interest section, and from speaking with people that have applied in the past, the interest section has contributed at least to some part of their interview process. Do you know how you'll be looking at interest? I know it kind of only makes up, a portion of your application as a candidate, but I've heard that it's important and it's been a conversation in interviews. So I was just wondering if you've had any recommendations kind of around that.
Yeah, so I mean, interests are always helpful because it gives you something to talk about outside of the sort of general interview things that you're going to talk about. So I think if there are other ways you can certainly show your interest are through your activities. So, if there are groups that you've been involved with, like, I know for example, there are students who are really involved in, they're great musicians, and you can see in their clubs, they've been part of this orchestra, or they're part of this music club, and they listed those in their activities so that you kind of knew that they had that interest. And then I think the other things, you can certainly find a way to address some of those things in your personal statement. So, I think if there is something that you do that you can figure out a way to apply that to medicine or surgery, that's always, it's a nice compelling personal statement, but it also allows for a conversation during your interview. And then I guess the last point I would say about that I think, actually, Nemrith, I think you were in my group last night, that Vanessa made last night, was that you always can look at the people you're interviewing with. A lot of people on their pages they'll say like, my hobbies are, in the about me on our faculty profile sections, it'll say like outside of work, they enjoy doing X, Y, and Z, right? So you can always look at that during your interview. And so then when people ask questions, you can maybe find a way to bring it up, like, oh, I see that you like doing yoga. I like doing yoga too, and that can be another way to bring your interest in.
Thank you.
Yeah. Okay. So let's talk about a gap year. So I think this question comes up a lot about, should I do a gap year? Would it be helpful for my application? So, I will say that in general, the trend that we've seen is that more and more students have done a gap year somewhere, right? The traditional student that has gone all the way through is much less than we've seen, in prior years. It seems like a lot of people have had some other experience, whether they were working before they went to medical school, they took a year and did an MPH or research or whatnot. I think that those years certainly allow you to develop interest. It certainly makes you a more well-rounded candidate. Certainly we all look at that information to see what you did during that time and whether it seems, compelling or interesting. I think in terms of if you're deciding to do it for the reason of applying to urology, I think you want to really ask yourself, like, how competitive your application is. And if you think that there are some significant areas that are lacking and that you feel like are going to hurt you in getting a residency, then I certainly think a gap year can be helpful. It does allow you to work either from a research standpoint or, if you work and get some other experience in industry that might contribute to applying to urology. Or, some people do a prelim year and then try to use that as a way to, get to know a program and try to match again the following year. So there's a lot of different ways you can think about it. But it certainly is something to consider if you feel like it would help give you a better shot. So I'll stop talking about the gap year for a second, and then maybe I'll see if Laura and Basil want to chime in on that too, because I know at least I think both of you spent some time doing other things. So
I spent some time before med school, and I was gonna do a gap year. I was gonna do the MBA, and Suresh, who you might have met during the microaggression session, is doing the MBA. And I think is equally as important as it is to talk to people who did do a gap year and what they got out of it, is talk to people about who considered a gap year and then decided against it. And talk to as many faculty as you can or mentors before you make that decision. And ultimately what it came down to is I didn't have great reasons for doing the MBA. Like it really didn't fit into my why and it wasn't necessary. And if it's not absolutely necessary, I personally would advise against a gap year. Like if you can go get started in residency and, get closer to getting a paycheck, like I think that's a really positive thing, but it's got to be balanced with other things that you want to do in your life as well.
Yeah, adding on, I kind of went through the same thought process. It was just identifying if there's any big gaps. And the advice I got from different mentors was really just think about what value it would add to your application.
Yeah, and I think that's a really good point. I think there's two ways, one is, do you want to do the gap year because there's something just really compelling that you've been wanting to do and you won't have time to do it later? Like, I don't know, you're going to go spend a year in, I don't know, somewhere exotic and do some, great volunteer work or, whatever reason it might be, or an MPH or an MBA. So there's that portion to it. And then there's the other consideration of whether you think you need it to be competitive. But I completely agree with both of their points in that if you don't need it, I would say it is a long road. And it is, most people do a fellowship, a lot of people do fellowship. So it's like, you're potentially looking at 7 or 8 years of training before you're going to be done. So I think if you, feel pretty good, I would say you should just go ahead, and not take that extra year off if you really don't need to or don't have a really compelling reason you want to. Are there any questions in the chat, Dr. Girl?
Yes, sorry, I lost my mouse for a second.
Oh, that's okay.
It says, would you mind elaborating on competitiveness? Are we speaking about grades, STEP, research, and what combination of those things?
So again, I think that's really, it is a little bit subjective with every application. So I'm going to put that out there first. I think a lot of programs have gone to looking at a more holistic review of applications. So not necessarily having a cutoff score for steps. So I think that seems to be less important. I would also say the grades, we certainly look at them, but a lot of schools are pass fail. So even grades are sort of less helpful. So I would say the things that we're really looking at are kind of package of your clinical and research experiences, your interests, and then also just trying to gauge the kind of person that you are. So when I say competitiveness, you know, if you're somebody who has not had a lot of time in urology, maybe you've not done a lot of research, you know, you haven't had a lot of time to spend with people and do rotations and get strong clinical letters, like those are things that would all potentially make it harder for you to match, I think. And so if that's the case, then that may be where you say, well, you know, maybe I do want a little bit more time. I need to do some more research. I haven't done any in medical school at all. Like I'm going to go spend a year doing some research, but I'm going to do it in a urology department where I'll get to know people and maybe I'll get to try to match there, right? Like that would be, I guess, an extreme example. But again, I think it's hard because it's a little bit individual with each person. So I say that because I think that there are elements of people's applications that can compensate for other things. Sorry, I know that's a complicated answer, but.
Cindy's got her hand up.
Yeah, I just want to like go off of what you're saying in terms of like research. How important is like having urology specific research in terms of your application? Like, are you okay? It's like if somebody joined in like wanting to do urology late, but they have prior like research in other fields, so like, what's your take on that person?
Yeah, so our take is it does not need to be urology research, and I think you know, I have a slide on this later too, but I think a big part of this is how much showing really follow through with a project. It doesn't need to be, you don't need a lot of projects. I always tell people quality over quantity is most important. And it really should be a project where you played a significant role in the project. It doesn't have to be a huge project, but it should be something where you can talk about it. You can say, you know, I participated in this part of the project. I helped, you know, present it. I helped write a manuscript. And so the other thing I think is important is follow through. So if I see someone is involved in 20 projects, but none of them have led to presentations or led to a paper, to me, that's like, okay, well, you just put your name on a whole bunch of projects, but you didn't actually go through the process of the research. Whereas if I see someone who did one project, but I saw that they presented it at some, you know, at a meeting, and then they worked on a manuscript, even if the manuscript's not published, if you even put that you submitted the manuscript, you know, we know it can take a while to get things published, but if I see that it was submitted, I'm like, okay, at least they followed it from beginning to end. And that one project would mean a lot more to me than lots of projects. And again, we understand that people come into urology at different points, so we don't expect everyone to have urology specific research. Let's see, other questions. Okay, nothing else in the chat. Okay. So the next area was step 2 scores. So I know everyone's kind of asking about this. And so with step 1 becoming pass fail, right? Some people are saying, well, your step 2 score matters more because now that's the only score that we have to look at. So I would say I view this as an element of your application. You know, I think if you have a really low score, that could potentially hurt you. I think if you have a medium to high score, that's fine. Like most people, so we specifically we don't have cutoffs that we are using for scores. Now, there may still be programs that are using cutoffs. It is certainly an easier way to help screen through applications, and I'm not sure who those programs are. But overall, what I would tell you again is that people are really trying to view applications as a whole rather than just based on an individual score. Where I think it can be helpful for you, and then Laura and Basil, maybe you can comment too as to what you've heard. But I think that if you are someone who maybe has struggled with grades, or maybe there's been some things from grades, or that I would say really grades, I guess, or rotation evaluations that weren't as good for you, then maybe having a really high step 2 score might help balance that. And so that is something to consider for your application, is if you feel like you're weaker somewhere, you could like really try to knock step 2 out of the park and have that score on your application to be like, hey, look, I do have a good base of clinical knowledge. So I'll stop there. Laura, Basil, do you have any questions or comments on step 2 scores or what you've been hearing?
I think Laura's in the throes of studying.
Yeah, I'm in the throes of studying, but I'll share what I've heard, which is like people used to view step 1 as like almost like a dose response. Like for whatever reason, people thought like a 255 is better than a 250, which is like, we're now realizing that's like probably not true. And so the thing, the scuttlebutt is that like it's more of just like a checkbox, like you've passed this certain number, and like unless you're that person who's gonna get way, way, way up there, which is like the top 2%, like it's all kind of one and the same after a certain threshold.
Yeah, absolutely. I've kind of adopted the same philosophy as I'm in the middle of step 2 studying as well. And that's the advice I'm getting from loads of different people.
I mean, I really think that the weight, and actually this goes to sort of the next slide, is I think the weight of your clinical, clinical, like clinical evaluations is going to be what's really important. We'll talk about that. So I looked at the chat and I realized I shouldn't be looking at the chat. Yeah, so I think there was a comment about thresholds. And so, honestly, I don't know that I can tell you what the threshold is nationally. I haven't talked to other program directors to tell you that I know of a threshold. Like I said, we're not using a threshold here. So that's, I guess, the best information I can give you generally. I don't know, Laura and Basil, if you've heard anything about a number for step 2.
I've heard so many different numbers, so I really don't want to like cause anybody anxiety. And I to clarify, it's not a threshold. It's more like people are like, you're above a 240, you're good. I'm not going to look at you any different than somebody who's got a 270 if you have a 241. Other people have been like, be above a 250. So like it's hard to say when everybody has a really different number, but the consensus is it's not a cutoff score. It means like we will still look at your application. We're not using it as much as we used to.
There is a recent study that came out. Oh, sorry. I was just going to say there's a recent study that just came out that said, they interviewed PDs to see what was the most important thing. The number one thing is your letters of recommendation.
Yep.
So how you do on your rotation, the letter that you get is the number one thing they look at.
Yeah. And that's actually why I want to spend some time on this next slide about sub-Is and clinical letters and rotations, because I think that is really it is really the biggest thing. So again, when you're asking how we're looking at application, remember we're looking at, last year we looked at 400 plus applications at University of Michigan, right? So everybody, in general, everyone they've done fine in medical school. They've done fine on their steps. Everyone has some interesting, groups that they've been part of. They've had a leadership thing and a club. So, if you look at that, a lot of that's all the same for everybody, right? It's, different flavors of it, but it's all about the same. So then the question that program directors are asking is, how do I know if this person is going to be a good fit in my program? Do I think they are going to be a good clinical resident? Are they going to be a good surgeon, right? Like those are the questions we're trying to answer when we look at your application. And so that's why the clinical letters of recommendation mean so much, because if I don't know you, I don't know how you perform in the office setting. I don't know how you perform in the OR. So I'm going to take the weight of someone who observed you in that setting and say, okay, yeah, this seems like somebody who would be a good fit into my program. So I think, getting a good letter that really that can attest to your clinical performance and your potential as a surgeon is really helpful. So the question always comes up, how many sub-Is? So I would say, in my view, I would say 2 is what we generally recommend. It seems like people are often doing 2 to 3. I think you should consider one of your sub-Is being at your home program or at least close to home if you don't have a home program. So pick something close by, and then at least 1 or 2 away at other locations. I'm gonna also, I'm putting up here geographic location, and I think this is something, it's always hard to know like how much weight different places put in this, but I think that if you are really interested in being in California and you're in school in the Midwest, like it probably makes sense to do an away in California, because then you get to know some of the programs there, you get to meet some people, and you get to say like, hey, yeah, I might be interested in living out here. If you do all your rotations in the Midwest and you want to match in California, like it's just going to be harder to do that, right? So I think you have to think about that a little bit in terms of, are there certain geographic areas that you would like to be? I do think that's important. I also think when you're thinking about a sub-I, if there's a program you're really interested in, I would suggest trying to do a sub-I there. Like if you think that's somewhere you want to go, remember that a sub-I, as much as it's an audition for you, it's also a chance for the program to sell themselves to you. And I think that's an important thing to keep in mind when you're matching, because we're all so nervous, like, I just really want to match, but the program also should sell themselves. If you go there and you hate your experience there, do you really want to be a resident there for 5 years? Like, so I think it's actually, it is really nice to go to a program because you're interested in it. I'll give you guys one little anecdote. I'm not going to name any programs, but I did an away at a place, and I will tell you, I had some faculty that were not very kind, and there was a person in particular who was extremely racist and misogynistic and made a lot of terrible comments to medical students. And I remember being like, gosh, if this is the person I have to learn from, like, do I want to be in this person's OR every day? And it really colored my my opinion of that program. And so I think those are, it's important to remember that the program is also for you, that sub-I is for you as well. Okay. So I'm going to stop there for a second and maybe let Laura and Basil comment on sub-Is and what you guys have been seeing on the trail so far.
I don't have much to add. I am a person who's doing 3 aways, and unless you're a DO student or don't have a home program, I personally would actually advise against it now that I'm in the throes of how much like time that will take in terms of like your electives. The finances of it is pretty significant. I had a really good reason for why I wanted to do 3. There was, just personal stuff. There was like an area I absolutely needed to do an away at for my own reasons. But I think, 2 is probably the safer bet. And an M4 last year had told me that, and I didn't listen. So I'm now passing that knowledge on to the next generation. Really do 2, unless you have a very, very specific reason, or you don't have a home program, or you're a DO student.
Yeah, and adding on to that, I'm doing 2. And one thing I've realized, I've just done my home rotation at Michigan so far, but I found it's really helpful is trying to get a hold of someone that's done the sub-I before, or a resident, to kind of learn more and know what to expect. That could be really helpful. Even going out of town, knowing where to live, like where's a safe spot, how do you transport to the hospital, and then knowing kind of expectations. I know a lot of sub-Is will have like a presentation or something, and in the midst of a sub-I, when you're really busy, it could be hard preparing for something like that. So it could be helpful getting your personal statement ready if they want that, or a presentation, so you're not really stressed leading up to those weeks in your sub-I.
There's a question in the chat. It says, do we need letters from both sub-Is? I'm doing one in August and one in September. I want a letter from both, but I don't know if the September date is too late. Does it look bad not to get a letter?
So I will say, if you do an earlier sub-I, it does look bad if you don't have a letter from the sub-I, because we're kind of like, well, why didn't they write you a letter? The September one, I think, is tricky, because I think that we would understand why you didn't get a letter from the September one, particularly with timing, if they're not able to do it. So I think that could potentially be okay depending on the program. And I think, if someone asked you, you could always mention it. So I think that's fine, as long as you have a letter from your first August sub-I. And I want to just make a comment about the letters and ways that I would think about, being successful about getting a good letter. So most of the letters are written sort of as a committee, or written by the program director and maybe the associate program director, and signed by the chair. Sometimes the chair is involved in writing them as well. But think about who those people are. And I would try to spend time with those people on your sub-I, right? So I would say you should go to clinic with those people at least once during your sub-I. Clinic is the best place to get one-on-one interaction, and for that person to kind of get to know you and be able to, see how you perform clinically. So I would definitely do that. I think that helps us write a better letter, because we've actually observed you. And I would advocate clinic over the OR. The OR is fine, but clinic is really where we get a chance to see your skills as a medical student. And then I would also, talk with the residents about what would be the best ways to kind of showcase your clinical experience. So ask them who are people you should spend time with in clinic or in the OR that might be instrumental in giving feedback for your letter. And then the last point I would make about the letters is that we do ask, most places ask the residents for feedback about how you performed and how you did on your sub-I, because again, we're trying to comment on how you are going to be as a resident and are you someone we want to work with. And so resident feedback is important. So remember that on your way, that the residents also do have a say. And so you want to, you know, be a good team member and, you know, get to know them as well.
One comment that came out of our in-person group is that you should start, when you first start your rotation, like set up through the admin, like a meeting with the person you're trying to get the letter from, 5 minutes to introduce yourself, say who you are. And then before the end, you know, make sure you work with them also, but before you end, and when they're getting ready to write your letter, have a list of kind of accomplishments or things that you did during the rotation that stood out. Like, you know, you personally helped a patient do this task or something like that. So if you can come up with those things, it makes the letter writer have a better flavor when they write that letter. So it's more personal and not just kind of generic. There's a question in the chat. How many letters of recommendation can we submit? Can we submit more than the required amount?
I don't think you can. I think you can only submit the required amount. I don't know if anyone else knows any differently. I guess at least all the ones I looked at last year were the required. I don't remember anyone having more than the required amount.
Is the required amount 2 or 3? I mean, 3 or 4?
I think it's 3.
Yeah, it's 3 required, 4 is the maximum.
Yeah. So I guess I should say no one had more than the maximum that ERAS allows. I guess that's what this, so let me correct myself. No one had more than the maximum. And I would say I probably saw 50-50 applications with 3 versus 4 letters. Sorry,
Someone has a question in the chat. At my school, our M3 clinical obligations end later this summer, so I will not be able to do aways until September, October. How would you recommend navigating a letter of recommendation from September away, especially when it's so close to the due date?
So for this person, are you doing anything in your home institution?
Yes, so my school year ends towards July, and then I'm doing my sub-I at my institution end of July through August.
So I think that sub-I letter from your institution is going to be the most important. You know, obviously you won't be able to do one for October, and then the September one again is tricky, right? So I would say make sure you have a good letter from your home institution.
Thank you.
Someone
If you're
has
planning,
Go
sorry.
ahead. Go ahead.
If you're planning on using a September letter, does that mean you originally just like upload 3 letters to your application and then on like the back half do the 4th?
Yeah.
Is that
Exactly.
okay? Thank you.
Someone asked.
Yeah, and you can always
do you have
add
a
that,
preference?
you know, yeah.
Do you have a preference, 3 or 4?
I would say it depends on the quality of the letter, because if I get 4 letters that are very lukewarm, I'd rather have 3 really good letters than 4 lukewarm letters. So if that 4th letter is just going to say, yeah, we met this person, they were nice, like, you know, because you can read between the lines. Sometimes that's what a letter says. It's really not that helpful. So I'd almost err on not having that letter.
Someone asked, when we're looking for the potential letter writer during our sub-I, what are the titles, quote unquote, we are looking for?
So it's usually the residency program director or the associate program director and the chair. It's usually from those 3 people. And you can ask the residents if there's anyone else involved, or if someone else is responsible for them, but most of the time it's those people. Oh, I guess I will add one thing. I have had in some of the applications where someone got the sub-I letter, which is written, you know, like I said, the president, written by the program director and the chair, but there's been some people have had a second letter written by a faculty member that maybe they really got to know on the sub-I, and then there were a few situations where someone had done research with somebody and then like really got to know them on the sub-I some more, or kind of formed a really good relationship with them and had an additional letter from the sub-I from a specific faculty member. So that is something you could consider too. If you really click with somebody and have, get a lot of great advice or mentorship from them, you could consider having them write you a letter as well. Should we go to the raised hands, Dr. Go? So Susanna, I see you first.
Hi, my question kind of jumps back to sub-Is and VSLO. So if anyone else has more questions about letters, I'm happy to have them ask the questions while we're still on the topic.
We can continue. We'll consider it sub-Is letters. It's all the same.
Okay. I kind of similar to, I think Abby was saying her school goes kind of late into August. So I have a similar situation. And so I feel like a lot of students are going to try to apply for VSLO to get a rotation for the August, September timeframe. Are there any recommendations on how to be successful with VSLO to get matched into doing an away rotation during that time? Just I'm imagining, especially with the accelerated timeline of urology applications, everyone's kind of be aiming for that time frame.
So I don't know if I have any great suggestions for how to game it. I mean, the one thing I would say is that if there's somewhere you really want to go, I would get your application in early for on VSLO, like right when that place opens up their applications. Because we do, so for example, here we did review them in a rolling fashion, like we scored everybody, like each week we were scoring them because otherwise it's a lot to review at one time. And then, but we didn't put our list together of offers till after we had reviewed all of the applications. So I guess that's where I would say, getting it in early and then, submitting your preference for when you want to do your rotation. Laura, Basil, I don't know if you guys have comments on that part of it.
Yeah, I had a place that I really wanted to go to and had like very similar fears of you. I was like, everybody's going to want to go those 2 months. I think in VSLO, you can do it to where you can like have like a little short bio, or some places like will require a personal statement. When you're given that opportunity, so what I did is like I applied to each individually, like meaning like I wanted, let's say I'm applying to UM, like I applied to UM only so that I could make a personalized short bio on that away rotation. And I like had very specific reasons for why I was interested in that program. Like you do this type of work with this person matches my interest in this area. So rather than just being like, oh, you're a great program, I'd love to come see what it's all about, like you're showing that you've taken that just like little extra step of knowing exactly why you would go there and why you'd be a great fit. And I think that goes a long way in urology.
That is super helpful.
Sorry, go ahead.
I saw in my experience, some programs will have a little bit more information on VSLO, while some will have more information on their website. So kind of being aware that to kind of look at as many resources as you can for how they kind of divide up your tasks.
Yeah, and I would echo what Laura said. I forgot about that part of it. That I do think the personalized letter, it certainly does help us because we're like, oh yeah, this person is really interested for a good reason and they want to come here and they have a more compelling reason. I do think that's helpful. I will warn you, make sure that you put it to the right program, because I certainly got some personal statements that were for other programs, not for University of Michigan. And then we, I'm sorry to say, didn't offer those people in a way here because we also needed some way to screen. And so, that's a little detail, and I'm sure it was a mistake on their part, but something obviously that you should think about.
BB has her hand up.
Hi, just a quick question about letters of recommendation. So next April, I'll be doing an elective rotation at a program that I'm interested in. And since it is April, it's my last rotation of the year. So I feel like I should have decent clinical abilities. So my question is, does it make sense for me to get the letter from them during that elective rotation, or should I come back? Well, I do want to go back as a sub-I. Should I get the letter during the sub-I? Because in my mind, I'm like, it might make more sense for me to get the letter in April. That way I can do a sub-I with them a little later on, past like the deadline for me to submit the letter of recommendation.
I think that's great. I think I would say that's totally fine. Just figure out what works for you. I think if you're going to do your sub-I early there, then wait and get your letter then. But if you want to do it that way so that you could do a different sub-I somewhere else, then I would just get the letter during the elective. I think that's fine.
Perfect. Thank you.
There's a question in the chat. But I need clarification. When we are trying to identify potential letter writers, what titles are we looking for?
That question's been answered already.
Oh, okay, sorry.
Problem.
Oh, no, there's another one. For DO students, would it be better to focus away rotations at programs that accepted DO students in the past, or a geographic location you prefer, but the program has not accepted DO students before?
That's a tricky one. I don't know if I have the right answer for, I don't know the answer to that. You know, I think, I certainly programs that have taken DO residents, I think obviously they're, you know, that they're less biased about applications and you know that they're friendly to that idea. So it's certainly a good thing, and probably helpful for you. I guess my bias, and you know, we have DO residents at Michigan. So I guess, you know, I feel like we are not biased about it. And I guess what I would say is, to me, I think if you come in and you do an amazing job on your sub-I, you know, even in a program that hasn't taken somebody before, I would think that they would say, gosh, this person was amazing. We'd really like them to be in our program. So I guess that's what I would like to think most programs would do in that situation. So I would say maybe not to limit yourself, but if you're doing more than one sub-I, maybe the best way to game it might be to do one program that has taken DO students and one, you know, maybe one that hasn't, you know. I don't know if anyone else has any comments about that.
Gina DeMeo is was a successful DO applicant in the last cycle, and that's actually something that exactly what she did. So I can't speak to the DO experience, but she did away rotations at places that took DO students, but she also had a preference for staying in the Northeast, so she also did that. So like a little bit of both.
Okay, I see Hannah with her hand raised.
Hi. So as someone who doesn't have a urology home program, one of the intimidating things for sub-Is is that my observership experiences in urology exceed my hands-on clinical experience. Do you have any advice on like how to navigate that and how to just try to be as successful as people like me can be on sub-Is?
So, you know, even though you haven't had hands-on experience in urology, I hope you've had at least some hands-on experience in surgery, right? So I would say that work on your basic suturing and knot tying skills. Those are things that are always good to be able to demonstrate that you can do from a hands-on perspective, you know. So when you're given the opportunity of like, hey, would you like to close skin, if you know how to do that and, you know, are pretty proficient with knot tying, like those are things people are going to see that you can do. So I think that's something you can work on no matter what. In terms of other hands-on things, you know, I guess I would say, I don't know, Laura, maybe you and Basil can comment too. My feeling is there are people who have a good OR sense, and you can get that no matter what, you know, and I think part of it is just getting a sense of like, where do I fit in the OR? How can I be helpful? Like I can help clean up the patient. I can grab the bed, you know, showing that you're engaged in what's happening in the operating room, reading about the procedures. Yeah, I don't think you need to necessarily have had a lot of hands-on experience to be able to do well from that standpoint. I think you can also make up for it by reading. So, you know, when you go to clinics on your sub-I, like read about the topic of whoever's clinic you're going to, right? Whatever their specialty is, like make sure you read some things, you know, if you're coming to my clinic, I would expect that you would read some things about incontinence and OAB and, you know, have at least a general, you know, basic fund of knowledge. We don't expect you to know advanced things, but a basic fund of knowledge. And those are things you can do no matter what. From a clinical standpoint on the rotations, you know, I think, again, just being able to show that you can be a good resident. So, you know, having a patient you take ownership of, following up on that patient, you know, knowing their history and their information in the morning, like knowing their numbers, knowing what's happened to them. Those are things you would do on any rotation, but just doing the same thing on your urology rotation. You know, we don't necessarily expect you to know how to put in like Foley catheters and put a cystoscope together. Like that's what your residency's for. You're going to learn all those things later. So I think it's more just a general how you behave clinically, you know.
There's a question in the chat. Can you provide examples of how previous students positively or negatively stood out in their sub-Is in your experience?
Sure. So I think positively, I would say, you know, people who have come to my clinic and I can tell they've read, that they've read a little bit about the topics. I think some of the sub-Is have really stood out to me. They've prepped my clinic, so they've actually looked at the new patients and read a little bit about them ahead of time. And so, you know, most of the time when you go to a clinic, the faculty is going to ask you to see the new patient, because that's usually the most valuable for you, because you can take a full history and then present a full history rather than like a return visit patient. And so if you're going to go spend time in someone's clinic, that's a pretty easy thing that you could look at 5 or 6 new patients that they have that day and have read about them ahead of time. It'll show that you've got some basic knowledge. So that always stands out to me when people have prepared. I think in the operating room, when I see that people are just being helpful, they're helping the residents, they're helping the staff. I pay attention to how you interact with, you know, the support staff, both in the clinic and in the OR. You know, are you friendly and, you know, kind to the nurses and the MAs? And, you know, that's important to me when I think about the kind of person I want to be a resident. So those things certainly stand out, because students who are that way, I'll have my nurses say to me later, like, oh, that was a really great medical student who was here today. Like, they were so, you know, sometimes they were helping the nurses out, or they were just like very helpful. And when I say, what could you, so let me be more specific even about that. Like, you know, they help clean up in the room. So like they throw things away, like rather than leaving everything out on, you know, the table and stuff. Or they ask if the nurses are coming in to do a procedure, sometimes they'll ask like if they can help, or maybe they can help do the catheter or whatever, you know, like those are ways you can be involved, I think, as a student. And then I guess negatively, things that have stood out to me. So on that flip side, there were people who came where I really felt like they had not read anything. Like they were asking me basic questions of, you know, I mean, like very basic about, you know, just even how to take a history and when it came to incontinence. And, you know, those are things as a sub I would expect that you'd at least be able to ask some good questions about, you know, urinary symptoms. So that certainly stood out to me negatively. I think the other big negative I would get from sub-Is is if we hear from the residents that they felt that the sub-I just really wasn't helpful to them, wasn't participating in like team rounds and taking ownership of patients and presentations, and that goes a long way for us. Or if I hear that someone was really rude to our staff. So here's another example, specific one, where someone was very rude to our admin who helps coordinate interviews or coordinates like your application process. You know, we're going to hear about that. And that's, you know, that stands out to us. We're like, those are people that are part of our team. And so if you're negative to people that are part of our team, then that's not somebody we want here, you know? So those are some specific examples, I think. Is that helpful? Hopefully.
And someone had mentioned previously, like having things like when you're on rounds and you're with the residents that have supplies needed for like dressing changes. If that's a patient that you're following, it's yours. Make sure you have stuff available. Like if you know the Foley's going to come out tomorrow, have the syringe ready in your pocket so that no one's searching around for it. Those are kind of helpful things to make the teamwork better. And that's what they're looking for is, are you a team player? The question, what learning prep resources would you recommend to students before starting a sub-I? And I know some people put some nice things in the chat, especially for students who don't have a home program. So their sub-I is their first formal urology exposure.
Yeah, so I'm just going to look really quick at what people put in here. So yeah, I think all of these are really great. I was going to suggest a student curriculum. I think the, you know, WEDR, the like 5-minute urology consults are good. I think the AUA core curriculum is really good. Yes, and I agree. The NCCN guidelines, if you're going to go to an oncology clinic, those are good to look at, and all of, you know, all of that. And actually, you can look at AUA guidelines as well. Like, you know, there's basic guidelines for how you treat BPH, how you treat OAB, how you treat recurrent UTIs, like those are all out there and those are pretty digestible. Okay, Namrata, you had a question?
I just wanted to follow up on those resources. So what would you recommend for surgery specifically in terms of like clinic medicine, just so you can brush up on procedures before? Usually I use PubMed and I'm sitting there like Googling, trying to find some paper on procedural steps, but do you have any resources you recommend?
Yeah, so let's see. Hinman's, yep, Hinman's Atlas of Surgery is really good. There's a Cleveland Clinic Urology, at least I remember I use that one. There's, I think it's like it's Cleveland Clinic Urology, something like that. I can't remember. Urology procedures. I don't remember the exact name. Yeah, Hinman's I think is really good too. And then the AUA, I don't know, Dr. Go, do you know, do they have access to some of the videos through the AUA? Through the
do, and someone just put what I was going to say, YouTube.
Yeah.
A lot of people have been watching YouTube videos and they do it at like twice speed to see the steps.
Also, I just like to add, someone had mentioned that it's also good to read the surgeon's operative note. So like when you're there, you kind of are able to follow when you're in the OR. So in addition to the YouTube, that might be helpful.
Yeah, that's great. That's a great point. I was actually thinking about that as well, as you could look for an previous operative note of that surgeon, you know. So I had put, well, so we kind of got into this already, but I did put a slide up here about no research and no match. And, you know, I guess I wanted, and we sort of already made this point, but I think I wanted to make this point again, that research in some fashion is important. And most programs view that as something that's peer reviewed. So, you know, again, it doesn't need to be a lot, but there should be some engagement with research. And that's kind of all I'll say about it, because we already talked about that some.
Yeah, someone wrote, look at the dot phrase in Epic, and someone else had mentioned that before too.
Oh, and then I guess the other thing I put up here, these are all the slides I have, but I did just want to put this up about, I did want to get to the financing before we run out of time too. So Laura, I think you mentioned this already, but you know, it is obviously it's expensive to do sub-Is, and that's where, you know, I think doing 3 or 4 sub-Is, like that's a lot of expense. You have to go live somewhere, you have to, you know, deal with all of that, the logistics. So some institutions do offer travel scholarships. They're not, most of them wouldn't usually cover your whole cost, but at least it might help offset some of it. So I would certainly look at whether those are available, and if so, you know, certainly apply for them. I will look at other organizations, see if your medical school offers anything, or if there are any other organizations in your area that might offer something. You also could look at alumni associations from your medical schools. So sometimes medical school alumni associations will either offer travel grants, or they'll even offer a list of alumni in areas that might be willing to house a student doing a sub-I. Like those are options sometimes. So I don't know, those are all, I just wanted to kind of put those out there as things to consider. And then Laura and Basil, I don't know if you want to mention if there's other resources you've heard about.
I didn't. What I ended up doing was I actually applied for funding for my research, and then I'm using that money on the research that I was going to do anyway to put towards away rotation. So I thought that, and then I'm using credit cards, but there's, yeah, it's not a great system as it's set up right now.
Same exact thing here.
Yeah, and I've heard credit cards or loans a lot too, so.
You might want to look, especially if you qualify as a URIM, at specific institutions that have grants. I'm not going to say that they're perfect. Like, for example, we do through OHE, the Office of Health Equity and Inclusion. What's frustrating is that amount has not changed despite things getting more expensive. So sometimes that can be a little bit of a struggle. a lot of the folks that had talked earlier this week to us were saying that they tried to go to places where they had friends and family, kind of rely on that, because then your housing is a lot cheaper. Some people didn't rent cars. I think Charlie, who's going to be I think he's coming in the next section. He rented Lime scooters, and if you have Lime Prime, you get the first month for free. So he just used it for a month, and then basically like it was free. So that's how he got around. Some other people used e-bikes instead of cars to save money. So that were some interesting options to help defray the cost. But yes, it is expensive.
Yeah, and I was gonna say, yeah, friends or family or like other people from your school who maybe have gone somewhere. Like I slept on the couch on a friend from med school who was like 3 years ahead of me doing residency at, you know, one of the places I did a sub-I at, and I slept on her couch for a month, and she was very kind to let me do that. But, you know, certainly looking into, I mean, a lot of people have been there before, so seeing if those options are available, trying to use the network as much as you can. Certainly a good thing to think about. And then I also would say, I don't know how much you all did this, but certainly you can ask residents or other people that have done sub-Is at that place, maybe where they stayed, or if they know of any resources, because sometimes those are good people that can help you try to navigate things or tell you what location you should stay in so that you maybe don't need a car and you could walk or take public transport to get to the hospital, those kinds of things. Are there, let's see, other questions? I think we still have a little time. So let's see, we've got a couple of things in the chat, some websites for finding housing, rotating rooms, credit card training. Oh yes, Facebook Marketplace, that's good too. Great, excellent resources. Other questions or thoughts? So those are the end of the slides I prepared, but we certainly have some time for more questions or discussion on any of the topics that we touched on, or other topics or burning questions that you may have.
I have a question that goes way back to the beginning to our timeline section, if that's okay. I think Laura had mentioned that the urology match process was pretty organized with set dates on when they release things. I was wondering if all applicants had to accept their offers at a certain date. I know there's something called flush day, so I don't know if that's related, but if someone could just speak a little bit more about that process.
Laura,
Sure, I can clarify. I like don't have like the specifics down, but basically my understanding of it is like you find out, let's say on a Thursday, basically where everyone who gave you an interview offer, that Monday you have the weekend to kind of figure out, because the problem that's going to happen is if you get several interviews on the same days, you can't do it. So you're going to have to think through which one you want to pick. So that Monday you basically tell everybody who offered you an interview, yes, or can you give me a different date, which really usually means like wait list. Can you put me on the wait list? And then you have that wash day, I think two days later, where people get moved on the wait list, things get reshuffled around. So yeah, you tell everybody kind of at the same time.
Thank you. Is there any benefit to like responding to those sooner? Like, do you ever feel pressured, like you have to respond right away or also get lost?
No, that's actually why so that's how like everybody else does it, where you basically have to be next to your phone, and if you respond sooner, then you get the date that you want. And that's why this system came up into play. So you get, 3-4 days to like strategize, think about who you're going to say yes to no to. And then as long as it's in by a certain time, and then I think it gets all released to all the programs at the same time. So
thank you.
It's much better than when I went through and you sat by and had to like choose your day. Like Laura said, you were sitting by your phone to get the date you wanted.
looks like we have some questions in the chat on personal statements, Dr. Gupta.
Okay.
someone asked, can you speak about how to approach personal statements? And then someone asked a very similar question. Do you have any thoughts on which types of experiences and qualities we should focus on or ones that we shouldn't?
Yeah, so, personal statements are always hard, right? Like it's always this question of, how do I display myself? And, so the number one thing, I guess number one, I would say to be authentic in your personal statement, because you certainly, what I would say to avoid is you don't want to write about things because you think it's going to sound good, but that aren't true to you. Because you can tell when you read an application, or say you do get the interview, people ask you something from that personal statement and it's not authentic to you, it's just not going to go over well. So that's my number one thing, is I would say write it in a way that's true to you. I think that I've read all the different, there's so many different types of personal statements. There's there's this, that you had a significant medical experience in your family or personally, and that kind of influence you. I think those things always certainly tell a story of your journey and why urology might be of interest to you. So, that's certainly one way that I think a lot of people go. I think some people talk about an experience that they had in urology that really kind of started their love of it and why they chose to do it. I think one of the personal statements that some of the ones that have stood out to me are ones where people have talked about, so like one that stood out, I'll give an example of one that stood out from last cycle, was somebody talked about cooking and how they had this kind of just significant love for cooking, but how cooking and elements of cooking related to the way they approach medicine and the way they approach surgery, and how there's like a precision to the way they cook and how that, related to surgical abilities. And it just kind of stood out to me as something that I was like, oh, wow, that's really great. They really kind of thought about what it takes to be a surgeon, and it was an interesting hobby. So that was one that was certainly, I thought, nice to read and stood out. But I guess what I would say in general is most personal statements that I read, I feel like I read it and I say, okay, yep, this seems like someone who's really interested in urology. They seem like a good person. I don't see any red flags, like this person seems to be unkind or not caring. And those are things that I'm like, okay, great. This might be somebody I might want to interview. I guess that's kind of, I would say that you don't want your personal statement to have anything controversial in it that might upset people. I think you also want to be sure that it reflects you. And then I guess other things to stay away from are, anything that you can't talk about, like don't make something up. And then I would also say, I think someone brought this up in a different part, that talking about weaknesses. So I think it's fine to talk about weaknesses in a personal statement if you can bring it in full circle to say how you've either overcome something or how you use that weakness in a positive way. I think that's something that's important. One other part of personal statements, if you've had a large gap somewhere because of either, personal issues or other things, some people have brought that up in their personal statement and used it as a vehicle to explain how they went on their urology journey. And I think sometimes that can be a good thing to do as well. So I'll stop there.
So someone in another session said, spell check, make many people read it, your family, your friends, your mentors, they help you kind of shape it. And I don't know if Laura or Basil have any other comments about who they asked to read it, but that helps.
Yes. Yeah, spell check and reading, and I would write it and I would walk away from it and I would come back to it a few days later and read it, because sometimes you need a clear head as you look at it, and that's important.
There's a question in the chat. I know this is applicant dependent a bit, but how many programs would you suggest to applying?
Oh, that was such a hard question. So we had to talk about this a little bit last night, and I think it seems like the average number is maybe like 20 to 40 programs. Would you agree with that, Laura and Basil, or is it more? I
think it's much more.
Is it much more? Okay.
Yeah. I think it's totally, I think 80 to 100, I think like 60 is the sweet spot. There's a paper out there somewhere that basically shows like at some point, like the number that you apply to doesn't increase your chance of matching. And I think that's why that 60 number is like drilled into my head personally.
Yeah, I mean, you'll hear from, I know some of the other students last night were talking about, there's some people who applied to a ton of programs and some people who applied to like 20 programs and still matched, right? So I do think there is some variance in numbers as well, but it seems like people applied to a lot, I guess. So sorry, I was grossly underestimating. People apply to a lot of programs.
Yeah, someone's got 880 to 100. And then there's a question for interview invitees. Is there a specific time or still full day now that they're virtual?
Sorry, I'm not sure that I understand a specific time of day or.
I think if Brittany wants to chime in.
Yes, I was asking about if there was a specific time that the interview occurring.
So I would say most places are going to expect you to have the full day because usually people have like a some sort of a social hour that's either the night before or the night of your interview day, and then there's usually interviews with multiple faculty plus like sessions about the place, about the program that you would attend as well. So I would say you should be viewing it as a day.
We had in a previous group someone who had stacked a institution in the morning and a second institution in the afternoon. It's doable, but they really don't recommend it. It like just fries you. So it's hard to be the best for both because you're just exhausted. Devante has your
I have
your hand up.
Oh, hi, sorry. I just have a question regarding sort of like interviews. You mentioned some sub-Is will have interviews at the end. How does that sort of work? Because from my understanding, just from talking with our department, we have a lot of people applying urology. And so they're like, we're doing sub-I interviews too. But like, it's difficult to sort of set up a day because everyone's so busy. It's not really blocked off for like faculty to have that day off. How is sort of like Michigan doing that if they are doing sub-Is, and how are other programs doing it?
Yeah, so I guess I don't know how other programs are doing it, but when we do our sub-I interviews, it's something that gets set up. There's, a few people that you meet with, includes like the chair, myself, our associate program directors, a few other people on the interview committee, and they usually get set up kind of throughout your rotation. Sometimes I know our admin tries to group at least some of them for you as much as possible, but again, because of everyone's schedules, like you mentioned, they're not always on the same day. So and again, we as faculty know, like, sub-Is will say, I have to leave for my interview with so-and-so. And I'm like, that's fine,
Thank you.
Mm-hmm.
And then in the chat, would anyone be comfortable sharing how much it costs to apply to so many programs, or would they recommend budgeting for interviews / applications in general?
Maybe I'll let Laura Basil comment since you're going through
Yeah,
it.
I just put in the chat the application fee calculator. I personally tucked away just like $2,500. Wasn't really I'm not really sure how much it'll actually cost, but I felt like that was like a good amount to be like, that will cover however many I want to apply to. I think it might be less than that though.
And hopefully now with most interviews being virtual, which I think the AUA still or the Society of Academic Urologists has to put out their final recommendation for this year. I think it's going to come out in the next week or two, but I'm assuming it's going to stay virtual. So that hopefully will save costs for, at least for interviews.
Okay, with that, I'm gonna unfortunately have to close the rooms. Waiting for everyone to come out of the other group.
Recording in progress.
Okay, I think we have everyone out of the breakout rooms. Just going to double check one more time. Yeah, okay. All right. Let me just make sure we have everyone else. All right, everybody. Welcome back from your groups. It's my pleasure to invite Effie Chantel Ghanney Simmons to speak today. She has done tremendous research in how URIM students match in urology. She started at Yale for her undergrad degree and went to medical school at Icahn School of Medicine at Mount Sinai and was most recently in at UCLA for her residency. She's now joining us at the University of Michigan for her FPRMS fellowship, and she's been asking these hard questions for quite some time now. Go ahead and take the stage.
All right. Thank you so much, Dr. Go, for that very kind introduction. I'm actually going to set a timer for myself so I don't go over time. So let's do that over here. Hi, everyone. My name is Effie Chantel Ghanney Simmons. It's a mouthful, but I go by Chantel, so you can refer to me as such. I am a current UCLA resident. Will be graduating in about 21 days and be joining the University of Michigan family. So I was asked to talk to you about the urology match, and I've done a lot of exploration specifically looking at the data behind the match. So I decided to entitle today's talk as Demystifying the Urology Match for the Underrepresented in Medicine Applicant. I'd like to start off with a quote. Data never speak for themselves. It is the questions we posed and those we fail to ask, as well as our theories and concepts and ideas that bring a narrative and meaning to all these statistical models. So what I mean the reason why I chose to present this is if we don't ask questions, we won't get the answers. And so hopefully this presentation will lend itself to that concept. Now, let's see here. So in terms of disclosures, I have some atypical disclosures to share with you today. So historically, we've worked under the pretext that researchers were void of bias and are observing phenomena as neutral beings. This is the concept of objectivity. This view allows us to ignore our bias and our effect on study participants and outcomes. This speaks to the concept of individualism. However, researchers are predictive variables, so I choose to name all the ways that my very being and my identity as a minority, as an immigrant, as a Black woman, with its privileges and disadvantages, as well as its motivations and experiences, may influence this work so I can account for them, and so others may hold me accountable in order not to interfere with the integrity of the work. Now, people of color are not a monolith, and I do not know all things about the experiences of others. So I want to be mindful of my own projections so I don't make assumptions about others as we move along. So very briefly, I'm going to give you some background, and then I'm going to go over 3 studies that I think are relevant to you all today. So the work that I'm about to present to you is part of a larger collection of projects, and they're entitled The Equity, Diversity, Inclusion in the Urology Workforce Strengthening the Pipeline. The educational pipeline for academic urologists is defined as progressively diminishing cohorts, starting with the US population, leading to medical school application, acceptance and graduation, through to urology residency application, specialty matching, and eventually residency graduation with the hope of potentially ending up as urology faculty in a urology faculty appointment position. Now, we recognize that there are many sub-steps that occur prior to applying to medical school. However, for the sake of scope, we limited our pipeline discussions to what you see here on your screen. The yellow box highlights the stages that may be most relevant to our audience today. So that's what we're going to zoom in on. So I am interested in examining barriers to access into medicine, specifically for individuals who identify as underrepresented in medicine. So that historically has been the 4 groups that I've listed on the graph above. But for the sake of just brevity, we'll be focusing on those who identify as Black or African American, and I'll be referring to them as Black moving forward, or Latinx or Hispanic, and I'll be referring to them as Latinx. So anything that you see in pink in any graphs that we see moving forward would be representing the Black cohort. Anything that we see in blue would be representing the Latinx cohort. So I keep that consistent so there's no confusion. And as you look across the spectrum, starting from the US population, I actually include here high school graduates as well as college matriculants and so on and so forth, you will notice that there is a decrease in representation of people who identify as Black and people who identify as Latinx across the pipeline. So by the time you get to urology faculty, even though we started off with a US population that consisted of 12.2% Black individuals and 19.2% of Latinx individuals, by the time we get to urology faculty, we're looking at about just above 3% for both cohorts. Now, this holds true over time. So here we're looking at data from 2007 all the way to 2019, and we're looking at the applicant pool, the resident pool, and faculty pool for urology. And really, there's no change. You notice that the slope for all these graphs are flat, showing that over time, we're really not seeing any increase in diversity, at least up until the 2019 period. Now, a problem that is not acknowledged is a problem that is destined to remain unsolved. When we look at the urology match data, when it's broadcasted to us year after year, there is intentionality in demonstrating the outcomes for gender, but we haven't quite gotten to the point where we are also putting out the data for underrepresented individuals, which means we're less likely to solve the underrepresentation issue. So we're going to dive in, looking at, most of you, I'm assuming, are urology residency applicants or hopeful urology residency applicants. And there are certain steps that are going to be required of you before you get to the urology resident position. You need to be offered some interviews. Well, you need to apply first, and then you need to be offered some interviews. You need to actually go for those interviews. And as have already been discussed, you're likely going to have to forego some interviews. So there is a funneling there. Then you need to be ranked to match. And I'll be defining that down the line. And then eventually you need to match successfully in order for you to become a resident. However, there's so many different factors that affect your ability to transition through this continuum. So we have your reviewer factors. So things like how diverse are the individuals who are actually looking at the application? Do they have any cultural or structural competency training? We have urology application process itself. And I heard some individuals in the breakout room talking about things like the cost of application that could determine how many applications you're able to even put in. Things like USMLE step score cutoffs, which, as you all know, is currently in flux with step 1 becoming pass-fail. Experiences of individuals who identify as underrepresented in medicine. So we have things like microaggressions and stereotype threat, tokenism, imposter syndrome, and this idea of homophily, which is defined as like sticking with like to the exclusion of others. So do you get invited to, I don't know, the golf game with a program director where you might have discussions about research projects that you could be a part of. And if you don't get invited and you don't go, but everyone else does, you might not get that research project, which eventually might help bolster your application. So that's just an example. Selection criteria and things like AOA status, class rank, research publications, letters of recommendations, and then resources that are made available to applicants. And I really speak highly of the organization Urology Unbound, because it really has created a space for you to go and tap into those resources. So here, very briefly, I just wanted to highlight, speaking of resources, a lack of resources for individuals who identify as underrepresented in medicine. If you take the top 20 institutions with respect to the proportion of underrepresented in medicine individuals at these institutions. So which top 20 institutions have the most people of color, essentially, graduating? And I include Puerto Rico since it's a territory. Now, of those top 20 institutions, only 10 of them have residency programs. Only 7 of them have urology interest groups. Now, think about how you get access to research, how you get mentors. If you don't have proximity to an interest group or a residency program, it makes the application process quite challenging. And for context, there are 145 urology residency programs and 155 medical schools. That means the 10 medical schools that don't have residency programs are most likely in this table that I'm showing you here. So I mentioned that our collection of research projects had this overarching goal of looking at barriers to access into advancement in medicine and barriers to access into urology. And we have 6 main aims, but for the purposes of this talk today, we're specifically focusing on critically appraising the urology match process. How we did this was manyfold, but the ones that we're going to focus on is data that was acquired from the Society of Academic Urologists. They were kind enough to share some data with us for the match, as well as pooled data from 10 urology residency programs, and I'll get into that a little bit later. So this is what we're going to be talking about, the SAU data set. So they provided data for 3 consecutive years. Actually, they gave for 10 consecutive years. However, they had not collected race ethnicity data up until 2019. So in 2019, 2020, and 2021, those years, those race ethnicity data for applicants that were shared. And what we found was there was in that pool, there's a total of about 1,200 applicants. This is the racial breakdown of those 1,200 applicants from 2019 to 2021. In terms of those who were offered an interview, the median number of interviews that were offered, as you can see, is slightly lower for our Black and Latinx applicants compared to their peers. And then for those who were truly ranked to match, and what I mean by this is if they were ranked in the top 5 positions of any residency program. We chose the top 5 because the largest residency programs tend to have 5 spots available. So if you're ranked in the top 5, then it was really up to the applicants to choose accordingly in order for them to successfully match. And when you look at these numbers, we notice that the Black applicants actually had the highest rates of being truly ranked to match. In terms of being practically ranked to match, and this is being ranked anywhere from number 1 to the last matched individual. So it can be a little confusing, but if you think about it, it makes sense. If you're matched between if you're ranked, between 1 and the last matched person, then you were practically ranked to match. So if you're chosen well, quotes and quotes, then you would have been able to match at least 1 institution. And you'll notice that the Latinx applicants have the lowest percentage of being practically ranked to match. But when all is said and done, when it comes down to being successfully able to match, our Latinx peers, 75.3% of Latinx applicants are able to successfully match. So in summary, in summary, the URM applicants have fewer interviews. URM applicants are less likely to be practically matched. Black applicants, even though they're the most likely to be ranked in top 5 positions, they are not necessarily most likely to successfully match. And Latinx applicants are the least likely to be ranked in the top 5 positions and also the least likely to successfully match. So now taking a step back and looking at some of the characteristics of all these applicants who are captured in this pool, we saw the highest representation of women in the Black cohorts. So 46.6% of Black applicants were actually women. And you might say, gee, this is an indication of parity. It actually is not an indication of gender parity. It actually is, what it shows is this underrepresentation of Black men in medicine. And that's why it seems as if there is gender parity among the Black cohort. Latinx applicants were least likely to be a senior when applying. So if you look, only 58% of Latinx applicants were seniors when they were applying. And this has implications because those who are outside of the current medical school framework, if you're not currently in a medical school with an advisor and close proximity to your mentors, it may make applying into residency more challenging. Black students are less likely to be granted AOA status. Now, there's a whole bunch of literature that goes over race and ethnicity biases when it comes to selection into AOA, and there was a movement by lots of medical schools to actually stop awarding AOA for that reasons. But for what it's worth, Black applicants are less likely to have been awarded this status. URM applicants are less likely to be DO students. Now, there is a preconceived notion that URM applicants are more likely to be DO students, because when you hear the narrative around interventions to increase diversity, there's a lot of talk of let's make sure that we do work with DO students so that we can increase our URM applicant pool. But that's not necessarily the case, as this data shows. Now, interestingly enough, and because I mentioned to you earlier that the top 20 institutions with URM representation are less likely to have interest groups and less likely to have residency programs affiliated, when you actually take a step back and look at the entire applicant pool, there is no difference across race for whether an applicant attends a medical school without an affiliated residency program or without an affiliated urology interest group. Again, this is important because when we think about making interventions to diversify urology, a lot of people say, oh, if we should make sure we should ensure that there are interest groups at all medical schools so that we can increase diversity. Well, the data is actually showing that that may not be the most effective way to do so. It might be a way, but not the most effective. And then lastly here, I just show that when you look at the top 25 institutions in terms of NIH funding and also in terms of US News ranking, and again, this is not a perfect metric, but underrepresented in medicine applicants actually do pretty well in terms of representation at those institutions. And I think, again, there's a preconceived notion that people of color tend to go to certain institutions and not higher achieving institutions, and that is not necessarily the case. So things to think about as we craft interventions for diversity. Now, our findings so far have certain implications. They have implications for match equity. How are we going through this process with fairness? And they also have implications for recruitment, as I've already highlighted. What was interesting to me, or what I thought to pay close attention to, is this. When we look at the matched cohorts and we look at our unmatched individuals, when we look at URM and we look at non-URM individuals, do we have different standards for URMs versus non-URMs, or are URM applicants not as prepared for the application process? What I mean by prepared is, do they not have certain academic performance metrics, or do they not have certain guidance when it comes to actually getting through their application in order for them to successfully match? With the data that I've shown you so far, it's hard to tell because we don't have things like STEP scores or number of publications in that data pool. So I show you this again to remind you that there's so many different factors that could contribute to you successfully matching as a person of color or as an underrepresented individual applicant. And so our data just right now just shows us how you transition through the continuum and doesn't show you how these other factors come into play. So now, in order to address that, we move on to the second study, but I'll just briefly conclude in terms of the first study what we found so far. There is a discordance that exists between the likelihood of being truly ranked to match and of success of the urology match. These findings may suggest differences in the perceived competitiveness of urology applicants and/or differences in the evaluation of applicants of different races or ethnicities. So more work needs to be done in order to be able to create interventions, because the interventions we're currently creating are not necessarily targeted towards what the data is speaking to. So that in mind, we decided to proceed with study number 2. What we did was we reached out to various different residency programs across the country, 10 programs, and said, hey, you have access to the applications that came to you. If you could share that, if all 10 of our institutions could share that data into a pool, we may be able to capture all the applicants, because as you've heard, people tend to apply on average to 80 to 100 programs. Well, when we did look at this data, what we found was when we pulled the data, we were able to get about 97% of applicants just by going to 10 residency programs. Now, I'm not sure if you understand the implications of this, but 10 residency programs were able to capture 97% of applicants. And that really speaks to the idea of people applying to more and more programs. But in any case, when we looked at that data set, what we were able to find in terms of match rates were, here things were a little different. 66% of applicants were able to successfully match compared to 70% of Black applicants compared to 70% of Latinx applicants. Now, this data pool spans way more years than the first data pool that I showed you. So it could show that over time, there is a decrease in the success rate for Black and Latinx applicants. And then this data set also just shows us, do they match or do they not? It doesn't really indicate number of interviews, whether or not you were ranked to match, whether or not you were practically ranked to match. So this is just looking at, did you match or did you not? And if you look here, the match rates for our Black and Latinx peers much lower than the non-URM individuals. Again, speaking to this idea of whether being a DO applicant can affect things for you, it seems like, again, the Black and Latinx applicants are less likely to be DO or coming from DO programs. 14.4% of Black applicants were awarded or inducted into the Gold Humanism Honor Society. So this tends to be an award that favors underrepresented in medicine. However, the question becomes, how is this award appreciated or valued by program directors on the back end? We don't know this at this point. Well, I'll be telling you about it later on, actually. I should put it that way. And in terms of AOA, we already spoke about the fact that Black and Latinx individuals are least likely to be AOA awarded, and this we can see here in the data. Percentage of applicants with an additional degree. So by far, Black applicants, 8.1% of Black applicants thought it necessary to get an additional degree. And I'll show you later on that actually does not confer any benefit when it comes to the match, in case you're considering that. Now, this might be of interest to you. Mean USMLE Step 1 scores. The mean USMLE Step 1 scores historically have been lower among Black and Latinx applicants. Now, a couple of caveats. One, the USMLE STEP scores were never intended to be a marker of success in the match. They were never created to be a marker of success in medicine as a whole. And so because of those things, as you all must know by now, it is a pass-fail exam. But then there are implications for Step 2, which that data I do not have, but we can sort of imagine what that data would look like based on what Step 1 scores historically have been. And then when you look at the mean number of peer-reviewed articles or abstracts, you might ask yourself, how many publications do I need to have, and how do I differ, or how do I compare with my peers? When we break it down by race, this is what we find. So on average, it seems that most people have about 2 publications that they've gone from start to finish. This is what has been actually been published, not just submitted. Then I thought to stratify this data by matched versus unmatched. So if you're looking at the unmatched pool of individuals, 17% of unmatched individuals are DO applicants versus only 3.1% of matched individuals being DO applicants, which may speak to the idea that DO applicants may be screened out inadvertently or on purpose, who knows? But that's just what the data bears out at this point. 10.4% of matched applicants happen to be in the Gold Humanism Honor Society. Now, 28.8% of our matched individuals have been awarded AOA status. There's no difference whether or not you pursue an additional degree, and I mentioned that to you previously. If you look at the matched data versus the matched pool versus unmatched pool, there's certainly a stark difference in Step 1 scores. And again, this has implications for Step 2. The mean number of publications that you have submitted that have been published, there's actually no difference between the matched and unmatched. So you don't need to say to yourself, gee, if I don't have X number of publications, I'm not going to match. There's no difference between those 2 cohorts. So in conclusion, when it comes to just this portion of the data that I've presented to you, There are differences in academic performance metrics that exist across race and ethnicity, but several questions come up for me. Do those academic performance metrics, do they predict your success as a urologist? As we create interventions to recruit more diverse candidates, how can we take into account these differences? And are program directors even aware that these differences exist? And how do they factor that into the urology match decision-making process? So I'm going to end with one last study. And with this study, what we were looking at is, well, we essentially surveyed urology applicants across the country, and we got a response rate of 70%, so really good response rate. And then we surveyed program directors across the country, and we had a response rate of 42%, so fairly decent. And what we wanted to look at was to assess the extent of concordance between the perceived importance of factors by urology program directors and urology applicants. Do they view certain factors the same way, and how do they view those factors as different? We also wanted to explore if those factors are used in ranking applicants, if they contribute to low representation of URM in urology. Now, this is a question that was posed. How important are the following factors in your evaluation of a urology applicant, i.e. the factors that make you favorably rank a urology candidate? So someone who's applying, knowing this information is useful. And then we also flipped the question and asked applicants, in your opinion, how important do you think the following factors are in the selection to a urology residency program, i.e. the factors that make a urology applicant successfully match, or factors that urology programs are looking for? So all the factors that are associated with academic performance metrics here, such things such as grades, are in yellow, and all the factors that are associated with the reviewer's perception of the applicant are in green. Our first key finding is this, that the 5 most important factors determining how an applicant is ranked are interactions with house staff and faculty, interpersonal skills, feedback from current house staff, and urology letters of recommendations. So the most important being interactions with house staff and faculty. So in this graph, and I'm nearing the close, so just in terms of being mindful of time. In this graph, we show that the mean difference in scores of how a URM applicant ranks a particular factor compared to how a program director would rank a particular factor. Anything to the left of the x-axis represents an undervaluing by the applicants. The URM applicant doesn't think is as important. Everything on the right refers to an overvaluing by the URM applicant. The URM applicant thinks it's super important. Now, compared to urology program directors, urology applicants undervalued required clerkship grades, preclinical grades, non-urology senior electives, and interactions with faculty and house staff, which, as you may remember, is the most important factor in a program director's ranking. These observations may have implications on how urology applicants navigate their medical school career and how they elect to engage in their preclinical, required, or non-urology senior courses once they choose to pursue urology. So this study may demonstrate to future applicants that, hey, a well-rounded medical education is actually valued by the urology community. The second relevant finding here was that compared to program directors, URAM applicants overvalued the importance of research, of step 1 scores, of medical school reputation, and urology clerkship at a program director's institution, as well as letters of recommendations. Now, with there being limited spots available for sub-internships and an overemphasis on completing a rotation at a particular institution may create an impractical pressure on applicants. At the time of application, your medical school is a fixed variable. You can't change that. So if you overvalue that metric, this is not productive first and foremost, and doesn't really help you with successfully matching. Increased concern and importance placed on research and step 1 scores in conjunction with an undervaluing of required medical school engagements may further dissuade URM applicants from making the most out of their medical school experience. So in conclusion, The discordance that's described in URM applicant and program directors, perceptions of factors that are important for the urology match could lead to undervaluing of the overall medical school learning experience, false expectations of the urology match process, anxious applicants, high residency application volumes, and overburdened program directors. Residency programs, they could consider clearly communicating their selection criteria so applicants may self-evaluate and determine, gee, will this program be a good fit for me? And the most important factors in ranking applicants are those that rely on a program director's perception of the applicants. Now, an awareness of this dynamic could mitigate potential bias in how URM applicants are viewed, particularly the risk of homophily, which I had defined earlier for you as like sticking with like to the exclusion of others. So with that, I just want to give a quick shout out to my research team. There's so many individuals who make this work possible, some of whom are pictured here. And I've also been fortunate to get some funding to be able to do this work. But most importantly, it takes a village to do this kind of work. And so there's several individuals who have poured into this project. So I want to acknowledge them. And with that, I will stop sharing my screen. I'm happy to take any questions if time will allow.
We can put questions either in the chat or just put your hand up. We'll go ahead and take probably like 3 minutes of questions.
Hi, Chantel. I was, can you hear me? Yeah. I was really interested by your presentation. I love it. Overall, so great. I guess one of my biggest thing that resonated with me a lot is seeing the percentage difference between the DO applicants, given the fact that those statistics were not to be found by publicly anywhere as I tried. So I was really glad to actually be able to see the statistics. Is there any more research, I guess, going into further evaluation of what's happening, causing that big discrepancy?
Yeah, so I have quite a bit of data and there are only 24 hours in the day. So if anyone's interested in helping me mine through the data and answer these questions, we'll gladly have you join. I put my email address and my Twitter handle at on the very first slide. But yes, I have data by gender, by race, by socioeconomic status. I have data from the AAMC, from the AUA, from the SAU. And so we can certainly ask those questions. Are there differences in academic performance metrics across groups? Are there differences in timing? And I didn't actually show that work that we're doing, but we surveyed all the applicants. We also surveyed medical students granted at just in my institution at UCLA. We surveyed all program directors. I surveyed all program coordinators. I currently have a survey out for all residents. And so we can look at things like differences in the timing to exposure to urology, and I published a couple of papers on that. Differences in mentorship, the quality of mentorship that you receive. I've also published some papers on that. And we can look at them specifically for DO. Right now, I've focused mostly on race and ethnicity because that was what initially sparked my interest, and that's why I started with that slide saying, hey, I recognize that I'm biased too. But there's certainly room for us to explore these questions for different populations because the data is available.
Thank you so much. I'll definitely reach out.
Sounds good.
Hello, Dr. Simmons. Thank you so much for the presentation. I went to DO school, so that was like really helpful to see. I had a question about the AOA status. So for DO schools, we have SSP instead. Was that like factored into the results for like AOA, or that wasn't looked at all?
So I actually do have that data. I didn't include it, so that's a really good point. I actually didn't include it in the data I presented to you today, but I do have that data available. And if you want to reach out offline, I'm happy to share that with you. If you also want to work on a project to get that published, I'm happy to do that with you as well.
Sure, I'll definitely reach out. Thank you so much.
Of course.
All right, thank you very much. And we'll take a short break. And just so everyone knows, at the end of this, you'll get our questionnaire, and we'll also send out all the contacts for everyone who has been speaking. So it's easy for you guys to reach out. All right, so we will be back at 2:30. Thank you.
Brad?
For those walls I built, maybe they turned down, and they didn't even put up a fight, didn't even make a sound. I found a way to let you in, but I never really had down. Sitting in the light of your halo, I got my angel now. It's like I've been awakened. Every rule I had you break. It's the risk that I'm taking. I ain't never gonna shut you out. Everyone else out. I'm addicted to life. Again. It's like I've been awakened. Every rule I had to break. The risk that I'm taking. I'm never gonna shut you out.
All right, everybody, welcome back. We're going to go ahead and start our next session on applicant perspectives for the past match, the match in 2022, and Dr. Sack will lead that group.
Thanks, Matey. Hi, everybody. Really nice to see so many faces of the next generation of urology. Good luck to y'all, and hope you guys have been having a wonderful day and a half so far. So I'm Brian Sack. I'm a pediatric urologist here at Michigan Medicine, from Michigan, and kind of bounced around Midwest and some of the East Coast for training. And we should have a nice panel today of previous applicants into the match. And there's a number of topics we're going to try to cover. Some include, away rotations, how to choose for them, prepare for them, navigate them, some preparation, pre-interview and day of interview advice, how to rank, preference signaling, etc., and some cost-based issues related to travel and doing the aways and also interviews for those that are in person. So before we get started on the topics, I'd like to go ahead and just introduce our panel. We have up to 6 people. I think hopefully most of them are here, unable to kind of see with so many faces in front of me, but we have Diane Park, Nita Gomba Komba, Hannah Glick, Helen Gambra, Vanessa Ponte, and Kanesha Overton. So I see a few of your faces. So if you guys wouldn't mind just going ahead and introducing yourself, that would be great. Hannah, why don't we start with you?
Yeah, absolutely. Hi everyone. My name is Hannah. I use she, her pronouns. I went to the University of Michigan and matched at the University of Michigan. In the past season, I did 2 away rotations, one that I could drive to, and then one that I had to apply to and secure housing and all that. Is there anything else you wanted us to add, Dr. Sack?
No, I think that's pretty good. And the next one I see here is Vanessa Ponte. Would you mind just go ahead and introducing yourself?
Hi, everyone. My name is Vanessa. I just graduated from Howard University. I will be going to Emory University in the next month. So I do not have a home urology program. I did 2 sub-Is, one back home and one far from home, but I did stay with family and friends, so that did cut some costs for me. And then I was the only one this year in my College of Medicine to apply urology.
Great, thank you. Okay, next one I got on my screen, Diane Park.
Hey everyone, I'm Diane. I'm from the Medical College of Georgia. I'm going to Oregon Health and Science University for my residency. I actually just moved into Portland a couple of days ago, so it's kind of exciting. I did have a home urology program. We had 3 people apply this year, which I think was pretty on the lower end for us. And I did 2 aways. I did one on the West Coast and one in the Midwest. So both a little bit far from home, but that was kind of my strategy, which I think we'll talk a bit later. And then I think that was it.
Perfect, thank you. Okay, next one I see here is Helen Gambra. Please go ahead.
Hi, everyone. My name is Helen, and I just graduated from Vanderbilt Medical School, and I'm going to be co-residents with Hannah going to Michigan for residency, and I'm currently en route to Ann Arbor, so I'm really excited. I did have a home program, and there were 4 of us total who applied into urology, and then I did 2 away programs that were both, one was on the East Coast, one was on the West Coast, and I also stayed with family for one of my programs, so that helped with costs, and we can talk more about away stuff.
Wonderful, great. So I don't see Kanesha or Nita, but are you there? If you're out there, please go ahead and introduce yourself. Okay, no worries. We got a good group now. So, okay, so why don't we just kind of start talking about, choosing, preparing, and navigating away rotations. Like, how did you approach this? Did it make a difference if you did or didn't have a home program? And what characteristics of an away rotation you guys would look for to help, improve your ability to evaluate urology programs and or help you in the match. So I'll just leave it open to you guys to go ahead and get started.
Yeah, I can talk a little bit on my decision making first. So I said this a few days ago, but I was a woman with a plan. I knew that I did not want to spend a lot of money on housing, so I did an away rotation where I knew I had a couch that I can crash on for the month, which wasn't ideal, but it didn't break the bank. I stayed with friends that had graduated from Howard 2 years prior. And then I went home to like my hometown, not in DC where I went to med school. I went to my hometown to do my second away. So I was able to stay at home. In terms of kind of logistics, so one of the biggest things for me when I was looking at away rotations is kind of seeing the cost, because I think it's something that we tend to kind of forget on. The logistics of like, you have to pay for where you're staying, you have to pay from the travel, so where you're staying to get to the hospital, and then you're also paying for your meals. So ideally, I know individuals like to do 2 to 3 away, so that's literally 2 different places of home while you're still paying for your home in wherever your med school is. So that's like 2 rents, and then you multiply that like 3 times more. So I wanted to make sure I could cut my costs in that. But since I didn't come from a urology program, my other tactic was that I wanted to go to a larger academic institution where I knew that my letter of recommendation had some worth, almost, that it was from well-known urologists, because I didn't have too many well-known urologists at Howard, despite we do have urologists, just not a program. So that was kind of how I did. I went to a larger well-known academic institution, and then kind of a still well-known academic institution, but their program was much smaller.
Okay, great. Next.
I can talk next a bit about kind of how I approached it. So I do have a home program, and I have a very supportive one. And talking to them, they told me that I just need to do 2 away rotations. So I did 1 sub-I at home, and I did 2 aways. And I'm from a fairly small program, so I kind of wanted to see how kind of different size programs, I guess, function, how I would feel about being in a bigger program versus a smaller one versus like a medium-sized one. So that's kind of how I dispersed it. I went to a bigger program and I went to kind of like a more medium-sized one. And then financially, I lived at home in 4 year because a lot of I finished a lot of my rotations early, or I had somewhere I could stay during kind of my med school rotation. So thankfully I didn't have 2 rents, which was really helpful, but it's still very pricey. And finding a house is also very difficult. So kind of a way that I approached it was I actually joined like the med schools, like Facebook groups, because I figured, other people are also on away rotations at that time. And that's kind of how I secured both of my housing, I think for cheaper, because people were also trying to save on their rents. So something I'd recommend if you're having trouble finding housing.
Great
Yeah.
suggestions.
Sorry, Dr. Sack. I think I had a somewhat similar experience. I did 1 sub-I at my home institution, and then my mentors said I should shoot for 2 away sub-Is. I contemplated a mix, along with cost, a mix of like geography. I was originally from the Midwest, and I went to undergrad in the Midwest and med school in the Midwest. So I wanted to try to open up some different geographical locations in some ways. So I did 1 out west. I think that there are pros and cons. There's lots of options for housing. Some are more or less expensive if you don't have family in the area. When I was out west, I opted to actually rent a room in a shared apartment through like it was from like the MBA programs around the country, also do summer internships, and they had sort of their own like rotating room thing. And with the city I wanted to go to, there were a lot of rooms for rent, and I found a room through that. And I will say, although it was much cheaper than like an Airbnb or something, my roommate was like really not great. So something to consider, just if you're not gonna have someone who, makes noise until 4 when you're getting up at 4. And then on my other way, I drove to save money with like air travel, but I did do an Airbnb, which was like pretty pricey. But the big things for me were geography, and then I was really interested in like culture of the program. And so I talked with my mentors who were able to suggest like a handful of programs that I could apply to for aways, and that's sort of how I tried to pick it.
Yeah, I would just echo so much of what's been said around the geography and approach to choosing aways, and really getting a sense of different programs and utilizing mentors and then other students who applied earlier before me of like, what are some good places to do aways, like trying to give them a sense of what I'm looking for and applying for those, and then really utilizing scholarships that are available for different away programs and helping me make my decision. And then of course, if I had family nearby that I could stay with, that played a role. And one other thing to add to the finance picture is when I did my aways, I sublet my place back in Nashville where I was staying. So that helped offset costs. And someone may have mentioned that in terms of like not paying 2 rents. So just remembering that that's also an option in terms of decreasing costs around aways.
Super helpful. So why don't we just jump into that kind of discussion right now, is the cost aspect of things. I know it's a lot of concern by a lot of people. So some of you mentioned scholarships, some of you mentioned kind of Facebook groups of other medical schools or subletting your program back. Like how did you find these resources? And if you could provide actually some more detail, like on the types of scholarships you applied for, where did you look for them, the timing of when you applied for them, to kind of give some more granular detail, that would be great. And I did include some of those resources that y'all shared with me before the meeting in the chat that some of you guys can look at, but just hearing from each of you and how you approached it financially or ways of saving would be great.
Definitely the scholarships were key. I am a big Twitter user, And that's usually where they're really posted. There's also a website. It's like an emergency medicine website that was always kind of shared around with multiple scholarships that apply to the whole institution, not just emergency medicine. But for one of my ways, I did receive a visiting scholarship, and it was particularly geared towards students that do not have a home urology program, which is a lot of us here at MUA. So that's how I got some money back in per se, because since I was staying at someone's house, it covered like my transportation, and then it was like nice to have that money for the rest of it ended up being used for interview season and applications for me. But that's not to say that the scholarships are going to kind of necessarily cover all your costs. It's just to offset your costs, because usually they range from $1,000 to $1,500, and rent at one of your sub-Is can range from like $1,500 to $2,500 if you go to New York per se. But yeah, scholarships, Twitter, and then a website that I can post in the chat.
And one thing I'll speak to with timing around scholarships is there can be a lot of variation in terms of some scholarships. There's a clear deadline and it's early before you're going through all the like VSLO away programs. So sometimes you have to kind of balance, because one scholarship that I applied for, it was later in May that I heard back, and some people may know about their ways earlier than that. So just having a sense of where do you want to go, what the scholarship timelines look like, and then as well, like open communication with the programs, which I definitely did to get a better sense of, okay, I'm applying for the scholarship, what's the timeline for hearing back, so I can make a decision about different ways, because that was something that I didn't really anticipate going into, but there was a lot of support from just the program coordinators and the people I was communicating with about giving me information.
Real quick as well, we have Nita, who's one of the panelists. I see she's joined as well. Nita, thanks for the comments in the chat, but if you're able to speak out loud, we'd love to hear what your thoughts are as well.
Hey everyone, can you guys hear me?
Hear you perfect.
Okay, great. Apologies, I'm not in my usual place, so there might be some background noise. But I think to the topic of like scholarships and how to kind of make things a little bit more affordable, I was mentioning I try to look for visiting programs that were kind of funded in some way, shape, or form. So whether that was funding for like just the housing aspect, or pretty much for the whole rotation. So some programs will do where you keep a record of your expenses, and then you just give it to the program, and then they kind of reimburse you via like a check at the end of the program. So you're still kind of having some kind of support to sort of offset your costs. And I think some of the websites that have been posted in the chat already were also very helpful places for me to look at.
I do want to make a comment about some of the asking program directors for other resources. I don't think it's inappropriate for you to ask if the program offers support, because sometimes they may not advertise it or come forth with that as an opportunity for some support, but they may be able to give you something, a few $100s, maybe support something, provide some transportation. And I don't think and if they're unable to provide any support financially, I don't think it is a negative point against you. I think every program appreciates the cost of these experiences and that they're not cheap. So even by asking, there's no harm against you. If they say no, you at least tried, and then you can look for resources elsewhere. Anybody else want to comment on the financial aspect of things?
One thing I was also just going to say about the scholarships that we haven't specifically talked about, but a lot of them also provide like additional resources and support. So they'll have like one-on-one mentorship through the scholarships, or they'll match you with other residents, and is kind of like a holistic approach that they're doing around the away rotation to give you additional support in addition to financial support. So that's another plug for these different scholarships and programs that are available.
Okay, great. So a question I have for y'all is, how did the away rotations, or how did you use the away rotations to help you with your application and or with the match with regards to letters of recommendation and or advice from the people at the away rotations to help you navigate the match? Because a lot of time the advice from the other programs is really good to help direct you into the right, into the right path. So how did you use that?
I can start on that. Oh, I would say letter of recommendations almost kind of understanding, I think, with OA rotations that they'll write you a letter of recommendation. At least that was my kind of my experience with both my OAs. I had one later though, kind of like right when ERAS was due. So I had to definitely kind of be on top of it, make sure all the dates are lined up so that I can have it submitted in time. But I would say it's kind of expected. You do kind of dance around it, but just kind of talk with your program director when you meet them about that. In terms of kind of with the match process, at least my experience with interviews is that most of my interviews, and I don't think this is the same for everybody, was kind of very geographical for me, kind of me being from the East Coast. A lot of my interviews were from the East, Southeast, or kind of like surrounding area. So I think doing my OAs at kind of other places like the West Coast and Midwest, the only interviews I got from those areas were those two that I did my OAs at. So that's something to consider, I guess, kind of going into the match and kind of with interviews. If you have a program that you like are really, really interested in, but it's not in, the geographic area that you reside in.
Yeah, I'd say for letters of rec, I mean, I think they're a really important part of the application just because, as we all know, urology is such a small field and everyone sort of knows each other. I agree that at most places, it's sort of expected that there's some sort of letter that gets written. At some places, it's usually the PD or someone who's sort of like a medical student liaison and the chair. Sometimes it's a combined letter, but I would ask, like on the first day, the program coordinator, you usually do some sort of orientation with them. Just say, just so you know, don't go in expecting it. I would just get that confirmed, because if there isn't an understanding that you do get a letter of recommendation at a baseline, then you do have to find someone. I think that I got a little lucky in that the understanding was that I was going to have one written, so I didn't have to necessarily seek out a faculty that I'd worked with a lot. But if you do have to do that, I think a really good resource is the residents, asking them who would be like a good target to try and find someone to work with, and then make sure you're working with them a few times and then target them for a letter of rec. Yeah, I'll stop there.
Yeah, for me, so I use, of course, the letter of rec is like key on your away rotations. Actually, on one of my aways, it was kind of during our program coordinator orientation. She was like, you need to do one clinic and one OR, and then you get a letter. So it was kind of everyone at this institution kind of is already prepared to get asked to write a letter. You just have kind of a prerequisite to get that letter. From another standpoint, I kind of used the away rotations kind of to make my baseline for what I wanted in a urology program. So coming from Howard, which we don't have a urology program, it's like, I know I want to do urology, but what exactly am I looking for? So it was kind of like I used both of my ways to compare and contrast what I did like and what I didn't like. So what I did like is that, a program that has 3 or more residents. I liked kind of that big family. What I did like is that, some attendings didn't work as late as in some other institutions. So I started kind of doing my pros and cons list, because it really helps me narrow down. And I know we're going to talk about it in ranking. So I ranked programs that were larger, higher than programs that were smaller, because that's what I was able to see on my away rotations. So while you're on your away rotations, you're obviously auditioning for them, but just kind of keep in mind to take notes of what you do like and what you don't like. And those are things that while you're interviewing, you're like, I saw so-and-so at this program and I didn't like that. Would I like that here? So definitely kind of making my list of kind of my expectations and kind of like almost my ground rules for the whole process.
Yeah, I resonate so much with everything Vanessa said, because I would say that was definitely my experience as well. And coming from my home program, I kind of had the idea. I was like, okay, this is what the urology residency is going to look like. And then seeing something different, I was like, oh, okay, I like this more. I don't like this as much. So it gave me tools to be able to ask questions around what I'm looking for during the interview cycle. And I was really grateful to have those away experiences to see, even though they were like similar programs with similar volume or like size of residents, still being able to see how they did things different around different rotations or their research or how they did their different surgical skills. And it was really helpful going into the interview cycle to be able to ask those questions.
This is all really helpful. I also just want to introduce Ganesha. I know she just able to join on as well. Ganesha, we were just talking about, first we talked about kind of choosing away rotations, some cost recommendations to kind of help save, and also just talking about kind of how to use the away rotation for letters and kind of preparing going into the interview season. Do you have any comments you'd like to share with the group on that?
I think in general, I guess starting from the very beginning in terms of like picking an away rotation, I think kind of highlight, I'm not sure if anybody already talked about this at first, but I specifically tailored my search to programs that had scholarships because, you know, the process in general is expensive. And so I was not going to a program that did not have a scholarship. Secondly, the strategy that I use in terms of also selecting a rotation is because I came from a program that did not have a home urology program. I also came from a brand new medical school, so the name was not known. And so I needed other programs to vouch for me. And so I was looking for more of the bigger institutions, bigger names in urology that I can do a way rotation at, who can vouch for how I am as a person, both like as a team player, but also like how I excel on the rotation. And so I also did 4 away rotations. I know they typically say about 2 or 3, but I did not have a home sub. I actually created my home sub like while I was away on my sub-Is. And so I ended up doing 4 away rotations, but I did 3 bigger programs at the very beginning, and then, or 2 bigger programs at the very beginning, 1 community program, and then I did another big name like towards the end. And all of them wrote pretty much really good letters of recommendation. One of my tips in terms of what to do while you're on a way rotation is just in general doing your best. And one thing that I said yesterday was more so making sure you're better today than you were yesterday. You're not in competition with anybody else but yourself. No, you're not in competition with anybody but yourself. And I promise you, as long as you're better today than you were yesterday, that's all that matters. So whatever question you didn't get right today, or whatever question you didn't get right yesterday, just make sure that the next time that question comes around, you're gonna know it hands down. I think in general, like, you will be stressed about a lot of things, but everybody know that you are a medical student. As long as you are doing your best, I think in a team player and a hard worker, you will do fine.
It was really great. And would you mind just telling us what medical school you're at and what your plans are for next year?
I graduated from Carl Illinois College of Medicine. It's the new engineering medical school at the University of Illinois. And I am going to residency at the University of Washington in Seattle.
Fantastic. And Nita, would you do the same? Please introduce yourself. I know that you already spoke, but it'd be nice to hear kind of what your background and where you're going is.
Yeah, for sure. So medical school, I'm graduating from the University of Maryland School of Medicine in Baltimore, and I'm going to be doing residency at SUNY Downstate in Brooklyn, New York.
Fantastic. Okay, so kind of moving on, I think now that we're done with our away rotations, we're kind of going into interview season. And, you know, there's a lot of preparation that goes on kind of pre-interview and also the day of interview advice. So why don't we start with kind of pre-interview preparation? How do you get ready for your interviews? What did you guys emphasize? What in hindsight was more important than you maybe realized when you went in originally?
Okay, I can go. So in preparation, so on Google, you can search up kind of like behavioral interview questions like there's definitely like different websites that'll be like, tell me about yourself, tell me about a time. And those are usually the questions you're going to get. Also by the time interviews roll around, you'll have submitted your application. So that includes your personal statement, your CV. So knowing your research really well, because everything on there is fair game. Knowing your hobbies. If you say you like basketball, talk about what's your favorite team, be expected to be asked about a team player. And then if you don't know the team player, it's just like awkward and it kind of ruins the whole vibe of the interview. So just kind of know your hobbies well as well. But kind of to not like take every point, but just kind of I'll stick to the point of knowing what you write on your application, because literally someone can just pick out one little thing. And I promise you, if you do not know the answer of something that you're supposed to know the answer because it's on your CV, it is very, very painfully awkward.
For me, getting ready for interview, same thing as Vanessa. I looked at kind of standard interview questions. So definitely have, something ready for, introduce yourself, weakness, strength, why urology, because those are questions you definitely will get. So I practiced that a couple of times with, my friends, and also kind of with people from my urology program too, to kind of get their feedback on that. And before each of your interviews, they send you an email with like your schedule and who you're interviewing with. So, before the interview happened, I had a like notepad, I guess, of every single interviewer and just little facts about them, like where they went to school, what field they're in, like what their interests are. So kind of I'm ready before I meet them for the interview. Something that surprised me was how conversational a lot of the interviews were, honestly. And just I had every single interview I had, we always talked about what I wrote in the hobby section. So definitely be prepared to know that kind of inside and out.
Yeah, I totally agree with all that. Pre-interview stuff, there the like SAU and the Society of Women in Urology do at least last year they did a few webinars, which I found particularly the Society of Women in Urology, and anyone I think of any gender is welcome to go. But I found it to be really, really helpful. I do think even like there were faculty there and residents and program directors, and so they talked about it, and I really helped frame a lot of my answers based on like a lot of the things they were saying. I would say in addition to that, I tried to have like sort of at least like a unique thing about each program. You often do that, get the question of like why specifically this program, and so having at least a little tidbit about something that you have at the program that's unique, I think is good. And I will let someone else go.
Yeah, just piggybacking off of what has been said in terms of practicing questions that may come up, I would say also reflecting on like just your clinical rotations and having different like stories or different periods where you're working with a team where you can answer some of those behavioral questions, because I found that having those specific stories just helped get across like what you learned from it or what skills or what that experience meant to you, and those came up a lot. So just like knowing those details of the story, I practiced those a lot. And then your school may organize this, but also something that you can definitely like take initiative and do is having a mock interview where you set up your Zoom, get dressed, do it with a faculty member who's done residency interviews before, and they'll give you feedback not only on the content of your answers, but just like sound quality, background, different tips. And I found that to be really helpful as well. And just like what people have said, like hobbies were talked about every single interview. So definitely knowing your hobbies well and just things that you want to share around them, as well as why this school, why urology are common questions.
I think it's a really good point, Helen, about the mock interviews. I think practice is really, really important. And sometimes for a lot of you all, you'll probably remember the first few interviews felt like a little bit rustier than the subsequent interviews because of the practice that kind of occurred during the interviews live. So even if you don't have a home program, I think someone can interview you even if you're not going in, even if they're not a urologist. So they don't have to be a urologist to kind of read your CV, read your application, read your personal statement, and just have a interview type like discussion with you to see how well you know yourself, how well you know your passions. Can you tell a clinical story to kind of help sell why you wanted to go into urology, and really kind of get a practice on that. You guys can even bounce things off of each other. Like, how are you preparing? What kinds of questions are you preparing for? Do you like my stories? Do you like clinicals? Can be very, very helpful. Anybody else have any questions or comments? And anybody else from the group as well is more than welcome to kind of ask a question about kind of preparation for interviews.
I have one little tidbit that I wanted to say. In hindsight, I wish I would have taken the time because, so to be honest, after an interview, you are exhausted. I would take like post-interview fatigue is real. Like, do not be surprised if after an interview you take like a 4-hour nap, because there's something about the light shining on you and doing your like fake smile and laughing and all this that takes like so much energy out of you. But I wish I would have taken like 30 seconds after every interview and just record myself and kind of talk about the vibes and the energy and like remind myself of, I didn't like how they kind of said something. And just because after like even 3 interviews, everything starts blending together. You initially start like making your like rank list after an interview. You're like, okay, actually, I like this one more than this one. But then at one point, does 8 differentiate from 7 or 8 differentiate from 6? So like, I think having kind of a video of seeing myself and how I felt and feeling my feelings later on would have better helped me kind of with the little moving around in my rank list.
Yeah, one thing
Okay,
I also forgot to mention, I'm sorry,
Please.
Dr. Sorry, I keep interrupting.
No, please. Sounds good.
Something I didn't do until later in the season, but I wish I would have done, and that I heard about from other applicants on the trail was they developed like a single standardized question that they would ask at least every program, so that they had something that was actually like tangible that they could use to like compare programs, not necessarily like, you know, like what's your favorite thing about the program, or like, you know, a little something a little deeper than like a superficial question. And the one that I got from a different applicant that I liked, that I used for about a quarter of the season was to highlight what the perceived deficiencies of programs were without asking them to say something bad about themselves. And I asked them, if you won the lottery and you had like $1 billion and you could use it anywhere in your department, like what would be the first thing that you would fund? So if anyone wants to steal that, I give credit to whoever I took it from, but I liked that question.
That's nice.
And one last, just so I can add in, one last question that I will always ask a program director or a chair is more so like, are there any hesitations for my qualifications or whether or not I'm a good fit for the program? That way, like you can iron that out before they go back and discuss you with the entire group, like, you know, when they create their rank list. I didn't want to leave the interview with any chair or program director feeling any type of way negatively about me, and so that was the time at the very end for me to address those concerns.
I see, Vanessa, you made a comment, and Mady, thanks for sending me a comment as well, kind of about the hobbies aspect in the application. I saw that come up on Twitter myself actually yesterday.
Yeah, I saw it on Twitter.
Yeah, and I haven't confirmed it, but there's, you know, been comments in the social sphere that there is no longer going to be a hobby section in the ERAS application. And, you know, I read the whole thread about it, and there are some people who really value the hobby section. We had some people just this past week in person have different opinions on the hobby section. These are people who review applications, but as many of the applicants who went through it last year comment that the hobbies oftentimes leads to just good conversation and getting to know you as a person, or for you to even get to know the people who maybe have similar hobbies who are sitting across the table from you. So one of the suggestions, I saw some of the people in there who are working in different residency specialties across the country, was that you can include this in your list of activities, and that, you know, you do have a set number of activities though, however, in the application. So if you choose to emphasize one of your hobbies as an activity, that may be a way for you to include a said hobby into your application. And then obviously you can always include it into your personal statement too, but obviously don't go overboard on that. Okay, so I'm looking back at all the comments. Anita, thank you so much for the detailed comments in here. And you guys should remember, copy all this stuff too before you kind of finish up with the session today. But you know, you talk about interview day, Anita, and having a routine and the importance of that. And Vanessa, you talked about post-interview fatigue. So why don't you guys like talk about the interview day and like really kind of like break it down on like methods of success to kind of get you through. It's a long day sitting in front of a computer.
Yeah, so I can talk about pre-interview day, at least what I did. So I had a notebook. I had like, let me see, Adelaide. So I had like this notebook. Oh my gosh, I do have it. Now it's going to show it really quickly. But so this was kind of like my interviews. I would separate, oh, it's blurred, but I would separate it by interview number. I'd separate it with the names of each person that's interviewing me, because the day before you'll get your interviewers. And then I would say, okay, so this doctor is FBMRS, this doctor is endo. And then I would kind of search up, like I would do FBI work on every person that was interviewing me. And I would look at maybe a research paper or two, because at the end of every interview, you're going to get asked, what questions do you have for me? And one thing I said yesterday is that everyone, it doesn't matter if you are an attending, a resident, a librarian, everyone loves to talk about themselves. So if you're showing interest in someone, it just makes them like have good vibes about you. Wow, they like want to know what I do. And I think it always made the room feel lighter when I showed interest in them, because by showing interest in an attending that's interviewing, you're showing interest in the program. So I always put aside like 2 hours on my pre-interview day to kind of do my research on the program, exactly why I wanted to go there, why I wanted to be in the city, and then do interview on each individual person. Not like in-depth interview, like in-depth research, but just kind of research each person to kind of, when I get into the room, I know what I'm getting myself into.
Yeah, I would say the same thing. I pretty much had a notebook as well that was kind of broken down fairly similarly to what Vanessa mentioned. And I tried to have like very specific kind of questions for each individual who was interviewing me, and again, had those pre-written so that when I walked into the interview, I was kind of ready. As you walk through person after person, you already have your stuff in front of you. And so you don't have to be sort of thinking about questions necessarily on the spot, unless something comes up in the interview that you want to kind of really follow up on.
Yeah,
And even things like, okay, sorry, go ahead.
Sorry, Nita, you go ahead.
No, I was just going to say, as far as the rest of your routine for the day, even things like, what time I ate breakfast and, just other things, and what to do with my breaks and stuff like that, I kind of had those things planned out already. That way I try to minimize surprise as much as possible, because, things can kind of happen on interview day, but I try to keep a fairly consistent routine throughout all my interviews.
I was
Yeah,
just gonna add, sorry, I keep cutting everybody off. You go ahead.
Go ahead, Helen. You good.
Okay. I was just gonna add, like the prep, very universal in terms of who you're talking to, like what their field is, because I saw that depending on certain field, they may ask different questions about research, like if it's more related to what they do. So again, knowing your application well, and then you can kind of anticipate some of those questions depending on who you're talking to. And then something that I also learned through just doing interviews, where I did have like preset questions that I would want to ask different interviewers, like even based on their interests. And then I also started grouping it just based on what they do. So like questions that differ for a program director versus the chair versus the different faculty member that works with residents in this way. Because I just found that some of my questions, it didn't land well, and I just learned that they can give insight to different things. So that helped me tailor like which people I ask questions to. And then the way, I don't know if we've talked about like structures of interviews, but they can vary a lot depending on the school. But it can be anywhere from like 4 to 15 small different interviews that you do. So you can have like 10-15-minute interviews for the day. You may have like a small break in between, whether it's like 3 minutes or 5 minutes. It really just ranges, but that's what really kind of adds to the fatigue, where you're like going into a lot of different rooms and talking to a lot of different people. So just giving yourself time after to relax, re-energize in any way that gets you energized again. And then if you have like an interview the next day, making time to do that pre-interview work.
Yeah, I think the pre-work for interview is the same. Just make sure you do research a program, research who you're interviewing with. And I had a note card for each person, make sure it's in order. I think the pre-interview routine is also really important. So each program, depending on where you live, might be in different time zones, and they will send it to you in their time zone. So make sure you double check to make sure all the time is lined up and you're not showing up late or early, things like that. I made sure I slept early, made sure I had my coffee and water ready at the table, had a little snack and for the break. So little things like that to make sure I'm ready for today.
Yeah,
Thanks, that was
adding on that,
great. Please go ahead, Hannah.
yeah, technical difficulties happen. You like cut people off, not as much when you're one-on-one with someone, but everyone knows it's going to happen. So try to not stress too much about it. Make sure you have, it's helpful to have the program coordinator's like cell phone. I would write it down on my pad of paper. Oftentimes if you get disconnected or if your Wi-Fi isn't good for some reason, you can shoot them a quick text and they can communicate that with the interviewer. And like, at least in my experience, I don't think anyone called it over me if my Wi-Fi, which was not great in my old apartment, was like cutting in or out. And then I would say I did, like many other people, like take notes during the interview. Sometimes I was worried that if I wasn't like making eye contact and looking directly at the person, they'd think I was like looking at my phone or something. So oftentimes I would like actually put my pen in the screen and like shake my head and things like that. And then I like would intentionally look down so that they knew that I was like just taking notes about something they said or something along those lines. But similar to everyone else, yeah, I had a routine. I always would have water with me, coffee with me, go to the bathroom before. I'd always try and be like 10 minutes early. And yeah, recover. I also took many naps after interviews. There's somehow exhausting, even though you're just sitting at your computer.
Okay, fantastic. Thanks, everybody. In the chat, there was a significant amount of discussion on signaling. So would you all just kind of provide some comments on signaling and your thoughts based on your own experiences or what you heard about others who used it last year?
I think the jury is out still on like really what signaling does, because it's only, I think, going to be the third year of signals or fourth year when you guys are, this next cycle is applying. I personally talked with my mentors and like asked them, knowing my application and knowing sort of what they knew about me and what my goals were, should I use the signals on more reach programs or more like programs that I think I would get an interview at, but I really want to ensure that I do get an interview there because it's, you know, close to home or something I really wanted to do. And so you know, I didn't signal the place I matched in my home program, and I think I got 4 out of the 5 interviews. But it's so variable, so I don't know exactly really what they do yet.
One thing to add, SAU like guidelines also say you do not signal your home programs and you do not signal any aways that you attend. So if you are doing 3 or 4 aways, that's already 4 signals that you already saved, because at the end of the day, you already show interest by attending their away program or their sub-out program.
Yeah, for me, so the way I chose my signals were like institutions that I was very interested in going. Like I only did 2 aways and I had to be strategic in my aways simply because I wanted to cut some costs, but there were still a lot of institutions that I really, really enjoyed, you know, learning about, and whether it was at their open house or just kind of seeing their Twitter. So that's how I sent out my signals. I mentioned this in the chat. I received interviews at my 5 signals, and then I ended up matching at one of my signals, which was not where I did an away.
Yeah, the one thing I'll also add about signals, because I'm not sure in terms of interviews, like how much they help, but I was really stressed about how they played a role in ranking and thinking a program that I really loved during the interview. I didn't signal them, so I don't know if I have a chance to match there. And I would say don't worry about that. I don't know the background if they factor that in, like, oh, they signaled we'll rank this person like this, but just really ranking where you want to go regardless of if you did a signal or if you did an away there. Because I think after you've done your interview, it's kind of more blank slate. That was my understanding from just the experience. But going into it, I felt like the signals could still be very influential for ranking. And I just don't think that's the case.
Yeah, I mean, I think they're so new. We don't really know what role they play yet, but I think it really is dependent on the program. I think if you're signaling kind of bigger name programs, maybe it might not mean as much because they have so much interest and maybe they have so many people signaling them. But I did talk to a resident at like a smaller program, and they told me that their PD said, you know, they put a lot of weight on the signals that they got and who they chose to interview. So I think it really varies. I don't know if there's like a right or wrong way to do them. I would just say signal ones that you're interested in.
I have another question that was just brought up to me through the chat, but just kind of like how they approach the quantity of interview applications and like how many and how broadly and regionally, don't necessarily need specific numbers, and like how did you feel, you and your co-applicants, how many number of interviews they requested, how many they received, etc. Any advice you could give to kind of quantify how to send the number of interviews to send out or number of applications to send out?
So I could just communicate like what my story was and why I applied the way I applied. So my test scores were not the best. They were actually really horrible. But I knew that I wanted to be a urologist. And so for me, I actually did apply broadly. I didn't have any geographic ties because at the end of the day, like urology is where I wanted to, urology is what I wanted to do. So I would take any program that would accept me, one. Two, though, I also, at the same time, I also wanted to be at a very strong academic program because I also like wanted the academic route. So I applied very broadly. I ended up submitting like 100 and some applications. The only thing that I filtered out, honestly, on my applications was if they only had one resident. I did not want to be a single resident in a class, but if you had 2 or more residents, that's what I applied to. So I ended up applying to 100 and something. And then out of that 100 and something, I ended up getting, I think it was like 105, let's say. I ended up getting a total of 23 interviews, including like interviews at my sub-Is. And then from there, of course, you like do your ranking. I think that the amount of applications you apply to is important because they say statistically you need anywhere between 12 to 15 interviews to actually land a match in urology. And so those who have like less than that, I think there are people who match who have less than that, but you kind of like statistically have a harder chance of matching.
I personally talked with my mentors again, and I recognize that coming from Michigan, like I was very privileged to have people who are aware of the process. So, but for me, I really asked them like, what number do you think would be good to shoot for? I know that the national average this last year is pretty high, and I think that it's because of exactly what Kanisha said of like each program you go through when you're looking through the list of who you can add, you have to ask yourself the question, would I rather match at this program or would I rather not be a urologist? And I think that's really the question you have to ask yourself. And that kind of allows you to like follow your gut and dictate. I mean, obviously cost is a huge thing as well, but for you and your own personal, application and your path, how many would be good for you? I will say I am a queer person and I had geographic preferences of places that I felt like I wouldn't be as safe as, so I actually didn't apply to as many of certain geographic preferences because I decided for myself I would rather not be a urologist than match at some places where I wouldn't feel like necessarily as safe or welcomed.
Yeah, I'll just say that kind of like everybody else had mentioned, trying to be very strategic with your applications and kind of determining what your priorities are. And if you're, able to try to apply based on that. I think for me, my biggest constraints were mostly geography. I primarily just wanted to be kind of in the, East Coast, sort of Northeast sort of area. I have like aging parents with a bunch of different issues and stuff like that. So I wanted to make sure that I was reasonably close to family. So that was important to me. And then also was very particular about programs that were known to be supportive of people of color. That was going to be important to me as well. And also programs that had a, kind of a focus on working with people in need, because that's sort of the patient population that I care about as well. So, taking into account sort of these different things, I think is going to be very, 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 very helpful.
Yeah, I mean, it's definitely a numbers game. There's only so many programs and so many spots for urology, right? Especially with the amount of people applying. So, applications are expensive. It gets more expensive the more programs you apply to, but I think that's something that you don't want to skimp your money on at all. I would say, I mean, I was a little more selective, I think, in how many programs I applied to, I think, than I should have been. And it kind of really freaked me out once I got my interviews, because I think if I applied to more, I would have gotten more interviews. But at the same time, there was a reason I kind of filtered those places out, and it worked out, thankfully. But I didn't want to be in places that only had 1 or 2 residents. I didn't want to do any 6-year programs because I didn't want to do like a full research year. And there was just some like geographic areas I didn't want to be in. So that's kind of how I filtered kind of which programs to apply to. Oh, I ended up applying to like 65 programs, which I think is on the lower end for urology. So if that puts into perspective.
Well, thanks you guys for sharing all that. I do want to say the last 10 minutes or so about ranking and how you ended up ranking the way you did. How do you prioritize? I know everybody does this differently, but if you could each just give a minute or so kind of advice on how to kind of rank each of the things, make your list pretty much. Thanks.
I can start. I'll be relatively brief. For me, when I was doing each interview, after every interview, I had an Excel sheet and I picked specific factors that I felt were important to me, and I ranked them on a scale of 1 through 10. So it was like geography, like number of residents, research year or not, and then sort of like a gut feel. And I looked at sort of the numbers that were spit out just purely off that, and then I allowed myself some grace to be like, oh, I think I actually like this. I didn't do like specifically what was there, but I allowed myself to sort of look and have a gut feeling for, I think maybe this one a little bit more, this one a little bit more. I also have a partner who lives in Michigan, so we chatted about it together because her opinion was valuable to me.
I think I was all over the place. So after every interview, so like my first interview was number 1. Then the more interviews I got, I started like tweaking my list. I did not have a system. I wish I would have, but that would take a lot of organization and I was so tired. But I definitely just kind of added on. Now in hindsight, I definitely would have had a better system at that. But I went off of geographical preference. I also did want to stay in the like Eastern time zone. That was like my priority. I wanted to be near a large airport because I have family in Miami, which I did not want to come home to, but I did want to have the easy access to get home to them. And I think for me, it was a lot of my interviews that I accepted were pretty much already meeting all of my qualifications in terms of like call schedule. I was like really grateful that it worked out that way. So my interview was more for, is the connection there? Like, can I see myself here for 5 years with the residents, with the faculty? So I think my rank list was pretty heavy on vibes, I would say. So if I had a good vibe, if I saw myself in the moment, I was laughing with some of the attendings, and if the time went by like that, it was just like higher up on my list.
Yeah, I would say for my rank list, it was definitely based on like what I learned from the interview vibes, but also specific things that I was looking for in a program. So research was something that was really important to me. And then the size of the program and just the surgical volume were things that were really important, as well as diversity of the program and supporting initiatives that I really care about. And then I was also applying with a partner, and because urology has an early match, it's not the same couples match that you can kind of do it jointly. So those were my big priorities, and of the programs where we were overlapping with interviews, like those were top on my list. And then after that were just like the other programs that I felt would be a really good fit for me, and were the things that I was looking for, but might be like distance away from my partner.
For me, going into ranking, I kind of fell in love with where I did my OA, so that kind of made it easy in terms of like, my 1 and 2. But otherwise, I think I want to pursue a fellowship after finishing my residency. So I looked into kind of the match rate where, the residents, where they go into fellowship. Is there a fellowship spot like in the program itself? So that was an important consideration for me. And also I would just say just kind of the overall impression it gave me during the interview. Oh, also the city. I was like, is this somewhere that I really want to live in? I think that's really important because 5 year is a long time to be somewhere, right? So I definitely did extensive research, on the city each program was in as well.
So for me, like I said before, I applied very broadly, but when I received my interviews, that's when I more so focused on like what my priorities were. So some things that were really important to me was the program, the relation program, the research I'm back in engineering for medical school, so I want to research mentor at a program that will be able to like specialize in those interests so I can like continue to grow those interests. And it was probably a few other things. It's in my Excel spreadsheet, but I had like a basic algorithm and where I would score all the programs after each interview. So that kind of drove my ranked list process. I already knew what my top were in terms of from where I had did my away rotations. But outside of that, the programs that I did not do a away rotation at, I ranked those based off of the interview and what that Excel spreadsheet like gave me after I did the interviews.
This is all fantastic. Are there any last questions that anyone has or last comments any of the panelists want to share with the group before we conclude?
I guess just a good luck. I mean, it's the best field, so you guys made a good decision. And I think this is the hardest part. So after you get through this, it'll be all uphill from here. So just a good luck to everyone with the application process and the ways and stuff.
I kind of said this to the group yesterday, so I'll repeat it. In general, we know that urology is a very competitive field. And I think that at the end of the day, I don't know any success without any failures. So no matter how many no's you get during this process, like don't stop. And I mean that wholeheartedly. Like when I tell you my test scores were trash and I had so many people prior to this entire process, like everybody telling me no, and including my home program. My home program did tell me to dual apply, but at the end of the day, my heart was also really set on urology. And so at the end of the day, I think that like no matter what, no matter if you don't match your first year, no matter if you don't match your second year. I know somebody that went through the match 5 times before she actually matched. Not necessarily urology, a different competitive specialty, but if this is your dream, if this is what you want to do, like stick to it, and eventually the door will open for you. And I can definitely promise you that.
Fantastic.
Be yourself is all I can say. So, and I think my main thing about this whole process is comparison is the thief of joy. So don't try to compare yourself to things you see on Twitter, because everyone will always highlight their successes on Twitter and never their downfalls. If you see that your other person in your classes has a 284, like that doesn't mean you're not going to match if you didn't get the same score. Just trust in the process, trust in your application because you put your best foot forward, and good luck, everyone.
And I'll just add that even being part of this academy, there's so many resources you all have to get guidance and support going through this process. So please utilize all those resources. That's something that I love so much about this field, is everyone is so excited and willing to help and guide you through this when you have questions. So please do reach out to us and lean on those people whenever you're having doubts or want clarification, because they will be open and honest with you.
Okay, well, thank you so much to the panelists. Thanks for all of you guys for attending today. I hope this was helpful. And good luck and enjoy the summer and enjoy the rest of your day with MUA. Thanks, Beatty. Thanks, Simpa, for having me.
Thank you.
Thanks, Dr. Sack, and all of your panelists. That was really, really great. We appreciate the time you guys took to prepare and to help provide all the information you provided. We appreciate that. So the next part of our program is a feature that records every year. We had 2 people yesterday tell us about their journey in medicine, and the idea is for you to be able to see the trajectory of those who have been successful despite challenges that they face, and see what lessons you can learn that can inspire you to know that you can do this, you can match into urology. So our next speaker is Dr. Ashanda Esdaille, who is an assistant professor of urology at Emory University. She's a fellowship-trained urologic oncologist who did her residency at SUNY Downstate in New York, and then a fellowship at University of Wisconsin, and was recruited to Emory University, where she currently practices. And one aspect of her research interests are in disparities in urologic cancers. So Dr. Esdaille, you have our attention.
Yes, thank you. Can you all hear me? Yes, so awesome. I'm going to share my screen. Okay. Can you all see my screen? Awesome. Okay. Make it actually bigger. So yes, thank you, Simpa, for having me. I'm very excited to be here with you all today. Just going to go through my journey in urology. And what I've realized so far, as I was creating this presentation, every step that I've gone through, my career this far has kind of led me to where I am. And it's been a combination of identifying my purpose, being tenacious and having endurance, and just having a strong community with really great mentorship. So I went to Spelman College for undergrad. I started in August 2004. And at the time, I just knew I was going to be a journalist. I loved to write. I was creative. I drew. I wrote poetry and prose. So I was a French and English double major and a studio art minor. And as you can see, like Spelman College, I have their mottos listed: a choice to change the world, and Spelman College, women who serve. So Spelman's really, it kind of hammered down just the importance of serving your community. And I really took that to heart. And to graduate, we had to do a community service project. So I joined Helping Our Teen Girls, which is a nonprofit organization aimed to improve health literacy. And we did a lot of health education for young disadvantaged women. We did a lot of like STD and sex education type workshops. So I started becoming interested in public health and ways that we can improve healthcare outcomes for young women. I started then volunteering at Grady Memorial Hospital. And it was during this time that I had identified my purpose for serving underserved communities. So in my junior year, I switched my major from French and English to French pre-med. I joined at Morehouse School of Medicine. They had this program called MAPS, and where it was basically designed to introduce undergrads to health related careers. So then my junior year that summer, I took summer classes to complete the medical prerequisites. And then my plan at the time was I was going to work full-time for that nonprofit as the program coordinator, take off a year to study for the MCAT, and then apply to medical school. But then I moved home so I could do so. And my mom was my #1 supporter of which, but I think I kind of underestimated how difficult this part of my life would be. I actually took the MCAT 3 times, and I applied to medical school 3 times as well. And it was during my second time that an interviewer told me that I should get down on my knees and pray that I ever get into medical school. And that it just struck me to my core. I kind of felt just real devastated, because at the time I had applied and I hadn't gotten in. And I, after licking my wounds for a little bit, I used that to fuel my fire. I wrote out a 6-month plan. I took an MCAT prep course and I did pray. And I was waitlisted at Morehouse, but then I was invited to participate in the Morehouse summer program, where you spend 6 weeks matriculating with the first-year medical students. And if you succeed on that first block, or get like I think it was a B or better, that basically increases your odds of being accepted to the program. So it was during this time, about 2.5 years or so, that I really developed like my spirit of tenacity and endurance. And it ended up paying off. I got into Morehouse, and that's me at my white coat with my family. And I was really, Morehouse, I don't know how many Morehouse students we have on the call here, but Morehouse is, a small medical school. It's really dedicated to fostering an environment that addresses primary care and disparities and serving the underserved. It has really strong community health aims. And I have here the 3 women that really inspired me during my time at Morehouse, Dr. Nachabe, Dr. Marjorie Smith, and Dr. Martha Elks. And what I realized, during the first 2 years or so of me being at Morehouse, these relationships that I'd forged and the friendships that I built was really important, to fostering that sense of like community. It was the really strong support system that I developed and something that I knew I'd need moving forward. So that first hurdle in med school was step one. And I was really fortunate to have really dedicated professors at Morehouse. And during my second year in medical school, I really wasn't sure what specialty I wanted to pursue. I kind of bounced back and forth between surgery and oncology. But then on my third year rotation, so during surgery, one of my mentors, Dr. Frank Jones, he and I were speaking about surgery versus medicine. And at the time, I was kind of leaning more surgical. I knew I wanted a specialty that I felt like provided like definitive type care, in my opinion. But I knew I didn't want to do general surgery. And he started, throwing out the different surgical subspecialties. And he says urology. And initially I was just like, I would never do urology. I remember specifically saying that. I was like, why would I ever? Like, urine, no. And he said, just give it a chance, give it a chance. And he set me up with one of his colleagues at Midtown Urology. And I started rotating and I fell in love with it. I just realized that, it was more than just what I thought it was. It's a very vast field, combination of medicine and surgery, from peds to reconstruction to oncology. I just loved what I was witnessing. And then I also had a patient who was diagnosed with metastatic prostate cancer, very young, Black gentleman. And I became interested in understanding more as to why Black patients have worsened, outcomes when it comes to prostate cancer. So after deciding to pursue urology, I kind of added to my purpose, trying to understand prostate cancer, the disparity, and also seeing how I can marry that with my interest in serving underserved populations. Now, at Morehouse, we didn't have a urology program. So I leaned a lot on my surgery mentors and also a really close friend of mine and colleague, Dr. Shenelle Wilson. She was actually the second person to ever match into urology at Morehouse, and I was the third. And she was really integral to be helping me through, or navigating, I should say, the interview process and the application process. And I had to hustle a lot, because like I said, we didn't have a program. But she was a U1 at Medical College of Georgia, and I did my sub-internship there. And that's where I met Martha Terrest. She is the current chair of urology. She served as one of my advisors, helped me with my application, my personal statement. She wrote me a letter of recommendation. And it was really here that I learned the importance of not just mentorship, but also sponsorship. I had applied to roughly 70 institutions. I obtained about 20 interviews, ranked 15. And my number one choice was SUNY Downstate in Brooklyn, New York, for multiple reasons. So I matched, and SUNY Downstate is located in Flatbush, Brooklyn. This hospital, that in Kings County, we do our rotations at either. And they treat predominantly disadvantaged patients of low socioeconomic status with high rates of end-stage disease. And we see a ton of medical tourism. So basically patients from the Caribbean or from African nations will fly into JFK and take a cab straight to Kings County Hospital for their care. So my mom, she lived in Brooklyn in the 70s, and she also received her care at SUNY Downstate. And my sister was born at Kings County Hospital. So I ranked this place number one. I mean, to me, it felt right. It felt kismet. And in some way, it kind of felt like I'd be giving back to the hospital that took care of my mom and my sister. But residency was not easy. It was a 5-year program. We go to a lot of different sites. And I was the only woman in the program for the latter part of my training, but I had strong mentorship from attendings that treated me like family, like Brian McNeil, Llewellyn Hyacinth, and Jeff Weiss, who's the current chair. Now, during my 4th year, I took a little bit of a detour. I had started entertaining the idea of private practice and just coming back home. But when I did my oncology rotation as a 5th year, we do that at Sloan Kettering. I found it so striking how your zip code really dictates the type of care that you receive. And how is it that I can just go a couple miles across the bridge and the care is just starkly different? So I became inspired, and I knew that I had a job to do. And my time at Sloan kind of just cemented my plans. This institution provides the pinnacle of oncologic care. And I was inspired to be the best oncologist that I could be, but for my community. And there were so many questions that I wanted to answer. You know, why do we see worsened disease and outcomes in Black men with prostate cancer? And how can we best improve their care? But I was late. I was already a fifth year and the application cycle had already ended. But my mentors at Sloan, Bafara Day and Jonathan Coleman, they'd advised me to just reach out to the Society of Urologic Oncology and just see which programs went unfilled. So I emailed, and there were 3 programs: University of Wisconsin, UT San Antonio, and Roswell Park. And I was offered a position at Sloan as well. But at that time, I kind of wanted to change the scenery and I wanted to get out of New York. So I looked at all the programs, and at Wisconsin, I met Dave Gerard. So he was the fellowship director at the time and this well-renowned prostate cancer researcher. I wrote him a cover letter, sent my CV, and my mentors at Sloan and downstate just made calls on my behalf. And next thing you know, I'm being flown out to Wisconsin. So initially I had reservations. You know, I'm a city girl, I'm from Atlanta. I spent 5 years in New York. And I said to myself, can I handle the Midwest, you know? But I knew that at this point I can handle anything, at least for 2 years. That first winter, oh God, it struck me. It was like -11 degrees and I shed like several tears. And I think they froze like coming down my face. But, you know, in seriousness, I held on to my purpose and I leaned on my mentors and my community. Clinically, I learned how to do the big cases. I was doing major robotic surgeries, you know, prostatectomies, partial and radical nephrectomies. I love doing retroperitoneal cases as well. And from a research perspective, I was really grateful to work with Dave Gerard, and he helped to harness my research interest. I wanted to understand the immune basis of prostate cancer and whether the disparate prostate cancer outcomes seen in Black patients are in part due to differences in the inflammatory makeup of their disease and why that is. So I added to my purpose. You know, I wanted to understand, like I said, immune biology of prostate cancer and how that affects Black men. So Jason Abel, he's this gentleman here, he was the fellowship director at the time, and he was really integral to help me find a landing spot, a job that would support these research interests. Excuse me. So I spent 2 years in Madison, and by winter of my second year, I found the place for me, and it brought me back to Atlanta. So overall, so now I'm at Emory, and you know, I see there's my picture from my white coat, and here I am. It's my headshot for Emory. I'm an assistant professor, as Dr. Somali has mentioned. I'm 100% clinical at the Atlanta Veterans Affairs Hospital, and I conduct research through the Emory Vaccine Center, where my interest is in disentangling the effects of social disadvantage on systemic inflammation, and in turn, tissue level inflammation and immune biology for Black men. And, you know, I think about my younger self and I see at this stage, you know, and I knew the impact that I wanted to have then, and now things have materialized and kind of come full circle. So overall, you know, my journey has been long, but I've always held on to my why. You know, purpose and tenacity and having a strong community and mentorship has all contributed to where I am today. And I'm very grateful for the individuals who have helped me to get here. So I'll stop there and in the last 5 minutes, see if there are any questions or comments.
Thank you so much, Ashanda. Very, very inspiring story. We do have time for questions, so feel free to unmute yourself and ask a question. Let me check the chat. Yeah. All right. Thanks very much, Ashanda.
Yeah, no, thanks for having me. You all enjoy the rest of your afternoon. Take care.
So as you heard from Dr. Esdaille's talk and some of the talks yesterday and earlier today, mentorship and sponsorship are very, very important. So the next portion of the program is focused on mentorship opportunities that you can take advantage of. So lined up are 3 rapid fire talks that will highlight some of these different opportunities. So the first talk will be given by Dr. Linda McIntire, who is the president of the R. Frank Jones Urology Society. So this is the Black Urology Society, and she is a great motivator and mentor, and has been developing a lot of initiatives, pipeline initiatives, really from the grassroots to try to build, from the bottom up, so to speak, and also mentoring and promoting, junior and mid-career faculty. So she will be speaking to us today about R. Frank Jones. And then following that will be Dr. Sam Washington, who is an assistant professor of urology, a fellowship-trained urologic oncology at UCSF. He'll be talking to us about ureter. And afterward, we'll have a recorded talk by Dr. Shenelle Wilson about Urology Unbound. So we'll start with Dr. McIntire.
Hi, everyone. Thank you to Mady and Simba for allowing me to be a part of your program. And I sent my slides to Mady because I'm just not that good at that. So she's gonna put the slides up and then we'll get started. So my name is Linda McIntire. I went to Wayne State School of Medicine in Detroit. And that medical school, I had to look up the date, was founded in the late 1800s. And to this day, I'm the only Black woman to pursue a career in urology from Wayne State School of Medicine. I did my training at Henry Ford Hospital and graduated in 2004. I'm currently president of R. Frank Jones, and we'll get into a little bit of why we call it R. Frank Jones Urological Society. Next slide. So the National Medical Society Association actually was started by a group of Black men and physicians and dentists. And the reason it was founded was because the American Medical Association did not allow Black physicians and dentists to be members. So they started the National Medical Association. And if you can see, one of the founders, Dr. Daniel Hale Williams, some of you may know, was one of the first surgeons to actually perform a successful cardiac surgery at what is now called Northwestern University in Chicago. Dr. Miles Link actually graduated from medical school at the age of 19 and practiced until he was in his 80s. And Dr. Robert Boyd was both a physician and a dentist. And he also taught physiology. But these men gathered together and formed the National Medical Association. Next slide. Then the reason I mention that is because the R. Frank Jones Urological Society is a dedicated society within the AUA and also the urology section of the National Medical Society, National Medical Association. R. Frank Jones was the first African-American diplomat of the American Board of Urology in 1936. So the American Board of Urology was founded in 1935, where surgeons decided that they would subspecialize in different things. And Dr. Jones had the vision to pursue a certificate in urology. He established a urology residency at Freeman's Hospital, which is now Howard University, in 1947 for the same reasons that the NMA was founded. Black men weren't allowed in a lot of the established urological training programs. And so he started a program at Howard. And from this program, 26 men of African descent were trained, and 18 of them were board certified. He was active in civil rights and appointed by President John F. Kennedy to the National Advisory Committee on Selective Service for Physicians. And this is why our organization is called the R. Frank Jones Urological Society in honor of R. Frank Jones. Next slide. So at the National Medical Association, we have a busy convention. R. Frank Jones meets twice a year, once at the AUA, where we have mentorship reception as well as a scientific meeting. And again, in late July, early August at the NMA. So at the NMA that's coming up, we're going to do something a little bit different. On Saturday, we're partnering with Dr. Raju Thomas from the chair at Tulane University and provide prostate cancer screening. New Orleans is 59.2% Black, and we've identified 2 African-American physicians, urologists in the area. So there's a great disparity and a great need. On Saturday, we'll have our mentorship reception, and we've invited all of the students from Baton Rouge to New Orleans who may be interested in urology to meet them, to greet them, and tell them all about all the mentorship programs in urology, including the Michigan Urology Academy and Urology Unbound. On Sunday, we'll have a roundtable on the AUA 24, which will be in San Antonio. There's a Black History exhibit. And so we'll have a roundtable discussing that. We'll give the Stellar Award, which is a presentation to a distinguished Black urologist, and the William Baker Research Forum. And that is a forum for Black urology trainees, whether they be medical students, residents, or fellows, to present their research. It's prizes, you win prizes and monetary prizes, and it's an excellent opportunity to present your research on a national level. And hopefully some of you have submitted abstracts already. And then on Monday is our urology scientific session. So any of you that are on the call who may be attending the National Medical Association convention in New Orleans, please join us at our mentorship reception and plan on having a good time. Next slide. This is just some pictures of our mentorship reception that we had in Chicago, and boy, did we have a blast. And I really love these pictures, and I'll tell you why I picked them out, because well, the first picture is of the executive board of the R. Frank Jones Urological Society. And these are our workers. These are the people that make everything happen. These 2 pictures, I picked them because urology is certainly female. So when I started in R. Frank Jones, there weren't many women in urology, but as time goes on, as you can see by the pictures, you know, more women are applying to urology, which is excellent. So there's increased diversity. And then in the last picture, I wanted to highlight Dr. Hollowell, who 2 of his sons are urologists. And Dr. Hollowell is from Detroit. He's 92 years old. And he was so excited to come to the reception to meet you, to meet students, to meet trainees. And then there's Dr. Isaac Powell, who was the first Black resident at Henry Ford Hospital and is professor of urology and oncology at Wayne State University. And Dr. Powell is 82 years old. So you can see the level, and you can see Simpa, you can see the level of commitment from some of the older urologists to mentorship. There's Shenelle Wilson in this picture, to mentorship, to meeting students, to passing on that history of Black resistance and resilience. Next slide. So I like this picture. I think I had it in black and white as well, but this is just a picture from our scientific session that we had at AUA 23 in Chicago. Next slide. And I really like this juxtaposition of an older urologist and a younger urology trainee. And this is important to pass on the history of how you actually get through urology, because some of these men have actually trained in programs that were segregated at the time that they matriculated. And I think that resistance and resilience of spirit and that strength and courage to persevere is not new, and it's something that can be shared, and we can definitely learn from them. So again, just wanted to highlight Dr. John J. Mathis, Smith Mathis, who's part of our Frank Jones, and she did the program at the mentorship reception. She talks about structural racism and its impact on training as well as patient care. And it, like someone said earlier, how your zip code determines the type of care that you get. So we had a wonderful time in Chicago. Great attendance and also an opportunity to learn from one another. Next slide. So again, I want to talk about the William Baker Residence Research Forum. And I always show this little trophy that I have here. I've been a part of R. Frank Jones since 2001 when I was a resident at Henry Ford Hospital. One of my attendings came up to me and said, Linda, write up my experience on hand-assisted lap nephrectomy. We're going to a conference. And I was so excited. And as you can tell how long ago that was, because nobody does hand-assisted lap nephrectomies anymore. But at the time, I was really excited. I got to present the Henry Ford experience. I won an award, and later a check for $250 came in the mail. So I was super excited to be a part. I'd never been a part of a conference where there were this many Black urologists. I got to meet other women in urology, and it was just an excellent experience. And so again, if you haven't submitted your abstract, let me know, and I can definitely give you the website, the email address to submit your abstract to hang out with us in New Orleans. I promise you, you'll have a good time. You know, come on Saturday, leave on Monday night, or come on Friday and leave on Tuesday, but you'll enjoy yourself. Next slide. One of the things for R. Frank Jones, we have the social media action team. And this is head up by Dr. Kimora Scotland out of UCLA. All of our social media platforms are run by students and residents. It's very organic and it's awesome. I think they do an awesome job with their Instagram and Facebook page where they disseminate information. I see BB on the call, and BB's definitely a part of our social media action team. They have Urology Spotlight. Next slide. Urology Spotlight, where our Frank Jones members understand that you may be receiving a phone call from a medical student or urology trainee, and they want to interview with you with a template that they have. And since we started this program, the students have gotten a little fancy where they do video interviews now, just to get a feel and an understanding for what that person's experience was, what helped them, what guided them, who was their mentor. This is all very important information that anyone can glean from, all available on social media on our Frank Jones Instagram page. Next slide. So this is our Instagram page. In the other picture, Benoit, the urology trainees love her. So they all wanted to get a picture with her at the mentorship reception, Dr. Down Low. But, and she's very active with our social media group as well. But on Instagram is where you can find all information regarding R. Frank Jones. And I'm sure all of you participate in Instagram, can look on our page and find out the information for the conference coming up in New Orleans. We've done a lot, and we've progressed significantly simply because of involvement of the students. Next slide. We also have a website, blackurologistsociety.org. And the reason I highlighted this page is one of the things that I've done in my presidency is established 2 award systems in R. Frank Jones. One is called Excellence in Urology Award, and this needs to be updated for 2023. And the other one is the Stellar Award. And this is where we acknowledge Black urologists across the country who have done an excellent job in urology and as well as promoting health equity for Black people. And then the Stellar Award is very important that we recognize our senior urologists and give them their flowers while they're here. So please check out our website. We also have an events part, upcoming events where we have pictures from all of our previous mentorship receptions and conferences. Next slide. I did want to mention this is because the AUA is doing a history exhibit called Onward and Upward, the Legacy of Black Urologists in America, and I'm actually on that committee. I said to them, there are a lot of older Black urologists in the city of Detroit. And so we were able to get the AUA to come to Henry Ford Hospital Wednesday, June 14th for a grand rounds. Dr. Burnett, Johns Hopkins will be the keynote speaker. And then we'll have a panel discussion that I'll moderate with Dr. Melvin Hollowell, Dr. Isaac Powell, Dr. Conrad Maitland, and Dr. Ray Littleton. And these are urologists, established Black men in the community in Detroit who've been in urology since the 60s and 70s. And we have a WebEx where, people will be able to view this, but I just wanted to mention this is going on. And I think, with me being in urology, or at least trying to pursue a career in urology since 1998, this is incredible advancement, progress, and movement for the AUA to acknowledge Black urologists. Next slide. So I just wanted to think of something very inspirational, and your future is bright. No matter what you decide to do, your future is bright. You've inherited a legacy of resistance and resilience. And if you decide in your heart and soul that you're called to be a urologist, then you will be a urologist. And I, encourage you to take advantage of all of the mentorship programs. Everyone has a purpose, whether it's Future at the AUA, the Michigan Urology Academy, which is excellent for giving information, Urology Unbound, or our Frank Jones. Membership for students is free. Join us, come hang out with us, present with us, and everyone is welcome. Thank you. Are there any questions? I did want to mention one thing. I am one of the, sorry, BB, I am one of the creators of Prospect. And Prospect is a pipeline program that we're having in North Central section where 4 participating institutions, University of Michigan, Henry Ford Hospital, Cleveland Clinic, and Ohio State University have 4 Prospect students. And the Prospect students will participate at these universities and get a $5,000 stipend, as well as we have Prospect lectures. So anyone that applied to Prospect, the lectures are open to you. So when you talk about your urology rotations, this is a perfect opportunity to get free lectures before you start your urology rotations, so that you won't show up like I did, not knowing anything. So you'll understand the basics of research. You'll understand the basics of urology with hematuria, reconstruction, pediatrics. These lectures are free and available to everyone. So don't hesitate to join us for the Prospect lectures. We'd love to have you. For everyone that wasn't accepted to Prospect, and Susanna can attest to this, I went out of my way to try to find a spot for them someplace else. So, because I think that, I wish I had spots for everyone. I only had 4 spots, but I did try to make sure that everyone that was interested in urology had an opportunity to participate at someplace else. Thank you for putting that in. Thank you for putting that in the chat for me. BB. Hey, BB, good to see you.
Hi, Dr. McIntire. Nice to see you again.
Good to see
I just wanted to quickly ask, were we allowed to submit more than 1 abstract for the research submissions?
Submit your best one, because I can tell you, the one that you submit will be accepted. We don't turn anybody down. I mean, this is our opportunity as an organization to mentor, parent, to love on you, encourage you. So we generally don't turn away anyone. We give everyone the opportunity to present. So I'd rather that you put all of your effort into the one that you think is the best and embellish it so that you can win first prize. Now, I will tell you that last year, first prize got $1,000. Second prize got $750, and participants got $500. That's good money. And that's what our treasury is for. That's one of the main missions of our Frank Jones, is to make sure that we have the finances available to encourage participation and to reward and our students and residents, and also to help fill up any gaps where programs don't fund them. So Tamaj, I hate Mr. Gather, I hate to kind of put you on the spot, but didn't you tell me that you were working with Hollenbeck? No? Or do I have the wrong person?
No, ma'am, I don't believe I told you that.
Okay, I'm sorry, I may have the wrong person. Okay. I know I met a student that told me that they were working with Dr. Hollenbeck, and I wanted to make sure that they turned in their research abstract to participate in New Orleans. So, you know, again, I encourage you to come to New Orleans. As you know, from Chicago, we plan on having a good time in New Orleans. So BB, just pick the one that you have the most passion about, and I'll see you in New Orleans.
I sent it already, so I'll send a follow-up email with just one.
You were making sure you got in there, huh?
Yeah, I was like, just in case, let me give you some options. But I'll send another email.
No problem. And thank you, Mady and Simpa. I really appreciate you for giving me the opportunity to speak with your students. Thank you so much. Thank you, everybody.
Thank you, Linda.
Good to see you, Sam.
All right, we'll give our attention to Dr. Washington.
Perfect. I will share my slides and then share my screen. 1 sec. Right. Hopefully everyone can see this. We're okay here? Okay, perfect. So I was tasked, I'm Sam Washington, urologic oncologist at UCSF and associate chair of DEI for the department. I'm talking about the Urology program. So this was something that was actually developed by our residents. So not something Sam Washington did, but something that our department and I support, continues to be led by our residents, which is amazing for us. Now, I think we all know about underrepresentation within urology, and that's spread across the country. And the extent of it differs based on where you are. So the likelihood of you finding someone that looks like you, same life experience, similar questions or experiences, as the opportunities for that have decreased over time. And we've seen that throughout the years, the numbers of African-American, Hispanic students going in through medical school, finding urology in general, going through urology all the way from college to medical school applications to residency to graduation to residency continues to drop over time. So this was kind of the background or the thing that we're all trying to understand and improve. We know even in our current workforce, there continue to be discrepancies or differences between the populations we serve and the workforce and how those two look different than one another. We have had some gains, even in the most recent AUA census data, but we know that in other groups, things have been fairly stagnant and haven't really improved. And these things were kind of the impetus for the Urology program, led by our residents saying something needs to change. This was around the time when everything was happening with BLM and George Floyd. Residents wanted some way to create a space for trainees, medical students, residents to come together and help each other through the process. So this was an annual opportunity, now in its 3rd year, I believe, where we can really do a peer-to-peer mentorship program. So instead of medical students talking to me, which can be intimidating, I guess I'm intimidating, just from the age difference, the power differential, finding residents in different programs, people who are in the urology space, now having an opportunity to talk to people outside and give them kind of a peer-to-peer safe conversation, safe environment to do that. And that was something that we wanted to start at UCSF, and it's expanded throughout. And that has really been an opportunity for long-lasting relationships, long-lasting opportunities for sponsorship and networking. Now, it's not something where it's just kind of free form. There are expectations for the mentors. And I want to show this because this is just to let everyone know when they're coming in, what's expected of the people that they're talking to. This is really an expectation that we want people who are interested in engaging with all of you, meeting with you regularly. You know, depending on where you are, social distancing, you know, Zoom versus phone versus in person, but opportunities for you to really establish roots at different locations inside the bubble of urology. And those are things that have continued even from the first year in terms of networking, sponsorship, career guidance, research projects, and then things that are important with just the nuts and bolts of transitioning from medical student to applicant to resident when it comes to practicing interviewing, getting insights, kind of tricks of the trade to how to manage sub-Is, urology programs, how to understand the differences between different programs. So these are what developed from that initial drive from the residents. And that is something that's spread just from San Francisco across the country. So this allowed us to have a combination of mentees, trainees, as well as mentors across the United States. And that's not just residents, that's also fellows. So we've been able to expand this. So now people are able to connect with people they may not otherwise interact with unless they bump into one another at a conference or a very specific opportunity that doesn't necessarily arise all that often. And that Urology program was really the starting point for other programs within UCSF. So if you guys are interested in urology, Urology is the place to go, one of the many places, thankfully now, to go to get more guidance, get more discussions, to understand what urology looks like, talk to people that look like you in a safe space. Once you get to the point where you're thinking about interviewing, then we have our UroCorps program. So this is people who are now interested in sub-internships at UCSF, funded with $3,000 scholarship. You come, you do your sub-I, but you also get one-on-one time with each faculty in different domains, CV development, interviewing, applications, and FaceTime with the chair, which is always important. We're just making sure, kind of grease that process. And then most recently, this has led now to a research opportunity across the UC system for funded research for first and second year medical students who do not have exposure to urology. So this is really trying to create opportunities for people to get exposed to urology at each different step and create really, different feelings about the term pipeline, but different opportunities at each node, each step through the medical journey. So you get opportunities to learn about urology, opportunities to do something that impacts your CV and your application, so it makes you more competitive, and opportunities is FaceTime, which is one of the kind of unspoken strong factors that can impact your ability to match. It's just people being able to see you being hungry, see you being proactive, interested in urology, dedicated to urology. So I just wanted to highlight those three opportunities at UCSF for mentorship, no matter what stage you are in the process. If you're interested in urology, more than happy to chat. Feel free to reach out. Try to keep it short for you guys. Cool.
Thank you so much, Sam. That was great. Do we have any questions for Dr. Washington?
I just wanted to add one thing was that for our prospect program, we had many qualified applicants and only 4 positions. And as a credit to Sam Washington, Yahir, Santiago-Lastra, and Camora, Scotland, I was able to send those names of students that didn't get in the prospect to the integrative research program, and that some of the students were accepted to do their fellowship in California, which just made my heart bubble with joy, because just want you guys to understand that we are trying really hard and that we respect and we love each other, and we're working together to really move the needle for students. So if there's something that I don't have, or if I need a lecturer, I call SIMPA. If I want to be part of Michigan Urology, I call Mady. If I need a place in California, I try to send them to Yahir. So we're really working, putting our life spirit into making opportunities available for students who are truly interested in becoming urologists.
I think the key is that nothing's siloed. It's a network. We all work together, we all talk together. It's not if one, then the other type of thing. Just understand wherever you land across the country, we're trying to build opportunities.
Yes.
Opportunities that cross state lines, cross age groups. So utilize them.
Yes.
You read my mind, Sam. And the other thing I'll add to that too is this is a great example of sponsorship, right? It's like being able to use resources that are available, use power or influence that people have to get you what you need. Any other questions or comments? Okay, so I'll go ahead and play the recorded talk by Dr. Wilson. She would love to be here, but was unable, but she did record a very powerful video that I will go ahead and play.
Hello, everyone. My name is Dr. Shenelle Wilson, and I am the founder and CEO of Urology Unbound, which is a nonprofit organization dedicated to increasing diversity in urology. Some of you may have heard of Urology Unbound, specifically our interest group, the Urology Unbound Interest Group, which is a pipeline program dedicated to underrepresented students in medicine who are pursuing a career in urology. So I wanted to come on today to introduce you to the interest group and also to orient you to the website so you can see all of the things that we have going on at Urology Unbound. So if you're looking to find us, you want to go to urologyunbound.org, and here you'll find more information about the organization, the story behind how the organization was started. But most importantly, you can navigate to this page and sign up for membership. Once you fill out this form and your membership is processed, you'll be able to log in as a student member and access our student member homepage. So this homepage is really the area where you're going to find a lot of the value that Urology Unbound has to offer for medical students. For example, you'll find our medical student timeline, which goes through year by year the different benchmarks that you should aim to reach as you pursue urology in order to make yourself the strongest possible applicant to the field. You'll also find many research resources and our archived videos and webinars from past meetings that still have a lot of great information that you can absorb. For those who are applying into urology, we have a special section meant just for you, and that's the applicant membership page. So here you'll find information about the different programs we offer throughout the application season and interview season, starting with our application polishing program, in which you're paired with a faculty mentor who go through your transcript, help you with your personal statement, review your CV, and in general, give you advice how to approach the interview season. So we also have information here about the mock virtual interview weekend that we host every year that allows you to have back-to-back interview practice with immediate feedback to improve your interview skills. We have many resources on how to approach interview season, how to prepare for it, how to organize yourself, sample personal statements, and more. And of course, we have our application season, interview season specific webinars that we have archived for you on the page. Another area to check out is our research and networking opportunities forums, where we have compiled multiple research opportunities that you might be able to participate in, along with the information on how to go about getting involved. We also have a list of all of the funded diversity and just in general funded sub-internships that we were able to find, that again, you can go through and find information on how to contact the university and program and how to apply. So hopefully I've been able to give you a small preview of what Urology Unbound has to offer. And you can always reach out to us at urologyunbound@gmail.com if you want to get more information. But sign up is free, registration is free, so you can also just go ahead and sign up and get involved with us right away. Thank you all for your attention, and I hope you have a wonderful rest of your day.
All right, they say information is power. So that's, that video is loaded with a lot of information. So do check out, the website. And if you have any questions, feel free to reach out to the contact information that was provided. Any questions from the students about mentorship opportunities? I think we still have Dr. McIntire and Dr. Washington here. All right, if not, I think we have come to the end of the program. So we'd like to use this opportunity to thank all of you students for taking the time to attend this program. Over the last 2 to 3 days with the in-person components and the virtual components, we had more than 100 students that were registered who attended various portions here and there. Hopefully this entire program has been motivating to you. Every time we host this program, I find them inspiring for me. Hopefully you're motivated and determined that you can be a urologist. So please do take advantage of the resources that have been provided, the practical tips and suggestions that were offered by your peers, by residents in our faculty. As mentioned through the various parts of the program, there will be challenges and there might be failures, but that's not to say that you cannot be a urologist. No one should say to you that this is not for you. The only one who gets to decide what you can do and what you will not do is you. So with discipline and dedication, determination, you can do it. You can be a urologist. So we're all here to mentor you. We want you to succeed. Your success really is our success. So we'll send you email addresses like Dr. Go had mentioned. We'd like to hear from you, your progress, your challenges, whatever it is that we can do for you. Let us know because we do want you to succeed. 2 requests that we would like to make. We would like to encourage all of you to fill out the surveys that you'll be receiving in the next week or so. Give us feedback. Feel free to be honest. We already know some things today that worked well and some things that did not work well. Let us know so that you can help us shape and plan next year's program. And here's a request that I'd like to make to all of us. Again, maybe about 100 students have attended this program this year. Think about what you can do. If you were to choose one student from your institution, from your school that you mentor, that's 200, right? Think about how many that will be in 5 years, what the landscape will be in the workforce, and what that landscape will be in 10 years. It will be even much more diverse. So I think all of us have an opportunity to continue to be a mentor. Mentoring and sponsoring is very, very important. I'd like to use this opportunity to thank all of our faculty, residents, fellows who might still be online, all those that have participated in helping this program to be a success, for taking out the time to inspire this great group. I think the future, certainly as Dr. McIntire mentioned, is really bright. Special thanks to Dr. Go, who really is the heavyweight behind this program. Without her, this program would not have been, successful. Really, really, thank you, Dr. Go, for all of your hard work. And Dr. Go, say the last words.
Dr. Salami says, we are here for you. Please reach out. There are resources, and if we don't have it, we probably know someone who does. So we are very open to helping anyone. It does help not to do it the last minute. That would help us out. And I will send out everyone's email that has presented either in person or online, so you can reach out and communicate. And we love hearing back from you guys to tell us, something that worked and something that didn't work. And please fill out our questionnaire so we can help the next year's folks as well. With that, I thank you all for your attention. I know it's been a long day and a half. Thank you.
Dr. Go, I was just wondering if you had a quick minute to chat very quickly. So my name is Narita George. I'm currently an osteopathic medical student at Touro University. I'm a fourth year applying this cycle. I recently have acquired the new role of being director of communications for Euro Residency, the Twitter handle. And I know in this past year it hasn't really been active. I was just wondering if it was okay for me to convey some of the information that I learned through this on this Twitter feed as well, so I can reach out to as many students as possible.
Absolutely. The more people we reach, the better.
And then if possible, I'll go through and email you if it's possible, but if I could get a copy of some of the slides just so I can reference them.
Okay.
As well.
Yep. Absolutely.
Okay, awesome. Thank you so much. I really appreciate it.
Just so you know, this recording will upload it. It'll take a minute for me to do it. But it will be on our website, which is part of the University of Michigan Urology Department website. So feel free to refer to that.
Okay, perfect. Thank you so much. I really appreciate it. This opportunity was amazing, especially as someone DO without a home program. So thank you so much.
You're welcome.
Bye.